parks and lakes are treasures we want to safeguard.
If you do have a cell phone, could you please put it on silence or vibrate, not to disrupt our conversation or others around you. Ledge Council, please take the roll.
Chair Cabral-Guevara.
Here.
Vice Chair Nealon.
Here.
Senator Kieski. Here. Representative Baer.
Here.
Polly Anderson.
Here.
Philip Blair.
Here.
Dr. Justin Bogie.
Here.
Glenn Fung.
Here.
Matthew Harris.
Here.
David Hoffert.
Here.
Dr. Mark Huth.
Here.
Frank Lau.
Here.
Krister Mattson.
Here.
Madeline Neverman. Do we have Julie Pavola online? Okay. Aaron Skold. Here. I think that's everybody.
Thank you very much. We are going to start out today by welcoming Ann Sappenfield, the Ledge Council Director, to provide some opening remarks and a short video regarding the study committee process that we will be working with today and over the next few months. Thank you.
Yeah, thank you. Thank you. Welcome, everyone, to the first meeting. We're really happy to have you here. This is a big committee, so we look forward to the work going forward. Thank you all for volunteering to serve on this committee. Thank you, Senator Cabral-Guevara and Representative Nealon for chairing and vice chairing this committee. It's really an important topic, obviously, and to have a room of experts to think about what the state's role should be in this really dynamic, changing environment and issue that affects everyone. So, every state has interim study committees because every state has a regular session, and then they have what they call an interim. And during the interim, all states have committees that meet during that time to get ready for the next session. But what's unique in Wisconsin is that we do bring citizens who are experts in the field for the issue that we're studying to the table to work alongside the legislators to work on a topic. And I've been with the legislature for over 30 years, and I just think this is such a valuable approach to take to really tackling tough topics like this one. Yes, so I have a video. It's about 12 minutes long, and then I just have a couple things to say afterwards, and then I'll let you get started. I'm Ann Sappenfield, the Director of the Wisconsin Legislative Council staff. Thank you for serving on a Joint Legislative Council Study Committee. The committee was established by the Joint Legislative Council, which is a committee of 22 legislators, 11 from each house. All of the legislative leadership serves on the Joint Legislative Council, along with 10 other members who are discretionary appointments. The Joint Legislative Council was created in law over 70 years ago. The Council has the authority to establish study committees for the purpose of providing information to the legislature. The committees, by statute, consist of legislators and citizens who have special knowledge in the subject assigned to be studied.
I think the thing that I value most about the study committees is the opportunity that you get to get an in-depth look at specific topics.
When an interest group or a legislator wants an idea drafted, usually they start with their own perspective, and then people have to argue to get their idea in. In the Ledge Council study process, I think you begin with a blank sheet of paper, and you hope to craft something that has both sides' input before it even gets to the legislature.
The great thing about the study committee is the ability to engage both as public policy experts and then pulling people from the private sector, so you have those subject matter experts.
Study committees present the opportunity to get in the weeds and get the details flushed out, hopefully get them right.
Real opportunity for the legislature to learn from the public members, as well as spend a little extra time developing some concepts and ideas.
A study committee is an opportunity to bring a group of experts together with policymakers to craft legislative solutions. In the committee, you will hear from other experts in the field and receive background research and information on your committee's topic. The final work product is typically in the form of proposed legislation. Each study committee is staffed by attorneys and analysts from the nonpartisan Legislative Council staff. Please don't hesitate to contact them with questions.
Sometimes when you do public policy, you don't necessarily have the time to go get subject matter experts as much as you should. So this makes sure that the product that comes out is really well done.
So you line up your ducks with the experts in the room. Sometimes that takes hours or months. And that's what a study committee allows experts and legislators to work on together.
You spend a lot of time actually digging in and understanding all the little nuances.
It is so much better to get the details right before you introduce your bill and before the political process takes place.
You really get to get an understanding for the topic. And, you get to hear from different experts.
And the study committee really flushes things out and thinks of all of the different angles and all the counter arguments. And so that work product is really solid.
You know the information that you're getting because of the setting, because of the credentials, is accurate information.
Study committees are established every biennium during the session interim and allow the legislature to take a closer and deeper look at an issue facing the state. The goal of every study committee is to develop recommendations for legislation.
Study committees being done in the summer between sessions is really a time when legislators have more time to delve into something.
I think it's really a perfect way to do it, where you take some of the politics out of it. The media doesn't really focus or obsess on a topic like they do on many things during the political or the policymaking year, because they're focused on the political side. So I think it really lets people who might have differing opinions come together, find some consensus.
It allows a lot more time to dig into those specific subjects, and probably a little bit more detailed of a subject too, where you can really laser focus on something and say, let's dive really deep in on this subject.
The pace of our legislative schedule it's always challenging to work on complex issues.
During a session, there are committee meetings, you're developing your own policy and legislation, and of course, floor sessions that you need to prepare just to see everything else that's coming towards you.
With the study committees, you get to take, ample time to really be able to understand.
Having legislators and citizens work together is great. Legislators have the opportunity to learn from those that are in the trenches, those that are really the policy experts.
I think is why it's so important to have those committees, because you really get that valuable knowledge. You get to learn about that topic.
Every biennium, approximately 30 topics are suggested by legislators for study by a council study committee. The council selects 6 to 10 topics to study. In addition, the Statutory Council Committee, the Special Committee on State-Tribal Relations, meets during the interim to study issues related to American Indians and American Indian tribes and bands in Wisconsin, and to develop specific recommendations and legislative proposals relating to these issues.
I think great topics for study committees are things that maybe we dealt with during the session that we didn't have time to really dig into. There's a lot of ideas that come up towards the end of session that the committees just don't have time to develop. So it's great to have those in the queue, and we can look at those, or subjects that are a lot more detailed, that take a lot more time.
I think back to some of the ones that we've had in the past where we did rural broadband. I think we had one on dealing with the EMT shortage in rural areas. Some of those actually had legislation that went through. Others was good ideas, but they never really came to fruition. So I think those are more the topics where they are complicated policy questions and hopefully not real partisan.
In recent years, the legislature has enacted legislation recommended by the Legislative Council study committees related to police use of body cameras, guardianship of children, problem-solving courts, and tax incremental financing.
We don't know what we don't know. Legislators, there are 1,200, 1,300 bills introduced every session. So we're kind of we're asked to be a mile wide and an inch deep. And private sector, experience-driven folks that come into the study committee help teach legislators that depth of issue area knowledge and expertise.
We aren't the experts. And in most cases, the individuals who are on the study committee have some knowledge of the area that we're studying. And that knowledge is super, super important.
They understand a lot better. The view on the ground is usually a lot different.
Just to have that perspective is extremely important, because you want, to know what people other than, your bubble have to say about the issue, what they're thinking. And so that participation becomes increasingly just valuable information.
Focus in on the feet on the street. What are they saying at the front lines? Because that will just make sure that your product is actually realistic.
Come in with an open mind. Don't, if you are going to sign up and if you are selected to serve, don't come in thinking this committee is going to get my bill passed. Come in to learn and then commit to working on what the committee decides to do.
In general, parliamentary procedure for council study committees is relaxed. Each member has one vote, and each member must vote in person. Once the committee completes its work, the committee chair will present the recommendations to the full Joint Legislative Council at a hearing. Every proposal that receives 12 affirmative votes by the council is introduced as a bill, which then goes through the same process as any other bill in order to be enacted into law. As a member of a study committee, you will be informed of any legislative hearings on bills recommended by your committee so that you may testify to the standing committee if you wish.
Citizens get their ideas, they get to hash out and listen to experts, they bring their testimony forward, smart attorneys draft the bills, and they go to the legislature where they still have to be adopted and again go through the committee process. So it's kind of like a double vetting. I think on some of these topics where they're really challenging to find answers to, the more input we can have, the better, and that's why I think the process works so well.
I really hope that the study committees take time to go through the detail and to really listen to the subject matter experts from the private sector.
Feel that it is a real opportunity to take part in the development of policies for the state of Wisconsin, that it is your opportunity to bring your particular expertise to legislators and get to build confidence and a relationship with them.
Step back and not necessarily come in with your own paradigm of the world, but allow that to be flexible, because I think everyone's going to learn stuff that they didn't necessarily know before.
Read the materials. That's so very important, so you're prepared with whatever questions you may have at the next meeting. You can't just take for granted that everything is going to be covered without there being any questions.
The ones that come from the legislative council process, let's hope that whether we have Republicans or Democrats in control, they're the kind of consensus that maybe we could actually form and move forward.
Politics is challenging, become patient and, still have that passion, but know that it's going to take time.
Thank you again for committing your time and attention.
Just wanted to say to committee members, thank you for taking the time to do this. It's really important. There's some really great subjects that we're going through that are very applicable, and it's really critical that we come out with good product so that the legislature can really figure out, hey, is there a fix to this problem? Because there's some pretty big issues that we're dealing with. So thanks for taking the time. Please invest a lot of your mental energy in this, because it is important. And enjoy the time too.
As someone who has chaired and served on many study committees over the last decade and a half, I really have come to value you as public members that have brought your expertise to the legislature and help us develop good policy. So thank you for your efforts. Thank you for your attention, and thank you very much for being part of this process.
All right, committee members, thank you so much for serving and for taking your time and providing your expertise and passion to the process.
Thank you so very much for your service on these committees. I remember my first committee meeting, and I was super, super excited as a citizen member, and it's something to this day that I have never forgotten. So thank you for your service. It's very much appreciated.
I'd just like to thank the people who have volunteered their time and their talent to be able to help make this legislative committee process work. If you go back and look at the history, you are making a difference, because I can name more than a handful, just in the time that I've been here, of seriously controversial and very complex issues that were solved because of people just like you. So on behalf of the entire legislature and those I get to represent, thank you for taking the time to be part of this process. You're going to make a difference, and you'll be able to see it in the reality of the work that you've done.
Things that you, one thing that you have at your desk is a memo from us on the open meetings law and the public records law, some guidance. This is a governmental body, and so the committee is subject to those laws. We just bring it up because you probably have noticed in the emails that we say, please don't use reply all. That's because in that circumstance, you could get into the territory of making a decision or having a committee conversation sort of behind closed doors by emailing as a group like that. It doesn't mean that you can't call each other and that you can't, talk to each other more informally. It's just anything that gets a group together that's enough to either defeat something or pass something talking about the work of the committee, that really needs to be done in person at our in-person meetings. If you have any questions, and then with the public records law, just we will be the custodian. So if you get a public records request or think you have materials that are a record of the committee, just make sure they get to Margit or Emily, and that, and then if you get a request, just let us know, and we can take care of that. And then the other thing is, at the corners, there are travel vouchers. So please fill those out. I think they're online too. Yes, and so we can reimburse you for any travel expenses and meal expenses you have today. So please go ahead and fill those out and let us know what we owe you. I also just want to say you have, as Ledge Council staff, you have Margit Kelly, who's a principal attorney, and Emily Hicks, who's a senior staff attorney. They're both long tenured staff with us, really excellent. So I know that they can help you with any questions you have, and we'll be working with you through the whole process to make sure that you are able to really understand current law, understand any changes you want to make to current law, and other questions you have. So do not hesitate to contact them. Do not hesitate to contact me. And again, thank you so much. I really appreciate it. Thank you for the time.
Appreciated. I know you have a busy day today also, so thank you very much for coming up and giving us a little bit of a rundown. Thank you. As you've already heard a million people thank everybody for being here today. I know that all of us wear many, many hats, and there's 1,000 places that all of us have to be. I know a lot of people travel the distance to be here today, and over the next other, 6 total, but 5 more meetings that we have. Thank you for giving up your time and helping out Wisconsin, particularly in this important subject. So thank you very much. A little bit more brief in here. We have restrooms, men and women's restrooms just down the hall here. We do have some water and we have some coffee over here if anybody would like that. If there's things that you need assistance with that you need to step out, or we do have staff in the room that can assist with anything that you have questions about. But please understand that this is fairly informal in the aspect that if you need to leave or step out, take a call or so forth, we completely understand. We're going to do a little bit of an intro. And as I say, water, I know there's a few people in here that get hangry. So if they need to step out and get granola bars, they're welcome to do that. Not looking at the lady at the end of the row here, but calling you out there probably. What we're going to do is a little bit of a brief intro for everybody. We'll take 1 or 2 minutes to try to stay on task here. I'm just asking, can you please introduce yourself? Where you're coming from, and then maybe a small bit on how you feel you're going to be able to contribute to our panel. So for instance, my name is Rachel Cabral-Guevara. I am a nurse practitioner. I have been down here in the Capitol for 5.5 years, have had the opportunity to chair the health committee over this last session. It has been absolutely amazing. Outside of the building, as mentioned, I am a nurse practitioner. I also own a clinic up in the Appleton area, and so I'm thinking this committee as a whole needs to be focused on our patients and advocating for our patients when it comes to AI, and looking forward to what everybody's going to contribute to that with an end product. So thank you very much. I think should we start with Ledge Council and then move out? Is that what we want to do?
Take the lead.
Okay, go ahead. Margit.
I'm Margit Kelly. As Ann said, I'm a principal attorney. I've been with Ledge Council for about 16 years. And I staff the Assembly Health Committee, not Senator Rachel's, but and also work on insurance issues and labor and employment and administrative roles.
I'm Emily Hicks. I've been with Ledge Council for 6 years. I'm a senior staff attorney, like Ann said. I don't usually do health. So my specialty areas are education and labor and employment. So I will be learning a lot here.
Thank you very much.
Thank you. I'm State Representative Adam Nealon. I'm a representative in Waukesha County. I've been a representative since 2013. Currently on the Health Committee, among some others in the Assembly. And outside of the building, I'm a partner in a health and fitness company. We do like fitness, personal training, physical therapy, things in that nature. Yeah, I have kind of my foot in the door in both health kind of policy and business. Also have worked on AI legislation, have gone to conferences studying AI. And so, yeah, looking forward to how this conversation shapes out and how I can be helpful.
Thank you. Representative Bear.
Thank you, Madam Chair. State Representative Mike Bear. I represent the far west side of Madison, southwest side, and Verona, town of Middleton and Cross Plains, which has a number of people and companies very much interested in this topic. And I did a lot of health advocacy, health coverage advocacy in my previous life before the legislature, as well as on the county board, and haven't touched health issues as much as a legislator, but certainly maintain that interest and excited to be here. Thank you.
Thank you very much. Senator Kieski.
Hi, I am, thank you. Senator Kieski. I have been in the legislature now for about a year and a half. I represent District 14, which is the totality of 2 counties and 5 other small counties, or parts of. I'm a licensed professional counselor by trade and have been doing that for 27 years. And I'm also on the mental health, substance abuse, prevention, family and children's committees. And so my interest is really in probably the mental health space primarily. In particular, some of the chat features that can be available to clients. So I'm hoping to bring a little bit of that expertise, but also learn a lot along the way. Thank you.
Thank you very much. I think we'll start over here and then just go around the room if that's okay. We'll start out with Miss Polly Anderson.
Hi, I'm Polly Anderson. I am
Mike. Thank you, ma'am. We do have green buttons here. If you press them when you speak and then take them off when you don't, your life will be wonderful.
At least everybody else's.
Everybody else's, yes. Thank you.
I'm an RN, and I've been a nurse for 33 years. My background is in critical care nursing. I've been a school nurse, a public health nurse, and I did a little legal nurse consulting on the side. I currently am a lecturer at UW-Oshkosh and work in the simulation space there, and have done some research in AI in nursing education. And as it is expanding in healthcare, I'm also doing some research as far as that goes. My main concern here is about patient safety, patient outcomes, as it relates to AI infrastructure in healthcare agencies.
Thank you very much.
My name is Philip Blair. I am the Vice President of HR for Gamber Johnson. We're a manufacturer headquartered in Stevens Point, Wisconsin. We are not in the healthcare space specifically, but I do help manage and oversee our self-funded health plan. And what I hope to provide to this group is hopefully be the employer voice in this space. We've done a lot of work within AI within our organization, and specific to the healthcare side, there are a couple of point solutions and other groups that we have talked to help us manage our self-funded health plan, and look forward to providing the input that I've received from those groups, and ultimately hopefully be a good representative of the employees that are members of our self-funded health plan within this body.
Thank you very much.
Good morning. My name is Justin Bogey. I'm an osteopathic physician. I teach at Des Moines University. My areas of specialty are anesthesia and pain medicine. I've also done medical legal work as an expert witness. The military paid for my medical school and a recent healthcare master's from Cornell. And I was talking to Dr. Fung about I'm starting a master's in clinical and healthcare informatics at Madison this fall. So I'm very excited to be on this committee, and hopefully I can lend some standard of care, safety, and maybe bridge engineering and healthcare implementation and governance and translate that.
Thank you very much.
Yeah, good morning. My name is Glenn Fong. I'm responsible for AI and data enterprise on Exact Sciences. Now we're recently acquired, and we are Abbott Cancer Diagnostics as of March of this year. My background, I've been lucky to be in AI for 25 years. So I started my PhD in 1998, and my advisor told me, "Do you know what machine learning is?" in my first meeting. So it kind of fell in my lap, since then, and I see the whole transformation, and since it was an obscure technique in computer sciences until what it is today. I always been in the industry, although at the beginning there was a lot of things to be discovered and papers to be written. So I've been part of the academia as well. I still do. Some of the conference and committee members and stuff like that. And again, I hope that I can help with my expertise on the topics that we want to discuss here today.
Good morning, everyone. Matthew Harris, Chief Digital Information Officer for Rogers Behavioral Health, headquartered out of the southeastern Wisconsin area, but we're across 10 states, so have a pretty national footprint there, which makes this a very interesting topic for us today. Combat veteran by background, Air Force kind of led me here, but I have a lot of healthcare experience over the past 12 years between other southeastern systems as well. My wife is also a nurse practitioner, so I get the clinician feedback at the same time as well as the IT side of it. So really looking to learn a lot from everybody here and offer up any expertise I have around AI governance and just how to really shape policy and build the guardrails to not stifle innovation, but protect our patients' data at the end of the day as well. So thanks.
Good morning, everybody. I'm David Hofford. I'm the Director of AI Policy at Epic, which is a significant vendor of electronic health records. I am a computer scientist by background, and the role I fill is to really be able to understand the technical underpinnings of AI and then translate that into public policy. Very excited to be part of this committee. I think I'll be able to bring knowledge in two primary areas. Epic is developing a lot of different AI functionality for many different constituencies, and so I have some familiarity with what's out there. And also then as part of my role, I pay attention to state legislation all over the country. I've read over 200 state bills this year, much to my own chagrin. And so I have a sense of kind of what's out there and what's been working and not working.
Thank you very much.
Hello, my name is Erin Skold. I am legal counsel with the Mayo Clinic. I've been with Mayo for 18 years now. I advise on clinical, regulatory, and operational issues, including issues related to the deployment of AI technologies in healthcare. I've worked closely with some of our leaders on governance issues and regulatory issues related not just to the deployment of AI technology, but also to the development of AI technology, and that's the perspective I hope to share with this group.
Thank you.
Good morning. My name is Madeline Neverman. I'm a technology director at Elevance Health, but here in Wisconsin, we do business as Anthem Blue Cross Blue Shield. I'm coming in town from Milwaukee. And at my role at Elevance, I lead a team of engineers that works with emerging technologies like AI to help improve our member, patient, and provider experiences. What I hope to bring to the committee today is just transparency how we as a payer use this type of technology. And I look forward to learning from others across the industry as well. So thank you for the opportunity.
Thank you for being here.
Good morning, everyone. My name is Christian Matson. I'm the Vice President of Enterprise Analytics and Data Science for Amplify Health. I've been honored to serve and lead teams of AI and our AI initiatives for Amplify Health, including our governance, ethical use of AI across the board. I've worked in nonprofit healthcare, integrated healthcare systems for the past 25 years and used analytics and technologies and really trying to bring insights to folks and really create better patient care, but also efficiencies within the organization. I think I can help by just providing background of how we are using AI, but also perceptions about AI use across the board, and just excited to be part of this committee.
Thank you.
Good morning, everyone. My name is Frank Lau. I'm really happy to be here. I'm the Senior Director for Digital and AI at UW Health. My background is I have a PhD from UC Berkeley, more on the computer engineering side. So I really sit at the intersection of technology with a technical background and how AI is being used in the provider space. I live here in Madison, and in my role I help oversee and lead a lot of our AI initiatives at UW Health. And I'm hoping to contribute really the perspective of we really try to use AI in a way that's responsible, yet deliberate and thoughtful and proactive. So we think AI can be useful if it's used appropriately and safely. I'm looking forward to contributing. I see some familiar faces and some new ones, so I'm excited. And I'm also looking forward to learning from you all.
Thank you very much. Last but not least, oh, we have one more on Zoom, but in person.
Well, good morning, everyone. It's a pleasure to be with you. My name is Mark Huth. I'm a family physician, and for the past 11 years, I've been president and CEO of Group Health Cooperative of South Central Wisconsin. We're based right here in Madison. We are a staff model HMO, very unique structure where we are both the insurance company and the delivery system all integrated together as one. I'm excited to be on this committee and to learn from all of you. As you can imagine, we are looking at AI, and we are using AI currently for scribing of visit notes and things, but we are very, very interested to see how this can be used to further lessen the administrative burden that is being placed on healthcare staff, and also how it can be used to allow patients opportunities to interact with their healthcare system more effectively and efficiently in such a way that it really drives great value and great outcomes for patients, and also keeps their data safe and make sure that the advice that is being given is solid medical advice that will actually help our patient population. So thank you for inviting me, and I look forward to working with all of you.
Thank you. We have one more folk on Zoom here. Miss Julie, can you hear us?
Yeah, good morning. My name's Julie Puala. I'm a pharmacist by training. I work in pharmacy informatics. I'm interested in this committee and learned about it through the Pharmacy Society of Wisconsin. I am interested in learning about how AI can be used by pharmacists and other healthcare professionals to improve the health of patients in Wisconsin, but also interested in making sure that our patients and the citizens of Wisconsin are protected from this technology. And so thank you for letting me be part of this committee.
Thank you very much for your time today. Okay, gals, we're going to go to Ledge Council here, and they're going to give us a little bit of a briefing here. Go for it.
So we won't talk too long about the staff brief. You all have it. You can read it at your leisure. I did want to just highlight that on page 3, there is a recitation of the scope and the charge of the committee, and that the committee is charged by the Joint Legislative Council in studying current and emerging uses of AI technology in healthcare. I think everybody here is aware of that and knows that. But it was also set up to look very specifically at kind of the 3 main buckets of the patient and the providers and the insurers, and where the technology development fits into that and all of those interactions. And then the end goal is to workshop and consider potential legislation to recommend for the Joint Legislative Council to create any kind of standards on the use of AI in the healthcare services field and in insurance. I will also note that at the end of the staff brief, we included some data which I think not surprisingly shows that it was pretty widespread in usage already. And that's 1 to 2 year old data, so it's already moved way beyond that. And as the committee develops, you'll see other writings from us that will hopefully help the committee kind of walk through some of the ideas and considerations. Feel free to reach out if there are any specific questions.
Thank you. Thank you. So before we start with our first individual here to comment, are there any questions that I can answer before we start? In essence, we'll have people speaking. If there are questions, please raise your hand. Let me know that you have a question. We'll call you on out. This can be maybe at a pause within the presentation or at the end, however that may be. Okay, then we will get started. Thank you very much. The first one that we have up here is a presentation by NCSL. This is Samantha Scotti. She is Associate Director of the Health Programs with the National Conference of State Legislators. And she is going to be giving us a brief overview of legislation overall regarding AI in healthcare. Thank you very much for coming in and educating us today. You're the first one. No pressure, girlfriend.
No pressure at all. Thank you very much, Madam Chair. And thank you to the committee for inviting me to be here today. My name is Samantha Scotti, and I'm Associate Director with the National Conference of State Legislatures, and I direct our healthcare portfolio, and I've been there for 11 years and was previously legislative staff in Colorado. I'm very excited to speak with the committee today. Not too far. And I believe many of you, especially the state legislators and legislative staff in the room, are likely familiar with NCSL, but if you are not, before I dive into today's discussion, I wanted to just let you all know who we are. So the National Conference of State Legislatures, for the legislators and legislative staff in the room, we are your membership organization. We serve all 7,386 state legislators across the U.S. and over 20,000 legislative staff. And we are a bipartisan membership organization, so our members are Republicans, Democrats, Independents, and we as NCSL staff are nonpartisan. So we do not take any position on the legislation that we are presenting on here today. We do not endorse model legislation. We're just really here to provide a lay of the land and show what other states are doing to tee up these discussions that you all will be having. So a quick agenda of what I will be covering today. So I will begin with a very brief background on AI and its growing role, specifically in healthcare. And then I will quickly discuss some federal activity and spend the bulk of time on state legislative activity and share some state examples from across the U.S. And then I will conclude with some NCSL resources that we have on this and leave time for discussion and Q&A at the end. So this slide is really just included as a reference. I will not go through all of these definitions, but it's here to serve as a resource for you all to look back at for a foundation for your discussions. These are some of the common terms that we see in state legislation as different bills are looking at regulating AI. So of course, if questions come up along the way, please feel free to stop me, but I will keep moving so that we can spend the majority of our time again on those state legislative examples. But before we do turn to legislation, I did want to briefly look at why this issue has gained so much attention across the states and from policymakers in recent years. So as you all know, and as has been discussed already, AI is currently being used across the healthcare sector, across the healthcare delivery sector, from administrative tasks like scheduling appointments to processing claims, to functions in clinical settings like drafting after-visit notes or helping with diagnoses. We also see AI accelerating healthcare research, also being used in drug discovery and even in clinical trials. And the number of use cases related to AI in healthcare are continuing to expand quite rapidly. And at the same time, policymakers across the U.S. are considering how to protect patient safety and patient privacy, ensure transparency in the use of AI, and then just generally determine the appropriate level of oversight. So really what we hear from states, what they're grappling with right now is how can they help foster innovation and the innovative uses of AI while protecting consumers and patients. So these opportunities and considerations have really driven this legislative interest in this area, leading to a huge increase in state legislative activity, again, really over the last 2 years. We saw this emerge as a trend in 2024. And then before turning to the states, briefly to examine some recent federal action, and I will not go through all of these actions. They are all linked into the slides here, so if you would like to dive into them more, you are welcome to. But over the last year and a half, we've seen quite a bit of activity out of the executive branch, out of Congress, and then out of different executive agencies setting regulatory actions. So this includes multiple executive orders that address even broader AI topics beyond healthcare, so AI in education, workforce, but some executive orders that do specifically look at healthcare. I will point out most recently in July, so just last month, the administration did release an AI action plan outlining a national strategy that is really intending to strengthen U.S. leadership in AI. And then I will also point to the first executive order on this list, which is the most recent executive order. This was just released in June, and it really aligns with that aforementioned AI action plan by promoting AI innovation, but it also has a focus on cybersecurity protections for critical infrastructures, which specifically includes rural hospitals in that executive order. And given these ongoing implementation efforts and the ongoing activity at the executive level, there is still potential implications for states. And NCSL did recently do a webinar diving into some of these executive orders and implication for states, and so happy to share that resource if you'd like to dig into that a bit more. And then similarly, Congress has continued to examine the issue of AI in health broadly, though progress on a comprehensive piece of federal legislation has been quite limited. Though where we do see some bipartisan action at the congressional level really is on this final bullet here under Congress, really involving privacy, online safety as it relates to children and youth. So now bringing us to the bulk of this presentation, state legislative activity. So this is a map of the 2025 legislative sessions. So last year, we saw states introduce more than 3 times as many bills as they did the previous year in 2024, which is really when I said we started to see this issue emerge. So last year, more than 175 bills were introduced across 37 states, with at least 25 bills enacted, and those are the bills in that kind of seafoam green color here on the map. And then bringing us to the current legislative session, where we've really seen momentum continue, if not somewhat increase. So this year we have tracked more than 285 bills introduced, so about 100 more pieces of legislation. That's across 44 states for introduced legislation. And this, again, is specific to AI and healthcare. This doesn't include all the broad AI bills that we are tracking as well. And so of those, at least 42 of those measures have been enacted across 24 states. So you see the introduced legislation in blue on the map and the enacted in green here. And for anyone interested in diving into these bills more, we do have a publicly facing database that includes all of this health and AI legislation introduced through enacted, as well as broader AI legislation as well. So happy to share that resource. So then bringing us to some of the legislative themes that are emerging across all of these bills that I'm referencing. So of course, state legislation is quite varied, but these are several common themes that we have seen emerge across states. So that's what you'll see here on this slide. So I will briefly go over all of these and then later share some examples related to each. So the first theme includes study committees, task forces, and advisory groups, so established to examine AI-related issues and in some cases provide recommendations to the legislature, so similar to the work of this committee here. So this was particularly relevant in 2024. We saw quite a bit of legislative action, and some of those states that were earlier adopters of study committees and task forces have begun to issue their reports. So just a couple months ago, we saw Washington publicly release their report from their committee, and it does have a number of different recommendations. And Colorado should be releasing theirs soon. But I reference those in case the committee is interested in looking at what some of those other recommendations or committee reports look like. The second category here relates to responsible use, or what is often termed in the field as responsible use. And this really includes bills that address things like algorithmic discrimination and related concerns. The next category involves clinical oversight and practitioner use. So these bills tend to address how AI may be used in patient care, so including how the healthcare provider reviews and uses any AI-generated content in diagnoses or in treatment recommendations, anything that really interacts with the patient. Next, states have also considered patient disclosure requirements, and so these proposals generally require a patient to be informed when AI is either used in their care or even AI is used in the communication of their care as well. And these requirements often often require some sort of disclosure or consent or even the opportunity for the patient to opt out if they so choose. The next emerging category relates to mental health chatbots. So this has been an area of significant legislative interest this year specifically. It's probably where we've seen the most legislative activity in 2026 so far. And so some themes in this area include requirements to disclose that a user is talking to AI, provide crisis resources to the user, and then also precludes the AI from suggesting that they are a licensed mental health professional. And then the final theme here centers on the use of AI in utilization management processes, particularly prior authorization and medical necessity determinations. And then, as I mentioned, there is also a whole host of other bills related to AI that are not specific to healthcare, though they might often affect different AI tools or include the regulation of different AI tools. So now to move into some state examples related to these different themes here, and I will start with examples related to clinical use and oversight. So to highlight some of these bills here, and of course there are many more bills, and I am just going to provide a snippet of these, and if you would like exact bill language or a deeper dive, please let me know, and I'm happy to share that after the meeting. But the Delaware bill here, that prohibits the licensure of an AI-powered agent. So that AI tool cannot be licensed as a health provider and restricts the use of certain medical professional titles by AI. Maine and Nevada, these measures both specifically address the use of AI in behavioral health settings. So Maine allows the use of AI to support functions within behavioral health, but not for direct therapeutic communication with clients. And then Nevada prohibits public schools from using AI to replace a mental health professional in the school. The New Mexico bill here, they enacted legislation directing their Board of Nursing to establish standards for the use of AI in nursing practices. They actually tasked the New Mexico Board of Nursing to create those. And then this Texas bill, that requires healthcare providers to review and then verify the accuracy of AI-generated content being used in treatment or in recommendations before that is then included in the patient's health record. And then finally, this Utah bill is a bit unique because it applies to the Utah Office of Professional Licensure, which is an office unique within Utah that does provide recommendations with healthcare licensure. And they created a process to review and evaluate whether licensed healthcare providers should use new technologies, which could include AI, in the profession's day-to-day practice. And next we have some examples here related to patient disclosure and consent requirements as well. So several of these states have focused on ensuring patients are informed when AI is used in their care. So California and Utah both require disclosure for certain AI-generated communication, though the California disclosure does not apply if that communication has already been reviewed by a healthcare provider. And then the other states here have focused more on the AI-assisted recording and transcription tools. So Louisiana requires verbal disclosure before a recording begins, and Colorado requires written consent before AI may be used to record or transcribe, specifically in therapeutic settings. So then on this slide, I've included 6 examples of enacted legislation related to the use of AI by insurers and in the utilization management process. There are a number of more enacted bills, but here are just 6 examples. So several of these bills specifically address the medical necessity determination. And so, of course, that's when the payer evaluates whether service is appropriate for the patient's need. And so these approaches might differ slightly, and the language does vary across the states, but 5 of these states have placed limits on how AI may be used for certain medical necessity determinations. So Arizona, California, Maryland, Nebraska, and Texas all restrict AI from serving as the sole basis for an adverse decision, so a decision to deny, delay, or modify healthcare services based on medical necessity. And then the California and Maryland, these also require another step within those bills, which is periodic evaluation of those AI tools and outcomes. And then Georgia's framing, the Georgia legislation is slightly different by expressly allowing the use of AI in utilization management and coverage decisions, but prohibiting that AI tool from superseding the human decision. Also not included on the slide, but another emerging trend that we're seeing here, kind of related to the use of AI by payers, is in billing and coding. So we've seen Indiana and Illinois recently enact legislation related to coding practices.
Out of curiosity, do you have a summary of what that entails?
I do know, I can provide that. I know that the Illinois bill specifically references down coding. And then I would have to look at the Indiana bill, but I'd be happy to provide those.
Thank you very much.
And then next, related to AI and Medicaid. So far we've only been able to identify 2 bills that explicitly reference AI in the context of Medicaid. We have Colorado and Indiana. And so first, Colorado prohibits Medicaid from reimbursing for psychotherapy services delivered by AI. And then Indiana allows state agencies, including Medicaid, to use AI software to prepare financial statements and budget predictions. And again, this is just as it relates to state legislation. We do know that a number of executive branch agencies' Medicaid programs are using or considering using AI for different functions, specifically around eligibility or enrollment. And then another area, as I had said, that we've seen significant activity this year specifically involves behavioral health and companion bots. And so those companion bots are those that are used more for a social or conversational function as opposed for a specific purpose or task. And so these requirements, of course, vary, but 3 common themes that we've seen emerge across these bills. So the first requires chatbot developers to identify and respond to suicide risk or mental health crises. Second, limits, again, how those AI tools can represent themselves. So again, they cannot represent themselves as providing licensed mental health services. And then third, we do see a number of additional protections for minors, including safeguards related to chatbot interactions and the content that they may share. And then lastly, here are just some additional legislative examples that don't fit nicely into some of those other themes. I won't review all of them, but I will highlight Utah here, which is kind of an emerging theme that we are seeing. So Utah, through legislation, established an AI sandbox program to allow innovators and regulators to test emerging AI technologies in a controlled environment. And these sandboxes are structured programs that allow the developers of AI to test and deploy these systems for a limited period of time in a controlled environment under regulators' oversight to generate evidence. So Utah is currently testing 3 different healthcare tools in their sandbox. And Utah is one of a handful of states who have created these sandbox environments. So Texas and Delaware and Connecticut have also looked at AI sandboxes. The 3 tools that Utah is testing, so one relates to mental health in schools, one relates to dental health, and the other is an automatic prescription renewal process. So happy to share more about those if you are interested. And as I mentioned, we have a whole host of NCSL resources on this, including databases that track all of this legislation. If you have specific questions about language framing or how another state has approached these issues, please do let us know. That is our bread and butter, and kind of what we are here to share is just other state experiences. So thank you, and I'll turn it back to the chair.
Thank you very much for your time and for your info that you have here. I was just asking Ledge folk here, people are aware that all of this can be found on the website, correct? Everybody has access, no struggles in that area. Okay. I guess questions. Let's start with questions from folks. Otherwise, I do have a couple. Does anybody have any questions for her?
I have one question, Justin Bogey. Creating an AI sandbox, some of the other states have done that. That seems that really helps establish trust because you can figure out resiliency in a new AI healthcare program or system that's going to be used. Is that a difficult process? Is that something that the state of Wisconsin is looking into? Because I really feel like trust is a really big barrier, and everything from data centers to implementing AI and people losing jobs. What's your opinion about that?
So we don't have an opinion explicitly about it, and I can't comment on if Wisconsin is looking at that. And I think really we would have to connect you all to another state to share more in depth around their experience. I do know I can share a bit about kind of what that has looked like in Utah. So as they set up that sandbox, there was legislation. I'm not sure, as far as that stakeholder engagement process to enact that legislation, I can't comment on that. But that it did include a regulatory mitigation agreement with some of those developers. So there is a piece of regulatory oversight that the legislature has been working with and working with the developers So there is quite a big state role. Again, we can't comment on if it's difficult or not for the state, but would be happy to connect you with some folks in that state. The Utah Office of AI Policy is really leading the charge for some of that. So I'm sure we could connect you all with that.
Thank you. So if folks have questions, we'll direct them here. We'll keep a list of everybody, and then we'll call out people as they go. As I'm asking, I am not familiar with a sandbox. I'm hearing from Ledge Council we do not have a sandbox. Maybe that is a direction that we will take as we go on. Write that down with a little star, sandbox possibility. Okay, wonderful. You're already working hard. Thank you very much. Other questions that we have, please direct this way, and then we will ask from there. Representative Nealon.
Thank you. Just curious, I mean, to be frank, and I, start the conversation here, I saw a lot of bad policy up there, and a lot of bad ideas, and a lot of fear, a lot of people scared about what this, and I understand that fear, but I feel like some of it's you got to disclose, but at the same time, the way everything's going with AI, it's like disclosing you're using the internet. Okay, as you're part of your process, how much red tape do we need to give these providers and these businesses? So I'm just curious if there's any states that are pro AI, or if there's any states that are positioning themselves as no, this is okay. We want to create a good thing here, or is it mostly regulation and out of we need to protect the public, we need to. Does that make sense? Is there any states that are leading the charge in a way that's attracting AI through their policy, or is it mostly protective in nature?
I think I'll go through the chair. Thank you, Madam Chair. So great question. I think, as I mentioned in the beginning, we do see states grappling with how do we not stifle innovation, but also protect patients and consumers. Of course, the state examples that we shared is really just what we are tracking, what we are seeing out of states. So if the state introduced legislation, it will be to regulate something. So that is a lot of the examples. Of course, this does not highlight states that might not be regulating. The one thing I will point to is these examples of sandboxes. So that is an example of a state who is looking at potentially lightening some sort of regulation to test a new AI tool. So again, that's Utah, Texas, Delaware, and Connecticut. And so partnering with some AI developers to look at patient safety outcomes and how these tools are being used.
That's a really good answer. Thank you. And I guess you are tracking who's not, because you did show that slide as who's introduced, who's enacted. And we were one of the states that had introduced but not enacted. So we have not regulated in a way. So I guess we're looking at what type of regulations. I think there is an appetite for regulation, but I think we need to be careful too. So just presenting that perspective, but thank you. That was a very good answer.
More questions? So when you point out all these different legislative bits in other states, one thing that I've struggled with a little is, and again, not an expert in AI in any particular way, but did you notice as they were written that they were in a broad form, or were they very specific? So I hear a lot, AI is changing. Are we having, or as we think about where we're going to go with this, is this something we need to focus on? Is this something that we should be looking at as a overview, like a broad or more specific, with the idea that AI is constantly changing from literally day to day? How do you address that?
Really what we see in the states is across the board. So we do see some language that is quite broad, and then some that is very narrow, or more specifically looking at narrow uses of AI within healthcare. But we also do see some bills, Colorado, for example, that are much more broad and just look at kind of how consumers interact with AI, again, more broadly. So it varies quite a bit across the states, and I'd be happy to provide some examples of maybe the broad and the narrow language, if that would be helpful.
Gotcha. Ledge Council, was there any introduction of any sort of medical AI legislation last session at all that you're aware of? Anything in the realm of medical?
Not that I recall. I have to look at the.
It's possible that the introduced bill had something to do with chatbots online potentially, because there was a task force on protecting kids online, but I'm not, that's the only thing I can think of. I don't know if you have the bill number for the Wisconsin.
I do not have it in front of me, but
Okay,
I'd be
we
happy
can-
to work with Ledge Council on that and how it compares to other states.
So it focused specifically, you're saying, on kids in chat boxes? Not sure.
I'm not entirely sure. I just know we had a task force that was focused on protecting kids online, and I don't remember if there was a chatbot piece to that, but that's the best guess I have without taking a closer look.
So can somebody let us, we'll notify that when in email with all of our summary from this. Thank you very much. Other folks, questions for our gal here? Senator Kiewski.
Thank you, Chair. I guess one of my questions is about the definition, because it seems like the definition is different in different states, even different countries. And so defining it seems really important. And maybe even in different ways of defining it in different applications, I'm not sure, but it feels like that is probably something high level that we need to address before we get into maybe more of the specifics. Thoughts about that?
And yes, that is certainly the case across legislation. We see, definitions vary in state. So if there is, maybe a deep dive you'd like us to do of how have different states defined AI in statute, or chatbots or companion bots, or some of these different terms, we'd be happy to show how those compare across states.
We have a little bit of that, but from the staff briefing that we got from the Wisconsin Legislative Council. But again, I'm just throwing it out there. That might be something that we really need to kind of grapple with. Top end before we get into more of the nuances and I guess given the fact that it is always changing, what does that mean as we try to define it?
That's a great point. And I think that's an area that we will be discussing. What do we need to define in statute so that we have at least a pillar or somewhere to start from and to build from there? Put another star on there, okay, sir? Thank you very much.
I wanted to comment on that because I think that's a critical piece of a clear definition, because my understanding, I know there's some experts in AI in this field, AI is not something new. So without a clear definition of what we are defining as AI, if I were to be provided with a requirement to disclose the use of AI, as an employer, physician group, AI is so complex and it's been around for a lot longer than I think many people realize. So a concrete definition is going to be critical to anything we do, because many of these groups, providers, have been using AI for in probably 10 plus years, if not longer, and I'll defer to the experts on that. That's a big piece of what I think we need to focus on. And then I appreciated your question regarding billing and coding. Would love some additional information on that. From the perspective of an employer, a self-funded employer, cost is a big thing. Quality is number one, but cost is a big thing for us. And with any tool, AI, if used for the right reasons, is incredibly powerful, but AI used for the wrong reason could also do just as much damage. So I'm really interested to see what they're talking about from a billing and coding standpoint. Medical billing is incredibly complex, and I think AI can streamline that process. But I also know AI could potentially, you talked about down coding, but up coding is a concern that I would have of utilizing AI as a revenue generation, which further increase the costs for employers and by downstream effect to our employees, which is a big concern.
As I speak with Ledge Council here, they say they will be putting minutes together from this, and then some of these questions or concerns that there will be maybe a link to that too.
I also have an update on the introduced legislation. So there were a few pieces of introduced legislation this last session. I'll just try to go through them quickly. So there was a bill introduced related to prior authorization for coverage of physical therapy that involved AI, and we can get you more of this information in writing. There was also a bill introduced relating to concerns with artificial intelligence systems that simulate human-like relationships with children. There was a bill introduced more broadly about prior authorization and medical necessity determinations made by AI. And then Same thing. Insurer denial claims processes, concerns with audits. So a few pieces of insurance legislation, and then a chatbots and children legislation.
Did any of them pass?
No.
Okay, that's important. Thank you. We had other questions, I'm sorry.
I just wanted to
Mr.
kind of agree that that's very important. Defining, for example, what we're seeing right now in the last, I would say, 7 years is because we got really good at something in an area of AI that is called generative AI. And what it is that we now have the ability to process data and understand the underlying distribution of the data, and that's why we can generate new data that feeds into that distribution, very similar data. And what happened with those models is that they're not deterministic. Especially for medical care, you can ask the same question to a model 10 times, and you can have 5 different answers. That's what is very important to define well, what we're talking about here, because in the past, we have this more deterministic model that will always give you the same answer, right? And I think part of the nuances here is that the new technology is not used well, and we don't have guardrails, and we don't have a human in the loop, can, especially for medical care, can give you many different answers. Again, and I've seen it in practice for medical necessity, for example, when the models are not mature, you can have the same patient with the same rules, same data, and you ask, is it meet medical necessity? It can tell you 5 times yes, 5 times no. So that's one of the nuances here, how we define what AI is.
So you mentioned the defining of AI. Is there a particular legislation that we would be able to get some examples that define AI in all the states that they've already done this, so that we can kind of compare and maybe put together something based off of what they've already established and cut and paste?
Yes, we'd be happy to pull that together to show how, and we can work with you on which terms, so we can look at AI, and then if there are other related terms that you'd like us to look at, how those are defined across the states, we'd be happy to pull that.
Would you be able to do AI and then maybe like the top, 5, 10 terms that you're saying within that legislation, just so that we can have compare and see if we can come up something for our state?
Yeah, we'd be happy to do that.
Other questions? Mr. Hoffert.
Well, just to continue that discussion about definitions, I also think it's important for us at some point to consider why we're picking the definition that we're picking, what it is that we're trying to regulate. I think, so I was very pleased to see in the staff brief the highlight of the OECD definition of AI. I think that does a very good job of capturing this point about what makes AI, as we kind of use it colloquially, different or scary or potentially game-changing is the fact that it behaves differently in different situations. There are some states that I think either intentionally or unintentionally have realized that actually they wanted to regulate software for a long time, and this is their avenue to do so, but they come up with much broader definitions that, that it may be a legitimate policy choice to say I want to regulate software, but they're not regulating AI. They're struggling to figure out what is it about AI that is different and therefore scary. And so I think that's an important framing for us to consider, is what is the concern and therefore what definition matches that concern.
Thank you for your insight. If we have no other questions, then we will move on to our next individual who will be speaking. Thank you very much for your time, and we look forward to that info.
Yes, thank you very much.
Appreciated. Next, we have on Zoom David Stoss, and he's going to be talking about legislation, state AI legislation, and focus obviously on healthcare here. David, are you online? Can we see you?
I am. Can you see me? Okay.
Wonderful. Can we turn this up a little bit? Who's doing audio? Do we have somebody to turn this up? Maybe, Michael? Can you help turn this up? Our audio.
They might be.
We've been abandoned. Oh, she is? Thank you very much. Thought I was abandoned for a moment there. You don't want me trying to figure it out. Okay, so we have Mr. Stoss here. Thank you very much, and whenever you are ready.
Thank you, Chair. Good morning, everyone. My name is David Stoss. I am joining you from Denver, Colorado. This morning, I'm a data privacy and AI attorney. I practice in this state.
Can we hold you for a second so that we can turn the volume up for old people like me?
Yeah.
To be noted, I turned 50 2 days ago, so I'm over the hill now and need it to be louder. I just want to point out that the day after my 50th birthday, my staff put a tour at a senior activity center. Literally not even 24 hours. They told me that the membership was $10 a month. And I was, that was pretty sweet, huh? Too damn smart for me. Yeah. Okay, do we have more noise now?
Still working on it. I'll let you know.
Okay. Okay, thank you. Hang tight with me, please.
All good?
David, can you give us a sound test, please?
Yep. Can you hear me? Any better?
I think that's better. Is that better for Paul?
One more moment. We're going to turn it up a little bit more. Hang on.
Okay.
Mr. David, another mic check, please.
Yes, sir. Can you hear me any better now? Am I any louder?
Oh, yes, we can hear you now. Thank you very much.
Great.
Whenever you're ready,
Thank
thank
you.
you.
And happy belated birthday.
Thank you.
Well, thank you for having me, members of the committee. My name is David Stous. I'm a data privacy and AI attorney from Denver, Colorado. I'm joining you from Denver, Colorado today. Just to touch on my background, I've worked for many years with state lawmakers, primarily in drafting state privacy legislation, both Republicans and Democrats across the country, and more recently working on state AI legislation as well. I do that in a nonpartisan, unpaid manner. I come in and help with the very things you guys were talking about before, which is how do other states do things, how do we define these things, those types of things, with the goal of just making it easier to implement these laws and making them more interoperable across other states, which is always a big concern with state lawmakers, is interoperability. In my private practice, I work with companies of all sizes and shapes that span the gamut of healthcare regulated entities all the way to startup companies, financial institutions, video providers, AI companies, you name it. It's like the companies you do, as well as big box retailers, walk down the streets, like entities that you would know by me. And then personally, I'm also just a heavy user of AI. I am a strong advocate of its benefits. So for me, it's, I don't try to be partisan in this, but I do come from it with a lens of this is transformative. It can be great for society. But there are concerns at the end of the day that other state lawmakers have identified, and I can maybe hopefully tease some of those out. I think when we sort of conceptualized this one as sort of the counterpart to what Samantha at NCSL had just talked with you about, she obviously went and spoke specifically about what was happening more at the federal level. There's been a bunch of bills introduced, nothing has moved. There's a lot of threats to pass legislation, but nothing actually is happening. And there's obviously the Trump executive order. The Biden administration was a lot more pro-regulation, and obviously the Trump administration is the opposite of that. I'm not saying which is better or worse. It's just that's what's happened in the last 2 years. The states have looked to fill the gap of that in many respects, with the Trump administration stepping back from regulation, and the states have looked to step in. It's a very similar story to what we saw with state policy legislation, which is, my core practice group. The federal government has, as you know, has yet to pass a generally applicable state or comprehensive privacy law. We have sector ones like HIPAA and TLPA, and there's always another bill introduced, but there's nothing that's passed. So the states have stepped in, and there's now 23 states that pass state consumer privacy laws. And so a lot of the same lawmakers who have been the ones who have passed those privacy laws have come back and said, okay, I know the story. We'll have to pass AI legislation as well. There's been efforts by the states to work together and have working group committees to do exactly what the things you were talking about before, like have common terms for definitions of AI. That is something that working groups have tried to do already, and it's worth sort of maybe adding that to potential follow-up topics, is maybe talking to some of those state lawmakers who have been part of those efforts to try to do that state AI legislation and cross this bridge, and could be a huge help to you guys. Just following up with some of the comments. But when we thought of the presentation, how could I actually be helpful to you in the way that NCSL was to sort of be the yin to NCSL's yang, was to maybe give you a touch broader understanding of what's going on with the AI legislation across the states, but also with the context that a lot of these laws that are being passed, they will touch healthcare. Maybe not specifically like the ones that Samantha was showing you, but they will touch it because they touch all organizations. So with that, you can see sort of the topics I'll go over today, and maybe I'll just kind of dig in. One thing to note beforehand, my website, we run a state privacy and AI resource center. So it's got links to all these laws. It's got high-level analysis of all the healthcare laws that I'll talk about, and many of the other laws as well. And then we also put out weekly updates. So, as you know, most legislatures are dark right now. State legislatures, that is. But once the legislative sessions pick up, we put weekly updates out to track privacy and AI legislation, and a number of many lawmakers track those weekly updates that we do. Okay, so let me start here. Frontier AI laws. You're going to start somewhere. You might as well start at the top. So what are the frontier AI laws? And I think there's sort of some context here, right, is if you're getting into this area, you're doing research, you're going to Google, and you're saying, tell me about state AI laws, tell me about state AI bills. You may hear it be consistently said that there's things like 1,400 bills introduced last year, or 2,000 bills introduced last year, something like that. And it's like this overwhelming number that you see, and you just think oh, this is state realistic. How can I ever get in to understand what's happening here? How could you ever bring order to the chaos of 2,000 bills? But they're very, very different, right? And they're scoped after different things. So what I've tried to do is really take what are the 2,000 bills and reduce it down to what you would need to know as state lawmakers to actually understand this area of law. So frontier AI laws is where I'll start. And so what is this at the end of the day? This is the Anthropics of the world. This is the OpenAIs of the world. This is the Metas of the world. Those large models that have incredible compute, those are the ones that the state lawmakers have looked to regulate. And there's been, the next slide will show you the states that have done it. It's the goal of this legislation, though, is to create some construct around how these models work. So what are the things that state lawmakers are kind of concerned about? Well, I mean, a good sort of from the headlines example would be just, what was it, 2 weeks ago, where OpenAI was using a sandbox, which came up before. It was its own sandbox, not a state sandbox, but it was using its own sandbox to test a very powerful AI model, a new one that has not been released yet. And the AI model broke out of the sandbox, and it went and it started hacking companies. And so it hacked a company called Hugging Face, which is another AI company. And the risk there with these frontier AI models is like, hey, well, A, that shouldn't happen, right? But if it does happen, somebody should tell somebody, is kind of the concept there. And so the lawmakers have looked at this, and it's a broader law. These are broader laws than just this, but the concept is basically like, hey, before you're releasing models, like, should be safety evaluations done, should be like catastrophic risk, like what if this model's being used in state government or to provide resources as part of the disaster relief, those types of things. Like, we should have some guardrails around those things. And if something goes wrong, somebody should have to tell somebody, right? And again, these laws are really focused on the most powerful AI models that are out there. There's been 4 states that have done it so far. California was the first with SB 53. The legislature passed the bill 2 sessions ago. I guess it's now 3 sessions ago. It was vetoed by Governor Newsom. They came back, they passed it again, and it was signed by Governor Newsom. So it was, just background, right? New York came in, then it did the RAISE Act. The legislature passed the law that was actually a lot stronger in California. And Governor Hochul in New York held it up with chapter amendments, and they reduced it back down to what California is. And then Illinois came in recently and has set the bar a little bit higher with its safety measures on frontier AI models. And in Connecticut, Senator Maroney ran a bill last year, SB 5, that touches on several different issues in AI, and one of them is frontier models as well. Anyway, not exactly the focus of your group, but you'll read about that in the news a lot, so worth kind of talking about it. Transparency laws. These are the ones that get after, and this kind of goes to some of the comments and questions before, like these get after like these models and these uses of AI that are generating, right? And so that is that subset. So you have AI, right? And I loved your conversation earlier. You guys so got to the point so quickly on one of the core issues in this, which is like the definition of AI. What are we trying to regulate, right? And there are, and I heard the conversation about like what have other states done. There is tons of that you can look at how other states defines AI, but at core, and I think David had mentioned the OECD definition, and a lot of folks, state lawmakers, have used the OECD definition because that was used in the EU AI Act, and they've used that as like their core construct of like trying to define what AI is. Because AI can be anything from like predictive text, right? You're on Microsoft Outlook and you are typing and it says what the next 3 words will be, and you just press tab and it, that's AI, right? But it's also Claude. That's, you can use it to vibe code and create websites, and you can use it to do, incredible, I have clients who are using this to, design entire buildings and design, safety systems within buildings, right? There's incredible use cases you can do based upon the computer. Back to these laws, though. So what these laws are getting after, and you see, I think what's kind of interesting in this one is you see Utah, a red state, and you see, obviously you see California and Washington are blue states. Another state that got close to passing one of these laws last year was Arizona, another red state, but it did not get finally done in the legislature. It got caught up in the last minute there. But what these laws are about is like provenance data, right? So this would be, at core, is, okay, you have something, like you have an AI that's generating content. And by content, I mean things like images or text or audio, right? Because not all generations treated the same under these laws. And here it's, okay, well, what went into that, right? What actually created this content at the end of the day? And can I tell when it's been Gen AI created versus not Gen AI created? So if you look at like the California laws, one of the California laws that I have up here is mandates the labeling. So I think that's the one, my screen's partially locked, the one on to the right, top right there. And so that's the idea of watermarking. And the concept there is basically like, I could look at Gen AI content and I could look based upon the metadata and I can tell it's actually in fact generated by AI. You're going to see this more often because this is part of the EU AI Act. And so you're going to see companies like Anthropic just came out this week and they said we're going to add watermarking to images and text that's generated through Claude in their later models that are going to be distributed, and they're going to walk back and put it into their existing models. But this would be like metadata that's contained within the generation that says it's an AI image, right? And this goes into things like deep fakes, but also like content and summaries and all those types of workflows. And then the other piece of it would be like the provenance piece of it, which is, and this is where it came from, right? Like what actually went into this model to build this? This is the categories of information that went into this model to build this, right? Anyway, so a little bit off topic for year one, but these laws are floating around out there. Okay, general AI governance ones. So this was hot to trot 2 years ago. 2 years ago, this was sort of like the big ticket item that state lawmakers were trying to do. Colorado passed SB 205, which is the Colorado AI Act. I'll talk about that more in a second. And then at the same time, Texas passed TRIAGA. And this is primarily and it's interesting too. Like, so Texas is in every other year legislature. So they were out of session this year. It'll be back in session next year, one of the 4 states that are every other year. And they ran something like 20, 25 different AI bills 2 years ago, right? And passed several of those bills. So again, a red state, looking at these issues, and I'll talk about a couple of things they passed. So what TRIAGA did at the end of the day, it primarily focuses on the government's use of AI, but it does have some broad stroke things that private companies need to adhere to. One of them is this concept, and it is one of the first states that did this concept of if you're interacting with AI, then we need to tell you you're interacting with AI. And this would be things like customer service settings. So, there was a commercial that was run a while ago with the woman. She calls up and she says, are you AI? And then the person on the other end of the phone call says, I don't know, are you AI? And she's like, I'm not sure, maybe I am AI, right? And like that's like the prototypical use case for this, which you call customer service, and you don't know whether you're speaking to a human or whether you're speaking to AI, or you're interacting with a chat feature on a website, and you don't know if that's a human on the other end of that or if that's a bot on the other end of that. And so like this law was one of the first, and it's something that I think now, just 2 years removed from that, I think is something that now we see companies do a lot of, where they disclose it's a bot in their chat feature, or they disclose it's AI in call services, customer call services. And it's laws like the Texas TRIAGA that did this. In the healthcare space, it does have a provision that's specific to healthcare, which I put in here, which is an AI system is used in relation to healthcare service or treatment. The provider must make the disclosure not later than the date the service is first provided, unless the service is provided in an emergency. So it's a broad attempt to address this healthcare setting. I'll show you some more specific ones, but it is in fact in TRIAGA in the Texas, the Responsible AI Governance Act. Some of the things that TRIAGA does is broader, like it's much different than the one that passed in Colorado that was eventually repealed and replaced. But it was things like, you can't use AI to infringe constitutional rights. You can't use it to unlawfully discriminate, intentionally unlawfully discriminate, or produce like CSAM material, sexually exploitive material, incite self-harm, those types of things. And I think what's kind of interesting with TRIAGA, right, is remember, at the state level, these things advance very quickly, right? So 3 years ago, you saw Senator Roden in Connecticut introduce SB 3 or SB 2, which was like the AI law that eventually became the Colorado AI Act. And then last year, you saw states jump in and refine attempts to this thing and do industry-specific ones. And that's when Texas did this one. And then this year, you saw states jump in and even refine what Texas was doing as well, and even go deeper into the weeds of like specific use cases. So it's been this multi-year evolution where state lawmakers have kind of leveraged the work of other state lawmakers and to like further and further refine and address what they see as the first cars of AI. Employment laws, let's change topics and talk about this right now, this piece. I think this is like what people intuitively understand, right? Which is, and if anyone's gone through a job application process or have had, a loved one go through a job application process recently, then this is probably something you know already. And these would be things like resume screening devices, right? So AI is being used, and automated decision-making technology is being used to do resume screening, to score, to score people based upon what's on their resume, or to do interviews, to score people and based on interviews. This is very prevalent. I have numerous clients that we deal with this issue. It's very prevalent, like staffing companies, those types of things. And so what the state lawmakers have looked to do in this space is they've said things like, at a baseline, so Connecticut SB5, that's a bill that just passed this year, became law, you got to tell them, right? So the concept there is you're going to use AI in that application process. You've got to tell people that you're using AI. This would be the prototypical example where, like, you apply for a job at Sunday at 4 o'clock and you get rejected at 4:05, right? Because the AI has just rejected it and no human has actually looked at the resume, because it's just based upon, green light, red light types of analysis, just traditional like ADMT type rules. The California ADMT regulations, so that's the CCPA, the California Consumer Privacy Act, and that has expanded into AI through recent rulemaking. And so there you would have to provide a notice, but you would also have to provide, in certain circumstances, like a right to appeal to get to a human, right? Like, okay, can I have a human look at my resume? And it's much broader than employment. It also affects healthcare. The CCPA does. But the concept there is basically not just a notice, but also having some sort of consumer rights behind it. Can I look at the data that you used to reject my resume? Can I look at the methodology that you used to reject my resume? So like this right to request ADMT is what California created. And again, it's in the employment space, financial lending, healthcare, and so it's one of those areas in which California is trying to advance the ball. New York Local Law 144, it's been on the books for many, many years. It only applies in New York City. It's a local ordinance just in New York City. But there is, if you have basically a resume screening device that's deciding, who gets jobs, who doesn't get jobs, those types of things, it has to be like that level of specificity. Then you've got to be providing people a notice and opt out. And you've also got to be doing bias audits. So that would be, taking the AI and making sure that it doesn't unlawfully discriminate against certain types of characteristics protected under federal and state laws. Generally applicable, if these apply, they would apply to healthcare companies and their hiring, as well as any other company in their hiring. And just a few more here I've got just for just interest. I mean, some of these have been on the books for a long period of time. The Illinois AI Video Act, that's basically like using AI to interview people. Maryland, I think, is the facial recognition one, like use facial recognition, like making people use facial recognition in employment settings. Illinois, a couple of years ago, also amended their Human Rights Act to provide that if you're using AI for purposes of employment, that you got to provide the disclosure. And just to touch broader, it's not just in the hiring phase. A lot of these laws also will talk on like the promotion or the compensation phase as well. Colorado is going to be, if you're embarking on this journey, I'm here in Colorado. I'll tell you, Colorado is going to be something that you're not going to be able to avoid as far as like what happened in Colorado in the last 2 years. So Colorado, I guess it's maybe three years ago, its time is eluding me right now, passed SB 205, what became known as the Colorado AI Act. What that required was basically like, hey, if you're going to deploy an AI system, a high-risk AI system, so something that's going to deal with healthcare, something that's going to deal with financial lending, something that's going to deal with education or employment, if you're going to deploy that in the state, again, in the involves healthcare, so relevant here, then you're going to have to do certain things, right? A, you've got a duty of care to make sure that that AI system, that high-risk AI system, doesn't discriminate against people. So you want to make sure about federal and state protected classifications, race, gender, religion, those types of things are protected. You're going to do that. You have a duty of care, and you're going to be required to have a risk management program put in place. And that risk management program is going to basically say you're going to have people involved in the company who are going to actually have to ensure that this is happening and these checks and balances are happening. You have to do an impact assessment. So the impact assessment would be analyzing it, making sure that the high-risk AI system is not going to discriminate, that it's going to work for its intended purposes, those types of things. And then you have to tell people that you're using the AI. You have to provide people with certain rights around the AI. So that'd be like the right to opt out or the right to appeal. So you got an adverse outcome, you would have the right to appeal that. And again, so this was intended to apply with SB 205, was intended to apply to all these high-risk consequential decision-making, the things that you would care about in your life, things like financial lending, healthcare, access to healthcare services, education, employment, those types of things. It passed and became law. It was signed by Governor Polis, and it was immediately objected to by industry advocates. It was a 2-year process to basically get it repealed and replaced. In the interim, that's just part of the story, right? In the interim, we had a change in president of the United States. Obviously, the Democrat President Biden was much more. I mean, there was like an AI Bill of Rights, right? That was the White House. Trump comes in. It's a much more obviously it's a pro innovation approach to he repeals Biden's AI Bill of Rights, or repeals whatever the executive order is, he removes it or something like that. And then he takes much more of a pro innovation approach, and he charges the Department of Justice with forming a committee. And the Department of Justice is intended to look at any onerous, is the word they used, state AI laws. And if there is an onerous state AI law, the Department of Justice was supposed to consider suing the states over the onerous AI laws. And also they threatened defunding and said that if the laws are not repealed or replaced or just repealed, then they would use defunding and remove defunding from the states. So there was a lot of pressure on Colorado at that point in time to do something. There was business pressure on Colorado. There was federal pressure on Colorado. And so they did. They formed a work group, much like you guys have had those with business advocates and AI advocates and civil society advocates and state lawmakers. And they put together what became is SB 189, and that was passed this past year, and it will become law January 1st, 2027. It's a much narrower bill. I would say if you're looking for a definition of AI or EDMC, which is maybe something that you guys consider is like, depending on where you go with this, it may not be that you're trying to regulate AI, it may be that you're trying to regulate automated decision-making technology, and that's an important distinction there. AI is like the entire field of stuff. Automated decision-making technology is you're just trying to regulate decision-making, but that'll really depend on the scope of let's go. So it applies in some of the same circumstances, things like healthcare, it kind of applies, education, it kind of applies, financial lending, it applies more, and employment, it really applies, that's kind of like a hard core where it applies. So you have to provide a pre-use notice, we're gonna use AI, some basic information about how you're gonna use the AI, and then if there's an adverse outcome, you're denied the job, you didn't get the funding, like those types of things, that adverse outcomes, and you have to provide a notice within 30 days. You have to provide a notice, and then in certain circumstances, there's certain rights, like the right to access the data that was used, the right to correct the data that was used. Hey, you denied Dave Stales a loan, but you had the wrong Dave Stales, right? So like I should be able to correct that, and you should be able to run it again and give you the loan that I should be able to get. And that's it. I mean, they got rid of the care, they got rid of the risk assessments, they got rid of the impact assessments, they basically just made it disclosure, limited rights. It goes into effect in January. There's currently the Colorado Attorney General's office is currently rulemaking. Draft rules came out 2 days ago. That they're really struggling with, the issue that they're really struggling with is the role of the AI, which is also something you're going to have to think about. It's not just the definition of the AI, but it's the role of the AI. And by that, what I mean is you have the AI and you have a human, right? And so is the human using the AI to accomplish a goal, or is the AI acting independent of the human to accomplish that goal, right? And so that's a central issue that the previous lawmakers have looked at and regulators have looked at. And in Colorado, what they came up with is this concept that the AI is materially influencing the decision, right? And so what that basically means, and trying to figure out what that means, it's kind of reality, is the statute says it's a non-de minimis factor in making the decision. Connecticut, when it did its AI employment law SB 5 this year, it used the word substantial factor, or the phrase substantial factor. So defining that role of like the human versus the AI is something that you guys may approach, and there's a lot of prior precedent here which you could draw from. And states are, I think, trying to align around those issues. Healthcare. I mentioned before that this 189 does in fact healthcare. I haven't wasted 5 minutes of your time explaining how well it does completely apply to the committee. So it's basically like, okay, fine, you're a HIPAA covered entity. But remember, healthcare is not all just HIPAA, right? So your Fitbit you're wearing, your Garmin you're wearing, or health tracker apps that you have, those are healthcare. And they're not necessarily HIPAA covered entities, or HIPAA regulated entities. Right? So like healthcare can be broad. And so they said, though, hey, if you're a HIPAA-covered entity, there's going to be a broad exception, except you're going to have to provide something. The notice requirement of financial assistance, disclosure, and protect HR, right? But still, they're subject to the employer. So, HIPAA-covered entities still, in their role as employer, they're still going to have to comply with SB 189 in their role as employer, the use notice, the adverse outcome notice, those types of things. But they carved out HIPAA-covered entities specifically. But again, there's so much healthcare adjacent things right now that there's still a ton of healthcare information that healthcare companies can decide to this in the United States. Chatbot laws, NCSL really hit on a bunch of these issues. Maybe I can explain why, but maybe it's helpful to explain why this happened. Because we went from one chatbot law, California. Well, I should say. Let me clarify. There's chatbot laws and there's companion chatbot laws, right? So chatbot laws are things like you're interacting on your computer with a company, and it's got the help button on the lower right-hand corner of the website, and it's like a customer service chat, right? Hey, I want to order this product or order that product, those types of things, right? This help, those help, right? It's a chat feature. So what that's doing is that's going back to a knowledge base, and it's that the company's developed, and it's competing against that knowledge base and it's trying to answer questions, right? That's one level of chat feature. And we've had laws in place. California's had laws in place, and New Jersey's had laws in place for years along those issues. You got to tell people it's not a feature. What happened in the past 2 years is, maybe you guys just know this, but anecdotally, this is when it sort of hit. It hit for me 2 ways. One is I went to a conference, and the keynote speaker said he was speaking to a bunch of students, high school students. And he asked the high school students, he said, by show of hands, how many of you guys have an AI friend? And he said a third of the high school students raised their hand that they had an AI friend, right? And then I was watching local news, and they were talking about the Colorado bill that Samantha had mentioned before. I think it was 1189. And so I was watching local news in the morning, 9 News, Denver broadcast, and they started talking about regulating mental health chatbots. And of the 4 people that were the newscasters, 3 of them were using mental health chatbots, right, in their daily lives, right, interacting with mental health chatbots. So lawmakers saw this 2 years ago, and a group of lawmakers got together and said, hey, what are the things that we should actually be looking to regulate, right? And this idea of regulating AI where it's acting as your best friend, as your boyfriend, as your girlfriend, right? And these things exist. I had no idea these existed, 18 months ago, but these things really exist. And to regulate those, and they also were looking at the headlines, and the headlines had things like the Florida teen who's told to come home by a chatbot feature and committed suicide, right? He thought the chatbot feature was his girlfriend. It was, a Game of Thrones character, that impersonation. And it really gets those, and what it really gets to a core is it gets to I tell people it's not an AI issue, it's a parent issue, right? You're a parent, your kids are in a room, you have no idea what's going on, and you think, what the heck just happened? Who did what? Some company is forming a best friend or girlfriend for my 16-year-old. And those are the issues what state lawmakers really came back to the State House this past year and said, these are the bills that we need to start passing. And so you see the larger category of chatbots, but understand it's chat features on websites, it's companion chatbots that are your boyfriend, your girlfriend, your best friend, and it's mental health chatbots as well, where it is acting as your mental health provider and giving you behavioral health advice. I don't know, is there a comfort level that, the chat feature is going to tell you things that it's supposed to tell you in a behavioral health setting? That's really the issue here. So what do they require? They require things like disclosures, I am AI. So when you initially interact with it, I am AI, and then on some sort of cadence, some time frame, every hour, every 3 hours, every day, reminding the person that I am in fact AI, having pop-ups on it. Minor safety is a big issue, right? If your chat feature is dealing with minors, then you've got to have a heightened risk of harm. And there's also mental health guardrails, and this is where it comes into the committee, is what if somebody starts expressing suicidal ideations with the chat feature? I want to harm myself, right? I have unwell thoughts. I want to harm other people, right? Which has been something that's been in the news as well a bunch, right? Then it has to be, okay, how should the chat feature react in that instance at that point in time? And the lawmakers have looked at it and said, like, well, you've got to do certain things. You've got to alert authorities with one of the things, provide direction to mental health services and those types of things. And prior rights of action. Oregon, California, and Washington have passed laws that have prior rights of action associated with this. That say, like, if you harm people, if you release a chat feature into the world and that chat feature harms people, then you're on the hook. And it's just not a matter of the Attorney General investigating. It's a matter of, private litigants can approach you. And then, the crisis protocols, that was kind of what into the mental health guardrails I was talking about before. So what I'd say is, like, this is kind of ubiquitous, approaching these things, these chat features. And it might be, I know you guys have a large charge, large scope, and that, maybe you'll just be provider-based laws and those types of things that you'll be looking to, their bills that you'll be looking to run. But this has been one where it's really been like red state, blue state. Lawmakers across the aisle have looked at this and said, yeah, wait a second. Like, we really can't have chat features doing these things, right? And so a lot of them have passed, and you will find definitions in these laws around companion chatbot. What is that? And that's a definition that really matters, because you want to distinguish like customer service chat features versus like, boyfriend, girlfriend type chat features. So you see, I've got these ones here, and then there's a second page of laws as well that are here. And like, again, you've got, red states, blue states, more blue than red, to be honest with you. But like, there's been, a growing chorus of this, and there's a lot of alignment around this issue. Pricing algorithm laws, I'll just hit this briefly because it's really kind of adjacent, but you'll see these and it's in the news. What is the issue that people are worried about? If you've read an article recently about like airlines that are, somebody dies in your family. You go online, you start Googling reverment, like, hey, what airlines, reduce prices for emergency situations when I've got to fly because of a funeral, right? And then the airlines have your search history, and they're using that to set a higher price for you, not a lower price for you, right? And like this, this is not me saying, like, you can Google it, like, airlines are using pricing algorithms to like change the prices, and they're using search history to change the prices as well. And this has like this ick factor, right? Where you're like, yeah, that really shouldn't be happening, right? That feels like you're taking advantage of me at the end of the day. And so states have tried to address that. A few. This is a really difficult area to legislate. Probably not one, to enter for lighthearted, because it does get into like, the use of personal data for pricing and how that works with like loyalty programs. So like, if you like Starbucks loyalty program, like they're using your data, they're giving you discounts, doing all those things, and people love their loyalty programs, so you don't want to mess with the loyalty programs. So states have kind of looked at like disclosure laws, like Connecticut and New York have said, well, let's do this disclosure. Yeah, we're using this, your personal data to set a price and just disclose that to people. They can go someplace else to a different provider. Maryland and New Jersey have like limited it to like grocery stores that are changing the price. Like the idea would be like to have, like if you have electronic labels in grocery stores and there's a hurricane coming, probably not for you guys, relevant hurricane, but there's there's some sort of natural event coming, and they're changing the prices on the electronic labels to jack up the price of milk or bread. Like those types of things are trying to get after those activities. There are two bills that are pending right now. There's a New York bill that passed the legislature, and it's on Governor Hochul's desk. We will not know what happens until the end of the year. New York session runs until June, and then the governor can call the bills later. So the governor just has to call the bills until the end of the year. So it's a really interesting process where the governor will wait until December to call those bills. And there's literally like 5 or 6 AI bills sitting with Governor Hochul right now. And we won't know until she passes them until December. And there's also chapter amendments in New York. So legislature can pass a bill, and then they will negotiate with the governor. And the governor can sign the bill or veto it, or she can do chapter amendments. And chapter amendments are basically like they rewrite the bill, but you won't, and then they'll pass it in the first week of the legislative session, first couple weeks of the next legislative session. So it's a really interesting process. So anyway, so New York has one, and California has one in the legislature right now. That would be a broader one that would really regulate pricing algorithms and really like sort of, say what you can and cannot do in that setting. Okay, just other AI laws, just to kind of round it out. Arkansas, HB 1876, one of my favorite ones. It's just favorite. I say that sort of like sarcastically in the sense that like generative AI input providers own the output is the concept there. again, that goes back to like the idea of like these are like the intellectual property issues that are associated with like scraping issues, those types of things. Connecticut will skip that one. The real estate laws that really just tangential to you guys, but that would be basically like you're putting up an AI image of a house that's for sale, and you've doctored the images using AI, right? So somebody drives. Here's a real, right from the headline. Somebody drives 3 hours to go see a house, and they show up and they're looking at the Zillow pictures and they're looking at the house, and it's just completely different, right? Because they've used AI to doctor the photos. So a couple states have tried to address that. And then the New York synthetic performance disclosure one, really interesting one, which is basically like if you're using AI images of humans in advertisements, you got to tell people that it's AI, it's not a real human. That just went into effect in June. I suspect you'll probably just in real life start seeing those disclosures on the websites and stuff like that. Other categories lawmakers have done before I get to the healthcare stuff is CSAM, child sexual abuse material, big topic. When you see like those articles that talk about like the 1,000 AI bills that have been introduced, a lot of them are saying things like this one, right? Like deep fakes, like in particular, like political deep fakes, CSAM issues, those types of ones. Again, like those are the ones that like have bipartisan support, and really what they're looking at, the decision points there are the First Amendment issues versus like the regulation of the industry. Government uses of AI, red state, blue state. I mean, governments have, like Kentucky passed one that has basically, if the government's going to use AI, then the government's going to have to do some things, and they're going to have to, like in the healthcare setting as well, to make sure that like they're responsibly deploying AI, they're vetting vendors. You don't want to have an AI vendor being used by the state government that can't, that discriminates basically. Education, ton of use cases in education, and then Name, Image, and Likeness Act. So this Tennessee did it. They called it the Elvis Act. Was the first one, and this is the concept that like you can't just decide that you're going to have Taylor Swift be your spokesperson because you can use AI to make Taylor Swift your spokesperson. There's a name, image, and likeness, right? She has the right to use her name, image, and likeness. Okay, so with all that, let me get you to the healthcare stuff. NCSL mentioned a few of these, so I don't want to dig too deep into every single one, but I do want to give you like here's also like taking a step back at the healthcare space. It is completely irregular, right? It is, states are all over the place. It depends upon the exact harm that they're trying to address. It depends upon the definitions. There's states like California that have this healthcare law right now, but they're running a number of other bills, and their legislature doesn't close until August 31st. So we quite won't know. But it's basic things like interaction, like if a patient's interacting directly with AI, one use case. If I'm using AI to generate content, patient communications, another use case. If I'm using a chat feature in a behavioral health setting, right, another use case. If I am using AI to provide the services, right, another use case. What's the role of the human versus the role of the AI, right? Is the AI reviewing the patient file and then coming up with recommendations or treatment, those types of things. And there's also the use cases Samantha talked a little bit about before, which are like the authorization of use, the insurance issues, those types of things. I'm not going to focus on the insurance issues, I'm going to focus on the other stuff. So California basic law is what I would call, right? It's a two-page bill, two-page law. And what it basically is like, hey, if you're using AI to create patient communications, you've got to tell people. You got to make a disclosure and tell people this communication was generated with AI, except if you have a human review it, right? So this could be, one of the use cases I use in my practice all the time will be things like I write something and I will say, okay, Claude, fix all the typos, right? And it'll put it in there, it'll fix all the typos. And then like I've created it and I've reviewed it, but AI assisted with it. And here, like it would not require disclosure. I'm not a healthcare provider, but it wouldn't require disclosure in that instance because human has reviewed it. So the role of the human, I talked about that before, not just definition of AI, but the role of the human becomes incredibly important. Colorado psychotherapy, Samantha talked about this previously, prohibited, you can't use AI to provide direct or guide psychotherapy without real-time professional supervision. This is another concept as well, too, you'll see that leads through the walls, which is like, AI should in no instance be representing itself as actually being licensed professional, right? Qualified to do these things. Like that's been a kind of like an easy one for states to pass, which is just like, hey, we have a licensing board and that licensing board gets to decide who can practice healthcare in this state, and AI cannot do something that a human cannot do, right? I mean, you couldn't have a human decide that they're going to become, just say they're a licensed professional, so AI should not be able to do that, right? And so here you get this prohibited, like we don't want AI to do certain things, but, and I think this is an important distinction as you're looking at this, is AI can do administrative tasks, right? And so they say things like, okay, you cannot have AI, you can't just press the easy button and have AI to all of your behavioral health services, right? But you can still use it administratively in the running of your practice. And that's a distinction you see in Illinois as well, which I'll show you in a second. I'll show it to you now. So again, prohibited AI, you can't use it with therapy. You can't use AI to basically replace the clinical professional in this instance. But what you can do is you can use AI to handle administrative support tasks, right? So drawing that clear distinction between what can and cannot happen. So Illinois did this law 2 years ago. I think it was the first one actually do a similar law. Louisiana did one this year. I think it's a one paragraph law. I can look back at it, but it's pretty clean, pretty easy one. And that's basically like AI transcribing. So this is a great use case. I mean, like for medical professionals, they've done the research and it's something crazy, like the amount of hours that you can save medical health professionals just trying to like take notes and using AI transcription services to do that for you. Like, products like Whisper, right? It's just like you put it in the room, you put a recording device in there, it listens to the conversations, take notes, and it summarizes those that the healthcare provider can then review. It's a wonderful use case. It can save, hundreds of hours each year by a healthcare provider. So Louisiana, when they looked at this originally, when the bill was originally introduced in the state, it said you needed consent to do that, right? It was going to be, you needed the patient to actually consent to having the AI transcribe the communication. Where it landed, the final bill that was done, was that it just requires you to disclose to the individual that it's being transcribed by AI. So not consent by the patient, it was just that you have to disclose, doctor walks into the office, hey, I'm going to use this AI note taker to listen to our conversation, create a summary. I've actually, in real life, I've seen this like disclosure being made anyway in healthcare providers. Like you go to the healthcare provider and they have like an AI disclosure anyway. But this is one way that I think that one of the issues came up before about like light touch versus hard touch. This is one I think was like a really directed light touch approach to regulation. Mental health AI, this goes back to what I was saying before, right? Like if you're going to have AI interact in this mental health setting, it cannot represent itself to be a licensed professional, period. Nevada, again, you got this two-part approach, right? Which is mental health, first of all, and I think Frank talked about this before, so I'll just go briefly. Can't represent itself to be a provider, but AI can do administrative tasks, right? And so again, you see this with Illinois, you saw this with Colorado. It's a fairly consistent theme that we're seeing in the states. Rhode Island, so Rhode Island passed 2 bills this past year. This is the patient notification one. So again, providers using AI for visit documentation must notify patients. Again, this is kind of similar to what that Louisiana one was, right? If you're using AI, you gotta tell people. And then also like, hey, if you're using AI to like create summaries, if you're using AI to like help generate like treatment plans and those types of things, the human has to prove that. It can't just be the AI is actually the one doing it. The role of the human, right? The role of the human needs to be the AI. And then the other Rhode Island one that passed the mental health AI law. So again, I feel like this is kind of redundant, but you can hopefully sense themes as I'm going through these. Prohibited the AI can't provide therapy, make independent decisions, determine treatment plans. And then, there's got to be consent, there's going to be emotional treatment involved there. So these guardrails, like these, like I think, these state lawmakers are looking at it and just saying these are go or no-go situations. Tennessee, I think I've copied and pasted most of the entire law there with Tennessee. So a person who develops and deploys an AI system in Tennessee may not advertise or represent to the public that the system is or is able to act as a qualified mental health professional. Mental health professional is directed at that one. But again, like you're basically saying, again, you're saying like, AI cannot act as a mental health professional. And I should say too, like we see this in the wild. Like this is not something that like isn't happening. Like we see companies that are providing exactly these types of services, and that's why these these laws are happening. So red state is run by Republican lawmakers looking at it and saying, like, we don't want this happening in our state. Texas AI and healthcare records just called that out by NCSL as well. So you can use AI for diagnostic purposes, subject to 4 conditions. It's got to comply with the law clearly. It's got to be within your scope of authorization to practice. You have to review the output, and you got to tell patients, right? So this is, again, this concept of, like, you can use it, but you've got to use it responsibly, right? You can use it under these circumstances. It's not a no, it's a use it. And I think a lot of this stuff is kind of logical, right? It's Texas, right? I mean, it's not going to be something that's heavily burdensome on companies, but it's things like, you know, it's got to be, you're the licensed professional, you're using it for scope of your practice, and you're reviewing everything at the end of the day before it goes out and tell your patients. Utah has this mental health chatbot law. I talked about mental health chatbots a ton before, so we'll talk about it a ton, except that Utah went a touch further here. And so this would be, you can't sell health information. And again, remember, this is not just HIPAA. This is not just patient-doctor type settings. This is things like, you know, healthcare broad sense, right? Healthcare covers a lot more topics. So you can't sell the information, and it also regulates how you can use people's health information to advertise to them as well. So kind of creating some guardrails around, like, how, like, and I would say, like, this one's even, like, with the chatbot law, like, this just feels like more like a data privacy law to me than it even feels like necessarily a chatbot law to me, or the AI law, I should say. And then, you know, Vermont, they just passed this past year. Again, prohibited. You can't use it to say it's a licensed professional, but permitted. Yeah, you can use it within your practice to do, like, administrative tasks. These laws, I mean, if you're sitting here thinking, like, this guy just always talking about his administrative tasks, like, these laws actually do in fact define administrative tasks. So if you're going down that path, like, that would be something to pull from and to look at, like, those definitions of administrative tasks. Okay, AI and health insurance. This was talked about before. Yeah, so I won't really go into it. I think a bunch of these laws were surfaced for you guys last time, but this is a whole area of law, right? Like, you know, the way I always say it, this one, I try to explain it, like, just in a colloquial kind of way, is like, your mom's 75 years old. She's, you know, not in great health. She needs a hip replacement, right? Do you want the insurance company using AI to make that decision, or do you want to talk to a human being to make that decision, right? And so, like, that's kind of the tug of war that I think lawmakers are coming up with right now, which is like, I don't know, my mom at 75 with bad health probably doesn't look like the best use case for spending the money than the 45-year-old in good health type stuff. But, like, I really love my mom, and I want her to have that surgery, and I should have, like, a human being to talk to and reason with. So that's kind of the concept, the core here with these. Again, so just kind of like, if I'm in your setting, I'm thinking, like, okay, what are the concepts at the end of the day that their state lawmakers should wrestle with? You know, Dave put me on second base, Dave, instead of home plate with this presentation. Tell me I can kind of jump to the front of the line here and leverage what all other state lawmakers have done. Disclosures, right? Like, that's something people have focused on, like, telling people it's AI, right? Should not be a heavy lift for companies. It's not a heavy lift for companies, and it's something that can, you know, that other states have looked at. Mental health guardrails, you clearly see that coming through the bills. You clearly see that lawmakers are concerned about, you know, chat features interacting with mental health, but also, like, the use of AI just in general with mental health. The definitional complexity, man, you guys stole my thunder on this one, on the last one, talking about the definitions of AI, but, like, you know, that's really what it is. I mean, like, it's really tough to define things like, what is AI? Am I trying to get after, like, broad AI? Am I trying to just get after generative AI? What exactly is it that I'm concerned about at the end of the day? Minor protections, so you see that as, like, a subcategory, so it's not just, you know, the large category chat features interacting, it's minor protection. Prior rights of action, it's been easier for states to pass laws in this context with the prior right of action than it has been in privacy. We have several of them already. There might be some buyer's remorse from some of the business advocates, frankly, in some states like California, Oregon, and Washington. We'll see about allowing for prior right of action to go through, but it's been interesting, just anecdotally, it's been interesting if PRAs have been much more capable here of passing. And then it was mentioned before, right? The rapid evolution is, you know, how do we pass something where the use cases, and I'm using AI, you know, in a lot of different circumstances, a lot of different ways this year than I was last year. And so how, you know, the models are improving, it's a race, but they can do incredibly wonderful things. So how do we write laws that actually are going to be by the time they go into effect, they're not going to be outdated already. So state lawmakers have got to really struggle with that. So that's it. That's my song and dance for you guys. They asked me to keep some time available to answer questions. I know I'm the last thing before lunch as well, so I won't be insulted if everyone's hungry, but also happy to answer any questions and be useful if I can.
Thank you very much for your information here. We are going to see if we have some questions because I always have questions. So if folks don't, I will throw a bunch at you. Okay, let's start with our guests first, shall we? Guests first. What do we have from folks? Ms. Skold? Skold, thank you.
Yes, I'm wondering, as we hear more about these chatbots and a potential provision of mental health services, have we seen any feedback from the FDA, or has the FDA looked at these tools at all as potential software as a medical device if they're providing diagnosis and treatment? Does it fall under the FDA's jurisdiction, or I should say, has the FDA asserted that it falls under their jurisdiction and tried to regulate?
Or who regulates it, in essence, is what you're asking?
Is there efforts at a different level other than the state level to also try to regulate that type of tool?
Gotcha. We'll start with our guest up here, Mr.
Madam Chair, thank you. I cannot recall. I can't recall seeing anything at the FDA level. The FTC, the Federal Trade Commission, has sent out investigatory letters to companies to ask about their practices here, but that would be broader than just mental health. It would be like chatbots in general. There have been several bills introduced at the federal level on chat features. There was a markup committee hearing. Ted Cruz had a committee hearing 2 weeks ago that involved the chatbot bill. So there has been stuff at the federal level, rumblings, but I do not recall anything from the FDA. I would be happy to stand corrected if somebody has a specific recollection of that.
Ledge Counsel, do either of you know that answer?
There is a little bit at the FDA level, and I'm sorry I can't remember the acronyms exactly, but it does fall into some areas if it's being used as a medical device, and so there is some level of it. I am not a technology person, so it's not entirely clear to me whether that applies to all AI uses and kind of what their line is. I tried looking at the documents that they have a large document that reviews it, but my understanding is that there is some, because it is integrated into the medical devices, and there are kind of two different technological levels of whether it itself is doing the AI's or the device is doing the action, or whether it's a human using a device, even like a pulse oximeter or something like that, that would be different. Like it's just a piece of.
I'm familiar with a lot of FDA oversight over software as a medical device tools that utilize AI. I just specifically was interested in have they weighed into the provision of mental health services and treating that as software as a medical device.
We're going to go over to Mr. Hoffert, please.
Yeah, I agree. I'm not aware of seeing FDA address that issue specifically. In general, I would say FDA is really struggling right now with the AI element of all the medical devices, and they have focused much more on physical medical devices that might be powered by AI. And I think they honestly don't know what to do with this one, and that's why states have been stepping in.
Mr. Harris?
I would say we have a vendor today that we leverage for our chatbot and some LLM capabilities on the back end, and they are pursuing FDA compliance accreditation. Whether they get it or not is another story. But I think there's a desire to go that route just because of some of the barriers that it would remove in the future. So we'll see when they get there.
Thank you. More questions? Mr. Hoffert?
Question hopefully for Mr. Staus, but I'm interested in what trends you see in terms of bills that actually successfully pass versus get introduced and then fall apart. I think couple of years ago, it seemed like those broad bills like Colorado SB 205 were gaining traction, but this year has felt much more narrow scope. And I wonder if you agree with that trend, or in general, what seems to be the recipe for success at this point in this area?
Yeah, sorry. For you. Thanks, Dave, for the question. I mean, things changed, right? I mean, I think what state lawmakers who were originally at the first line of looking at the laws in Senator Brody, Senator Rodriguez, and Waters, effectively, they had done data privacy, right? And so they looked at data privacy and they said, well, this is kind of comprehensive, right? It applies across all different types of companies, subject to exemptions, those types of things. And they were encouraged through groups, and quite frankly, I was one of the ones encouraging them as well, as I said, if you guys are going to regulate AI, you cannot do this with a state-by-state approach. You have to talk to one another. Like the same issues you guys are wrestling with, like defining AI and these circumstances, those types of things. Like, how can you deal with a definition of AI that changes based upon the state and changes based on use case? That's incredibly difficult to navigate. With privacy, it lucked out. Privacy, you have California with the California Consumer Privacy Act, and you've got the privacy laws that are all based upon the same model law, the Washington Privacy Act model law that never passed, but now 22 other states have passed it in other states. And so the definitions are really simple, right? And it's easier for companies to do that. So the concept was years ago was, hey, let's take everybody who's interested in this. Let's try to get people to agree on definitions. Let's try to get people to agree on use cases, those types of things, right? But that ran up against business interests. And it ran up against also a change in federal administration and a change in approach. And this isn't I'm not trying to describe any of those sense, it's just history. And it ran up against hey, we want to deregulate as opposed to regulate, right? And what ended up happening there is that state lawmakers said, okay, we can't do these sort of omnibus bills that create definitional alignment. So we're going to look for certain specific issues, right? So instead of regulating employment and healthcare and financial lending under one bill, I'm going to run a small bill on mental health. I'm going to run a chatbot bill. I'm going to run an education bill, right? And so that's actually made it, to crush it, it's made it much, much harder in this space because it's just everywhere, right? And so I think last year I saw more bills. I tracked something like 400, and I wrote the number down in case it came up. I tracked 400 something bills last year, and I'm not trying to track all of the the government ones. I'm not trying to track CSAM. I'm not trying to track political deepfakes. I'm just trying to track ones that apply to businesses, right? Because that's what I do for a living, is that businesses. And there's over 400 bills. And so I think it's become one of those things where in the absence of being able to go after this approach holistically, people have said, fine, I will take this issue by issue. And it's becoming a much more difficult situation. And for what it's worth, it's a much more situation.
Senator Rachel, out of curiosity, in your own opinion, do you think this should be addressed at a state level or a federal level based on the comments that you just made?
I mean, clearly it should be federal, right? I mean, clearly it should. And probably hesitate from offering opinions, but it's the same thing with privacy at the end of the day. Clearly data privacy should be addressed at the federal level. Everybody knows that. But I think what state lawmakers have looked at and they've said, if I have a company, use a chatbot, if I have a company that is unregulated, it's interacting with 13-year-old kids, and it has no guardrails in place to do anything if that 13-year-old falls in love with the AI, or that 13-year-old is expressing suicidal ideation, right? I can't wait for the federal government to step in and do something, right? I've got to legislate. That's what people elected. And I think they've looked into mental health, and I think they've looked into mental health as well, and they've said, listen, I can't wait for the federal government to tell me that, I shouldn't have AI, interacting in that setting. I think that's been a tug of war. So do I think it should happen at the federal level? Clearly, it would help businesses, advocates, all those things. But I'm not telling you guys that, wherever you sit in the aisle, it's not like the federal government's doing a lot. Because, in this space. I don't think I'm saying something that's controversial. Like it's you know, we've been saying for it's a running joke. I mean, I've been doing data privacy bills since 2018, and it's 2026, and we're no closer to passing. We're probably further away than passing federal privacy bill than New Bedford.
One more question. Oh, go ahead. I was going to say one more question, then I'll open it up to the rest of the folks because I got a whole list here. As you said and talked about like the disclosures, the chat box, I mean, are people really not putting disclosures on these things that they're putting for AI? I mean, is this really an issue or is it not an issue? Are companies being responsible in this aspect and saying, hey, AI generated, this is an AI generated chat box? Or is that truth or is that a myth? I mean, is this a concern?
It depends. I mean, so it depends on the actor, clearly, right? Like the bigger companies that have compliance people in place, the IBMs of the world, right? I mean, IBM had a responsible AI program 5 years ago, right? They weren't waiting for regulation. They were saying this is the right thing to do. We should have a responsible AI program. They looked at it as good business at the end of the day, right? So like you saw, like when Senator Maroney came out with the final draft of the AI bill that never passed the Senate, but it didn't get to the House, I think it was IBM supported that and said, this is what we're doing already, right? So like some companies are going to be doing those things. Some companies are going to be disclosing. I think where you see the issue here, and something you haven't talked about, but it's worth thinking about, maybe bringing another speaker, is the AI ecosystem is different than what you're probably used to because you have the frontier models, right? So, I mean, it costs billions of dollars to generate a large language model, data centers and NVIDIA chips and all those types of things. And like startup companies don't have that. They don't have that type of money. So they rent space, basically. They rent space in the data centers, they rent compute. And then they, or they're building their new AI platform off of somebody else's AI platform. And so you have like these frontier models, and then you might have another developer, you might have another developer, until you finally get to the end user, right? And if you're an AI startup and you're trying to get revenue positive, right, you may not have all the same guardrails that IBM has, right? And that tends to be, you can look like Character AI has been sued by, that was one of the chat features that is coming under severe scrutiny. They've been sued by Kentucky, if memory serves, and they were not providing disclosures, right? They were not providing any sort of disclosures. I think that's one area in which I have an opinion, which I try to stay away from. I'd say like that was one area in which states really came in and did some good at the end of the day. Anyway, so.
Gotcha. Questions from folks. Mr. Fung?
Yes, I have a question. So there are other efforts, mostly by practitioners and academics, like the National Institute for Standards and Technology, NIST. They just released this year a whole initiative for standards on safety and security on AI applications, mostly focused on agents, because as we know, that's kind of the latest thing. So we have LLMs, and now, I don't know if anybody's familiar with agents, but what it is now you can have these entities that behave mostly like a human and can make decisions and use tools to go and improve workflows. So I wonder, my question to you is, how influential are these efforts that they make into decisions that are made from lawmakers, right? Like, is that something that's taken into account? Because I know that they're pushing. I was in a conference earlier this year where they are really kind of trying to get that out there. Of course, there's no way to enforce that people adhere to these recommendations, but I don't know if that kind of gets into the minds of the lawmakers at some point and influence these decisions.
Mr. Chair, it does. I mean, it does. So, just for some background, this National Institute of Standards and Technologies, it has frameworks, right, that it puts out. So there's one for privacy, there's one for cybersecurity, there's one for AI. And it's not like a wall. It doesn't say like can do, don't do. It's a framework at the end of the day, is what they're called, right? And it's things like, do a risk assessment, identify the risks, have a process in place to resolve the risks, those types of things. It's a flexible one, it's iterative, it's intended to be something that you like build a program out of, right? It doesn't say provide a privacy policy. It'll say like, how are you handling disclosures to consumers, like those types of things. And so one of the ways in which it was attempted to be used was in Colorado. I mentioned SB 205, so that was the Colorado AI Act that was repealed and replaced. But it had this aspect to it that said you have to have a risk management program in place, right? So before you deploy AI into the wild, you've got to actually make sure it doesn't discriminate against people, right? And so one of the ways it said was you can use, as a safe harbor, you can use the NIST standards to develop your program. And if that's the case, then the Attorney General's office would recognize that as being acceptable, right? They're like, hey, you use NIST and you use that as a framework. So I've seen it be used that way. It's used in a privacy setting, like Tennessee has, in Tennessee's privacy law, it says if you're complying with the NIST privacy framework, then that's a safe harbor. It's kind of square peg round hole, to be honest with you. But I think state lawmakers, at least the ones I've interacted with, are very familiar with NIST. But it's hard to say like comply with NIST and you can comply with our law because it's not prescriptive like X, Y, and Z. It's just that framework and you go through and you analyze the risks. And it's intended to be that way. I mean, this is intended to be sort of like something you can take and apply to develop a program. My experience, I mean, others may have different experience in space.
Thank you. Other questions that we have from anybody? Yes, Senator Kioski.
Thank you. As you stated, it would be great if we had something coming from the federal level that could help guide this so it's not state by state. When the federal government previously was looking at that 10-year moratorium in the reconciliation bill, that seemed pretty concerning, and I'm curious if you have a sense of what is happening at the federal level and what we should be aware of and or protective of what our rights as a state are to be able to do something in case something like that is floated again. I guess maybe that's a little bit of a big question, but I'm just curious what your thoughts are.
You guys have 5 hours on that one. I mean, it's hard to, it's such a great question, right? So, it just has so many iterations for 10 years. So for folks who may not be familiar, this was maybe 18 months ago. It was part of the budget reconciliation bill. The concept was basically going to put a 10-year moratorium on states regulating AI, right? And eventually, there's been different iterations of it. I think there was a 3-year moratorium that was proposed as well. The concept was basically like, well, like we did this with the internet, so the states couldn't tax the internet when it first started, and this really helps like get the internet going. And so it was a similar concept. Democrats obviously objected to it, partisan objection. But there's a lot of Republicans who objected to it as well, like Marjorie Taylor Greene objected to it, Rand Paul objected to it in reserves. And in even states like Florida, Governor DeSantis in Florida, who ran an AI Bill of Rights that did not pass this year, had chatbots and AI, other principles as well, objected to it as well. And the reason why, there was a few reasons. One is like the definitional issue we had before of AI, right? Which is this concept of like, hey, we're talking about AI interacting with kids. And it's not just AI with chat features, but what state lawmakers have also looked to regulate is AI within social media, right? So my kid's on, X, Y, and Z game, and that game is addictive because it's endless. Right? It's not like when I was a kid playing Metroid, where like there was an end. You actually like one Metroid, right? Like now it's just endless, and it's addictive, and it's designed to be that way. So there was a lot of concern if you put a moratorium on that, but you also would stop like social media regulation, which has been another big issue for states to regulate social media. Where it stands now, I think it kind of came around again maybe 2-3 months ago. My sense is honestly, but I think things have changed, right? Like I think people have, the news has changed. Right? Like you see Sam Altman coming to the White House to talk about their next release of the ChatGPT model, right? Or the OpenAI model. You see them like the White House saying like, well, hey, we're going to stop. So Fable 5, so you have Anthropic's the company. It comes up with different AI models. And the model it came up with, the base was Fable 5. And the White House looked at it, and I mean, depending on your point of view here, looked at it and said, like, this is risk, right? Like, it can break into, like, it can break into companies. It's got that type of power. So I think on the federal level, in the Trump administration, the Senate's changed a little bit in the last 6 months. That they've looked at these incredibly powerful mythos, AI models. They said maybe we should have a little bit more of a touch on this issue. And they've also been more receptive to bills, like I mentioned before, like there's the AI bills introduced. A lot of stuff are lining around like kids' bills. It's not like these types of bills where you're looking for like the Colorado version of a responsible AI, but it's this idea of like, let's regulate Jeff insurers, those types of issues. So I haven't heard a lot, and I could be wrong. I can get off this problem with politics. I get off this fall and get like CNN running an article on the moratorium, but I haven't heard anything more about the moratorium recently. It was a big deal ago, and it just hasn't, in my world, it just hasn't like made sense. So I hope I answered your question, but tell me if I didn't.
Nope, she has no other follow-up questions. Thank you very much. Mr. Lau. Thank you.
Thank you, Chair. So, David, just to follow up on that one, given the...
Do you have your microphone?
It is on. Can you hear me? So, a follow-up question. Hello, from Senator Kieski. Given the federal landscape, for the state of Wisconsin, do you have any recommendations or guidance for how to ensure any state policy is durable against the current landscape, or how the landscape would change? And have you seen anything that other states have done to ensure durability in their policy?
That's great. That's a great question. One, I mean, let's first principles first, right? You guys have questions, so I'll give them an honest answer. You guys have had a data privacy bill that has gotten through chambers before, and it hasn't passed. I think you should do it first, right? I just think like that's, enough states have passed baseline data privacy laws where like it's not a red state issue or a blue state issue. The particulars are red state, blue state, but like the idea is not. And there's plenty of models and states that have done stuff that does. Why do I say that? Because like AI is based upon data at the end of the day, right? That's what AI runs on, data. That's why 3 years ago as data privacy attorney, I had to add AI into it because like it's data governance at the end of the day. So I think Kerry's states are like, that's a good way to start, right? There's aspects there where like it applies to data, and it's a good foundation principle. And those types of laws stand the test of time because they're principle based, right? They're like disclosures and those types of things. Personal rights, consumer rights, access to correct those types of things. And then I would say, as far as like how to write laws that stand the test of time, one of the beauties of state lawmakers is you can come back and modify it the next year, right? So Senator Maroney in Connecticut has, I worked with Senator Maroney 4 years ago on passing the Connecticut Data Privacy Act. It's been amended 3 times since. Added children's provisions, AI provisions. This past, and then they came back and they amended the children's provisions. This past year they did facial recognition as well. So like the beauty of being state lawmakers is like you don't have to put something in stone that's going to last for 30 years, right? You can come back and change it. But I think if you make it principle based as well, and I think sometimes less is more. I think, if you take a narrow issue like what's the harm we're trying to address? Louisiana is a perfect example of that. Like, hey, when a doctor goes in to visit a patient and he has an AI note taker, you gotta tell him. That's a simple principle. It's hard to disagree with that principle, So like those things I think stand the test of time. I think the ones that are harder are the ones that are really, really hyper specific to to a specific technology. Those are the ones I think are really difficult. You've seen California with its AI Transparency Act. It's come back and it's amended that law. It's not even in effect yet, and they came back and amended it once to add capture devices. And now it has two bills to amend that this past year, but that's like hyper specific to a hyper specific type of technology. And that's the issue, right? Is you can't make it technology specific because once you make it technology specific, it changes. It's got to be principle based.
We have.
Oh, you saw one.
You have a question?
Yeah.
Oh, Representative Nealon.
Oh, thank you. Thank you. That was very informative. I've enjoyed this discussion. I want to also point out, I signed on to the letter to be opposed to the moratorium, but it was exactly for those reasons. It was more the fact that like we do have like state criminal law, right? So when you're talking about like CSAM and deepfakes and things, like we want to have something on the books in terms of like state law as well, and not rely on like feds and federal prosecution. Also, like we are tasked with election law, and I know we're off track here a little bit. Sorry about this, but like when it comes to like running our elections, like we do the laws around that. So if we had a moratorium on that, what would that mean for like disclosure and deepfakes and things in that space specifically? But I totally hear what you're saying in terms of like having a federal standard when it comes to like regulating business and regulating commerce. I think there should be like a federal framework so businesses are able to navigate that. But also we do have, you know, state criminal law and election law and other things that you alluded to that, you know, as policymakers, we need to be able to work on and deal with and not just let sit for 10 years. But I also specifically have a question like around that, and that's like, you know, I know that disclosure is important and it's big and it's easy, but in my experience, like sometimes people just ignore it, and there's like a like reluctance to prosecute. Like I don't know if you have any like examples of some states that are doing these, and it's not just like theoretical, but it's actually like somebody has gone after a bad actor and actually like stopped bad behavior from happening. And I don't know if you have any examples of that and what state that's happened in, but that'd be interesting to me.
Yeah, through chair. Yeah, thanks for that question. It's a great question. So I'm struggling to think of an instance in which a state has gone after a company for disclosure. There is, I've got a touch of an explanation for that, but there is the one that comes to mind is the one I mentioned before about Kentucky going after character AI, and that was not a disclosure-based one though. Kentucky does not have a law saying that must tell them it's AI, but they had a private law firm that was trying to use their new data privacy law was literally filed like I think 2 days after the data privacy law went into effect, trying to use the data privacy law to say that these things should have happened, like privacy policies, those types of things. I think to your question, I think the reason why we haven't seen something yet is a lot of these laws just got passed this year, right? I mean, many of these aren't even in effect yet, right? And it takes time for these things to work out. So California was the first state to pass privacy law. It went into effect January 1, 2020. Sitting here today, we have 13 enforcement actions, right? And they're ramping up. I mean, like they're ramping up and we're getting more. There was 2 this week, right? So like it takes time for like that to happen. And so, but to your point though, right, what I think state lawmakers have struggled with is, well, shouldn't we give a private right of action to individuals to pursue these things if there's actual tangible harm at the end of the day? And so you have seen Oregon and California and Washington try to do that. Like those are chatbot disclosure-based laws, and the one in Oregon in particular, which I don't think is in effect yet, but that has statutory damages associated with it. And so it's basically like if you do this and you you haven't complied with the law, then like you're on the hook for like $1,000 a pop or something like that. I have to go back at the law. So I've written I've written an extensive article about that one, saying like this could be a game changer, right? And I am not. Don't hear me to say that I'm an advocate of PRAs, private rights of action. I'm not. I think they've been completely misused by plaintiffs' lawyers. But I guess the answer to your question is like no, but it's probably a matter of just timing at this point in time. And maybe if we visited next year, I'd have like 20 things to talk to you about in response.
Fair enough. Just like looking for some specifics on some things you said that I'm interested in, but what specifically who are data sharing suppliers? Like who's providing that data to? Like who's buying it? Who's selling it?
To the frontier models or to the developers? Well, let me answer all of it, right? So this is such a great question. There are companies that exist, right, that are licensing or selling data, right? So say you're a company that has, 1 million pictures, right, because you represent photographers. Like that's a rich data set that you can sell to a Gen AI company to be used to have them come up with pictures, right? To generate pictures. So that's a rich data set. So some of that is those types of companies. A lot of it is, and there's lawsuits out there, a lot of it is scraping, right? A lot of it is like they've gone across the internet. Like if I write something on my blog, or if I put something up on that website I advertised before, I get scraped, right? And I go on Claude, it'll be using my own, if I ask a question of Claude, tell me about the state privacy law, tell me about the state AI law, it'll go read my stuff and regurgitate it to me, right? So some of it's public use case, some of it's private, licensing and selling of data sets. I have not seen it be like data brokers. Like there's a whole other piece of like privacy law, which is like data brokers, right? And like California regulates, and a few other states have gotten into that as well. It's a super interesting area of law. I have not personally seen data brokers sell data to these companies to create these things. And it's more or less like the publicly available stuff. And there's been some lawsuits that have been settled with like newspapers and those types of things. Hopefully I'm hitting it.
That is fascinating, honestly. And then the one also caught my interest that I want a little more on was this idea about the pricing. And I was curious what the difference between is in Connecticut with their approach of like prohibiting surveillance pricing versus what appears no state has ever done, which is banning the use of data to algorithmically set individual prices. So what's the difference between prohibiting surveillance pricing, I guess maybe what is surveillance pricing, and how does that differ than a state banning just outright the ability to algorithmically set individual prices? Does that make sense?
It does. I don't know that I know. Let me pull up the Connecticut law. I don't know that I know the answer off the top of my head, to be honest with you.
I would love to talk more if I have your contact information, so maybe we could just take this offline.
Yeah, I mean, it's super. Yeah, maybe it's broadcast doing because it also involves, like I said, California is running the same bill that Connecticut passed, and there's a definition of surveillance pricing, but then there's a definition of. I just can't recall the algorithmic pricing definition off the top of my head, but there is a definition of it. Happy to chat with you.
Thank you.
So,
thanks for your time.
Any other questions that we have for this gentleman before we break for lunch? Okay, we thank you very much for your time today and your expertise in this area. We hope to, if we have some more questions, to reach out to you.
Thanks for having me.
Thank you very much. Okay, we are going to take a break for lunch. We will come back in an hour. So should we say we'll restart at 12:45? Can we do 12:45? 12:45 it is. Back to this. You got 5 minutes to eat, and you better be back. 1:45. There are many wonderful restaurants around here, as well as I heard there's a famous pasta cart on the square somewhere. So find some food, come back, and let us continue our conversation. Thank you very much. We're ready to rock and roll here. Couple things to address. We do have a request in to get the temperature maybe a little bit warmer in here. So if you are freezing, hopefully we can warming you up a little bit here. Other things to keep in mind that I didn't mention earlier, WISI. We are live on WISI, so for public view if folks would like to watch us. And then I'm just kind of curious, is there anybody in here that... I'm just kind of curious if there's anybody that's been on a committee before. Is there anybody that's been on? Oh, we got a pro.
Nealon says he has.
Well, nah.
And I think Dr.
Just
Huth,
one?
No, Dr. Huth had two, I think.
But you weren't part of, you testified, but we're
like steering committees, task force, we've had a lot.
Yeah. Well, then it's new for many of us, then including myself. So again, thank you for being here. So we are going to go on now to presentations regarding patient advocates. So patient advocacy groups that we have in that might have some insight, either from their organization or from their members. So thank you for starting us off. We are going to start off with Emily Peterson with the Greater Wisconsin Agency on Agency Resources. Then we're going to be also talking with Erin, Leslie, and Mary Kay in turn with question and answer. Thank you so much for being here.
Thank you.
And everybody's fed, so nobody's
Perfect.
hangry.
Love
But
that.
now you
That's
might
a great
have to.
spot to be in.
Yes, but now you might have post lunch comatose kind of being lethargic a little bit.
Okay.
But
Well, I'll try to
we're
keep
here.
I'll try to keep it lively then.
Yes, keep her lively.
Okay.
It's cold enough to keep us all awake, so you'll be fine. Thank
Okay,
you very
good.
much.
Well, thanks so much for having me, Chair and members of the committee. My name is Emily Peterson. I'm the Advocacy and Public Policy Director for the Greater Wisconsin Agency on Aging Resources, or GWAR. I'm also here representing the Wisconsin Aging Advocacy Network, and I'll explain a little bit more about that later on in my presentation.
Oh, we are having technical. Oh, there we go. Bam.
Hardest part is going to be the remote, I guess.
Okay, you got it.
Okay, like I said, I'm with the Greater Wisconsin Agency on Aging Resources. We are a federally designated area agency on aging responsible for providing aging programs and services to 70 counties in the state of Wisconsin. So that's all 70, but we don't do Dane and Milwaukee counties. So there's agencies that take care of those two counties. And then we also carry out those services for the 11 federally recognized tribes in the state. So what that entails is carrying out programs related to nutrition, caregiver support, transportation, social services, all of those things required under federal law for older adults in the state. We provide training and technical assistance, so the counties are the actual ones delivering the services, so we don't actually do those services, but we help counties and aging units across the state actually do that. We also provide advocacy, education, and outreach. What that entails is helping older adults advocate for themselves, get them connected with their legislators so that they're able to learn how they can actually make a change, advocate for the policy priorities that matter to them. One of the ways that we do that is hosting an Aging Advocacy Day. So maybe for our legislative members on the committee have seen our older adults come to the Capitol every other year in their bright yellow sashes to meet with staff and legislators to talk about those policy priorities. We also have some statewide programs outside of that scope that we carry out for the state. The Guardianship Support Center helps individuals learn more about the guardianship process, protective placements, and advanced directives. The Elder Abuse Hotline is a resource center so individuals can learn more about elder abuse prevention, and also connects people to their local APS unit. So anybody in the state can call. You can be an older adult, family member, friend, member of the public, call and say, hey, someone's in a situation. I'm not sure if it's elder abuse or not, but I have a concern. And our staff person on that hotline will make a determination if it needs to be transferred to a local APS unit. Senior Medicare Patrol, again, a statewide resource to help detect fraud, scam, and abuse in the Medicare system. And I'll talk a little bit more about that resource a little bit later in the presentation, because that really helped get together some of the data about how AI impacts Medicare right now. And then a veteran self-directed hotline that helps veterans enroll in home and community-based services through Medicaid. And then, like I said, I also coordinate the Wisconsin Aging Advocacy Network. This is a statewide collaboration of organizations and individuals that advocate for older adults in terms of policy priorities. This is a mix of 13 member organizations. Some of these individuals are professional organizations, so they make up people who represent Wisconsin nutrition directors, Aging and Disability Resource Center professionals, and then it's also made up of older adults themselves. So it's that mix of professionals and actual members of the public. We deliberate public policy and set policy priorities with the goal of improving the quality of life for older residents of Wisconsin. Again, there's 13 members. We're educating the community and policymakers. So again, a lot of that activity is derived at, of course, trying to get people in front of their legislators, but also educating the public, educating older adults about issues that they may be concerned about in terms of older adults. Again, we host that Aging Advocacy Day in odd-numbered years in coordination with the state budget. And our top policy issues right now include funding for Aging Disability Resource Centers, Meals on Wheels, or home-delivered meals.
falls prevention programs, and transportation. So people are probably familiar with some of these issues and how important they are to the community. And again, our advocacy network gets together, talks about the wide variety of older adult issues that are important. This is not an exhaustive list of the things that we care about, but these are our top 4 priorities that we're advocating for. So when we talk about AI in healthcare, there's a lot of opportunities for this body and the legislature to kind of impact healthcare policy. I included this picture from the TV show The Pit, which I'm sure a lot of people have seen. It's a very fun TV show and funny. And there was a really great scene in this past season where one of the providers started recording a patient interaction and trying to encourage other providers to start kind of adopting AI, recording things so it can be transcribed to help with charting and notes. And I thought that was really interesting. That had been mentioned by one of the committee members this morning, that help that can be used for some of those administrative tasks. And when I saw it in the TV show, I kind of chuckled. I was like, how realistic is that really, that you'd like go into the ER and your doctor would say, hey, by the way, can I record you on my phone? But that actually happened to me when I was at my annual physical this year. My doctor walked into the room, had her phone out, and was like, do you mind if I just record this? It just helps me so much with the charting. And I said, sure, why not? I also didn't know if I was allowed to say no. But it actually kind of shows how prevalent AI is becoming in the healthcare system, and more providers are starting to use AI to help them. And I think Representative Nalon had said when we were talking with the previous presenter about is all of the potential legislation regulating against AI. And I think maybe when you hear an advocate perspective is going to present on this topic, that we may just say, AI is so bad, let's regulate against AI. But we know in the current environment that as we have a growing aging population in our state, we do not have enough healthcare workers to meet that need. We're at a kind of critical juncture in the healthcare workforce where we know there are less and less people available to assist older adults in nursing home facilities, in the long-term care system, and there are opportunities to bring in new technology to make those workforce issues a little bit easier. So there are opportunities to bring in AI for maybe some of those administrative tasks. I think charting, scribing would be a great example of something where AI could be a really useful opportunity. But there are also, of course, things just to be aware of when you're talking about AI, especially with older adults who are, of course, going to be less familiar with AI and a little bit more wary. Some of the materials provided by the Legislative Council showed that healthcare and insurance providers are reporting that they're using AI at higher levels, and also that AI has been used for many years now. It's not as new as probably some of us think. There are no federal overarching guidelines or rules around using AI in the healthcare system. And although there are some states, as we heard in our previous presenter, that are starting to legislate around AI, there's a very small percentage of those bills that end up being enacted. So here's where the opportunity is. You know, our state can kind of step in and maybe be a leader in this space and crafting legislation that fills in that Venn diagram of protecting patients, but also, you know, bringing in AI in a positive way to help promote healthcare for older adults. So I want to talk a little bit about where AI is being already used in spaces where older adults and individuals with disabilities are. There was a pilot project in Medicare called the Wiser Pilot. Wisconsin was not a state that was part of this pilot program, but there were 6 other states that are part of this pilot that is currently going on from now until 2031, and it uses AI models to determine if certain services are going to be covered or not covered. And Medicare has picked some services that are usually seen as maybe not medically necessary to treat a certain disease. And this model will go through and kind of do a prior authorization process on these services. If the model determines that the service is not necessary, a human will review that determination before issuing that denial. So this kind of shows that they are kind of putting this human oversight into the AI model. If the AI model determines that the service will be covered, there's no human oversight. It just goes ahead and approves that service. But when that denial piece comes in, that's when the human steps in and decides, hey, let me check on it before I go out and issue that denial. So this pilot project, again, it just started, so we don't have any data back really on how successful it's been or what some of those numbers look like, but this is a blend of where we have the AI model coming in and a physician providing oversight on the service. And again, this is happening in the Medicare space, and a really good opportunity to see, how this will turn out and how it will impact older adults. CMS has also recently proposed another opportunity for a pilot project for care navigation. And this is where AI agents or a chatbot perhaps would help Medicare beneficiaries select a plan. So right now, Medicare beneficiaries, if they want to select maybe a Medicare Advantage plan or a Part D drug plan, sometimes they're on their own. They just go look up these plans on a marketplace themselves and scroll through and see what they think would match. There's also people who are in person through maybe a SHIP state navigation healthcare program that can help people sit down one-on-one. There's a lot of folks in counties right now, county aging units, who are doing that service. But this would kind of be an AI version of that, where agents would go through, maybe look at some of your medication lists, look at some of your healthcare needs, and help you pick that plan instead. So this has not been enacted yet. This is just a proposal that came out this week from the CMS director saying that this is another frontier where AI can come in and help Medicare beneficiaries. There also is a current pilot project in the fraud detection space in Medicare, and fraud detection has been a huge conversation in the Medicare and Medicaid space. And recently, the Centers for Medicare and Medicaid Service did do a project where they were reaching out to different healthcare companies and technology companies to see if they could create any models that would help detect fraud and abuse in the Medicare system and see if there are any services in particular that are highly susceptible to being used fraudulently. So again, kind of tying into that WISER project, where Medicare has already identified a couple of different services that they already know are highly susceptible to fraud. This fraud detection project is asking different technology and healthcare companies to see if they can develop any other AI models that would help them discover any other services that people are wanting to get that are also highly susceptible to fraud. So those are 3 projects that the Centers for Medicare and Medicaid Services are working on right now to bring AI into the Medicare space. Prior to that, those AI had not really been used in that original Medicare setting, and that's where the federal government is providing Medicare to beneficiaries. However, on the flip side, AI has been really prevalent in the Medicare Advantage space, and that's because private health insurers are providing health insurance to beneficiaries. About 2022 is when we started to see more AI come through in Medicare Advantage plans, and that's usually around prior authorization for services and then in coverage determinations, particularly for people who are accessing skilled nursing facilities. And AI was kind of being used to determine whether or not somebody was qualified to be in a skilled nursing facility, how long they could stay in that facility, and if they were going to be removed from the facility. So again, in the Medicare Advantage space, it has been used for a little bit longer, and that's because private insurance agencies operate those Medicare Advantage plans. And in 2024, the Centers for Medicare and Medicaid Services explicitly allowed Medicare Advantage plans to use AI in those plans, and it was in their contract to do so. So again, the federal government, even though they don't provide a lot of guidelines around AI in healthcare overall, they've been definitely more encouraging of it in the Medicare Advantage space and are now explicitly themselves getting into AI use in original Medicare. And AI is, again, becoming very prevalent in the Medicaid space and is also exploring more opportunities to bring it into Medicaid. It's not used right now in Wisconsin's Medicaid system, but there are other states that are piloting AI usage in Medicaid. Again, that AI agent piece is becoming extremely popular. I think probably everybody in this room has talked to an AI chatbot at some point. And AI agents in California have become extremely popular to assist with enrollment and eligibility. They call their AI agent Angelica, and she will help you decide if you are eligible to enroll in Medicaid. So you go on to their website, Medi-Cal's website, part your information in, talk a little bit about who you are, how much your income is. Do you have a disability? And Angelica will tell you, are you qualified to enroll in Medicaid there? Kind of an interesting concept. And there are, of course, pitfalls with that. Maybe you don't really know a lot about yourself and maybe you're putting in wrong information. But there's opportunities, of course, if you're denied, to appeal that decision, and the human piece comes in to help rectify any errors. There are a quarter of the states in the country that are using AI chatbots to support enrollees in other ways. So maybe you're just going on to the website for your Medicaid system and asking simple questions like, when is my next renewal coming up? How do I find out where to connect with somebody for questions? So kind of like a chatbot that you would find on any other website. Like if you go onto the AT&T website and that little box pops up in the corner, those are the kind of AI chatbots that other states are using to help answer very basic questions about Medicaid. And then there are other opportunities to use AI to streamline administrative processes. In Ohio, they've developed a baby bot process for their Medicaid, which will automatically add a newborn baby onto Medicaid once that baby is born to the mother. So again, some of these administrative ways to help simplify processes in the healthcare field are really prime opportunities to bring in new technology to simplify things and to make sure that things are happening in an easier way. That just helps the system work a little bit quicker and a little bit faster for beneficiaries. And then we see another piece of where AI can kind of bring in some concerns for consumers. And again, like I said, we operate the Wisconsin Senior Medicare Patrol, where we track beneficiaries in Wisconsin who are having issues with Medicare due to different types of fraud, scam, and abuse. And over the past couple years, we've seen a lot of those opportunities for scam and fraud derive from AI. Again, I think we've heard a little bit in the news about opportunities for voice cloning and deep fake phone calls where someone is impersonating a doctor or a provider and pretending to be your doctor. And this has become extremely sophisticated with the ability to clone yourself or, again, create that deep fake phone call using AI. And beneficiaries get kind of scammed into giving out their personal information, giving out their Medicare card number, and that can be a huge issue. Same with that identity theft and impersonation of beneficiaries. So that's kind of the flip side, where somebody uses AI to not impersonate the doctor, but the beneficiary, and potentially enroll in a service that they weren't trying to do, and then they get billed for that service. There is not as much widespread use of telehealth in Medicare anymore. They did end that after the COVID-19 pandemic. But back when that was more rampant, there was an opportunity to use telehealth for Medicare. And there was a lot of fake telehealth and online doctors, so people pretending to be a doctor who did not have the right credentials. And AI makes it very easy to have fake credentials. You can go on to ChatGPT right now and generate anything that says anything about you. And so that was a huge concern, and people were getting scammed that way. Again, you're giving out your Medicare number, and then someone's billing you for something that they didn't do. They're not even a doctor. And then you're getting yourself into all other situations based on that. And then fraudulent enrollment. So again, this was an example out of North Carolina where Troy Health, which is a Medicare Advantage provider, had been using AI tools to collect beneficiary information, and then they were fraudulently enrolling them in Medicare Advantage plans. So they were caught and charged, and had to pay back some of that errors. But that's an example where an actual real provider was using AI, and then they were collecting information through a chatbot. So overall, there's a lot of considerations here. Kind of tying back to what I said at the beginning, you kind of got two different ways you can look at this. There's opportunity, positive things that we can do with AI to make the life of older adults easier. I think some of those administration, enrollment processes, helping people navigate the system, provide opportunities for older adults to get access to health care where they couldn't previously get access. And then, of course, there's considerations. There's a need for transparency. Are you opting in to the process? Are you agreeing to use AI for when you're at your doctor's office? When you walk into your doctor's office or your provider asks, can I record this so I can use it for charting? You should be able to say yes to that and not at the end of the visit, hey, by the way, I was recording this. It's an opt-in versus an opt-out, and we're hoping that beneficiaries get the opportunity to be opting in to the use of AI in their healthcare. And then that consideration of how private health data is collected and stored. Obviously, when you're dealing with sensitive healthcare information and things like individuals' Medicare numbers, these are things that when people have access to that information, they can use it for nefarious purposes. We know that even prior to AI, Medicare beneficiaries were being scammed and their identity and Medicare numbers were being used for fraud purposes, even before AI was in the picture. And now that there's additional ways for people to be victims of scam and fraud, we want to be sure that whoever is collecting their private health information, just like there's an expectation of privacy and protection now, that if AI is in the picture, there's a continuation of that expectation. And then accountability. Human oversight is very important in this process. Again, in some of the models that are already being used in the Medicare and Medicaid space, if someone's going to be denied a service for a critical medical decision, there should be a human making sure that that was the correct decision. There was actually just a report out of the Kaiser Family Foundation today that said 12% of Medicare Advantage and 14% of Medicaid managed care prior authorization claims are denied every year. And then when appealed, those decisions are appealed, 67% of the Medicare Advantage and 47% of those Medicaid decisions get overturned. So that means when someone goes back and looks at those, they realize the decision made was an incorrect decision and the person should have received the care. Everybody has a right to appeal a medical decision with their health insurance provider and to see if, a mistake was made and they need that life-saving care, especially for older adults who may be in a situation where they're being kicked out of a skilled nursing facility, where they're needing something on a very timely basis, and that human oversight provides a really helpful piece on checking on that AI. And then again, older adults and older adults with disabilities can sometimes have complex medical needs. They have overlapping health concerns, things that can be more difficult than AI may be possible to understand through a simple chat bot or through a care navigator. So kind of understanding the complexity of some of these health concerns for older adults is hard to understand without maybe bringing in that human piece at times. And then again, just kind of acknowledging that there can be a cost to some of these decisions. Sometimes it seems like there might be an upfront savings cost by bringing in AI or kind of speeding up the system. There's efficiencies found. But then, is there a costliness if you're going back to appeal decisions? Maybe you're going up through the entire administrative law judge process in the Medicare system to go through an appeal. And that takes time and resources, and you've got attorneys involved, and you did all that when the AI person made, or the AI chatbot made the wrong decision in the first place. So kind of weighing that and knowing that there's kind of a double-edged sword in that situation. Is it efficiency and moving things along quickly, or is it just making the right decision in the first place? So some policy recommendations. These, again, are just some basic things that we kind of thought about as a first step to consider. We don't have any actual bill language or bills from other states that have been previously considered that at this point we're ready to endorse, but these are some considerations from other iterations of bills that we think could be good to consider. So again, that requiring disclosure of AI use by practitioners. If someone's going to use AI, especially in a healthcare setting where there's kind of trust built, making sure that individuals know that that's happening. That human oversight of healthcare decisions. If there's an adverse determination being made, is there a human that can double check that decision before it's made? And then disclosure of AI use by insurers, not necessarily from an insurance provider to the individual when they enroll in a plan, but is there an oversight process at the state level? Maybe that's to OCI or the Department of Health Services, letting them know, hey, we're offering this plan in your state and we do use AI in making decisions. And again, that coverage determination, I think anytime there's an adverse determination to an individual, there should be an explanation as to how that adverse determination was made. And then testing and retesting. If a provider or an insurance company is going to roll out a new AI tool and making decisions, they should be piloting those tools before they're dispersed on a widespread basis. So again, to give a key takeaway of this presentation, we already know AI is being used pretty widespread by providers, whether or not individuals are aware of that. And we have an absence of legislation right now, even though there are some states that are starting to make considerations of AI. It's pretty small right now, and we have the opportunity to be kind of change makers in that space. We know AI is not perfect, and human oversight can kind of provide that check on AI. Educating the public on AI can also help people avoid fraud and scams. So whatever decisions are made by the committee, whatever legislation is enacted, another crucial piece that a coalition of legislators, healthcare systems, insurers, and advocates can do is also provide education about how AI is being used. It's going to continue to be used, and if we can help people understand how it's used in a positive way, I think that can help everybody as well. And then policy solutions should be putting the consumer at the forefront. So we can kind of blend that efficiency of AI, that inclusion of positive technology, and to help arrive at better healthcare outcomes, making sure the consumer is at the forefront is really the opportunity to do that. That's all I got. Thank you so much.
Thank you very much for your information and your representation of your group here. I'm going to start off with a question. One of your slides here had to do with consumer scams and fraud, and you listed off 5 different areas here. Are these things that you're actually seeing here in Wisconsin? Have you had consumers say, hey, this has happened to me? Or are these just things that you have read or heard others speak of in different states? So my question is, have you had stories of this here in Wisconsin?
Not all of them have been in Wisconsin. Some of them have, and some of them are from the National Medicare Patrol.
Thank you very much. Other questions? We have Representative Nealon.
Thank you. Thank you, Emily. Thank you for your presentation. It was very informative. I'm interested, I don't really have a question, but thank you for bringing up Ohio's baby bot. That's an interesting example of what can be possible in government with some streamlining of administrative processes, which I always like. I have a question for you, and I don't have an agenda, so please just take this as genuinely curious. But you said, and I suppose you're probably speaking for your organization, that you should be able to know that your doctor is taking notes. You should be able to know. If they're using AI to take notes of my question is why? What's the expectation there that we need to give this administrative burden? Why does the doctor need to ask you? Don't we expect the doctor to take notes of our visit? Don't we want them as a patient to remember everything we said and look back on it? So why do we have to disclose the tool that we're in the market that we're using to take these and we think about all the things we need to do and why why?
Yeah, I think that's a great question because I think that everyone has a different level of comfortability around AI tools. And I think not everybody really understands what it really means to have your visit recorded. And I think the piece of it is not necessarily the recording. I think if a doctor was just going to use the audio recording feature on your iPhone and then maybe go back and listen to the recording and take notes that way, that's one thing. I think that's kind of different. But I think the informative piece is that the fact that that doctor may be uploading that recording into Claude on Microsoft or to ChatGPT. And if your healthcare system doesn't have a privately owned AI tool, they control the entire back end of it and know where that recording is being housed and what privacy tools surround that technology piece. I think that's where the concern for consumers is that where is that recording going?
Thank you. It's a very specific answer in terms of, and something we're starting to see some themes here emerging, maybe data privacy being one of them. Right. Another one being that you hit on human oversight of important decisions. So, thank you for your time and bringing these important things up, and thank you for that answer.
Thank you.
We have other questions here. Mr. Hoffert.
I want to ask you to synthesize 2 things you said that I think forms almost a fascinating contradiction that I've wrestled with for a long time. On the one hand, you said, providers should have to disclose their use of AI. I think that we all agree that seems kind of reasonable on the surface. You also said that older adults tend to be less trusting of AI. And that reminds me of this fascinating study I read, I don't know, maybe 6 months ago about AI used to help write responses to patient inquiries. And the study showed that if you just show a patient two responses, one written by a human and one written by an AI, they tend to prefer the one written by the AI because it tends to be a little longer, more detailed, often more empathetic, until you tell them that it's written by AI. And all of a sudden, they're like, wait a second, no, I want the human written response. So it almost makes me wonder, I guess this is kind of the point you were making about, like, can disclosure be, if you're giving disclosure to somebody who doesn't understand AI or fears AI, can that actually undermine its value? And how do you square those two things that both seem very logical on the surface?
Yeah, again, I think that's a great question. I think part of where we're at in society right now, AI is extremely controversial topic. There are people who are just going to be outright opposed to AI and others who want to use it for everything all the time. I think that is why education about AI and how it's responsibly used can be very important. I think Legislative Council in their memo about AI had some really great explainers about different types of AI. And so understanding that there are types of AI that are like not generative AI is very helpful for people to understand those differences. And I do think that education piece is important. I understand what you're saying, that people, once they learn it's the AI response, they're like, oh, no, I don't like that AI. But I do think as we go along in society and are able to educate people about AI, I think people will become more familiar with that and understanding about it. So I do think that piece is really crucial, especially for older adults who are becoming more comfortable with technology and more accepting of new technology as they learn about it.
Thank you. I'm going to start with Dr. Justin, is it Bogey? Bogey man, okay, thank you.
I have so many comments, but I'll just keep it short.
Well, please share.
You gave some facts on some of the pre-authorization, that AI framework, and 56% of the time.
Is your button on? Is your green light on?
Oh, no,
Thank
sorry.
you.
I'll repeat my question. You had some statistics on the AI algorithm that either denies prior authorization, and when it was challenged, it was wrong 46 to 7 or 60% of the time. So, and I think a lot of people are aware of this. Those AI algorithms can learn from the mistakes, and then that error should keep shrinking. Are you finding that? So it was 46% denial the last time you did it. Are you training that AI so you don't have to put a person through, a denial, and then they have to go through all the rigmarole to get it caught up on?
Yeah, great question. I don't know the answer to that. Medicare Advantage plans and Medicaid managed care organizations are only required to report to the federal government the percentage of denials that they have overall and the percentage of redeterminations after that. So that's it. They just provide an overall percentage. And I'm not sure that's all the requirements that they are placed upon them. And it's not necessarily denial based on an AI decision. It's very broad data that they break down into different health insurance providers.
Do you have more? Did you have a list by chance?
No, that's it, yeah.
Okay, thank you. Other questions or comments? Thank you very much, Ms. Neverman.
Yes, thank you. Emily, thank you for the presentation. At Elevance Health, that clinical oversight that you were referencing is very important, and AI does not deny those care decisions. Can you share some more light or evidence on like insurers' use of chatbots in that denial of care from what you're seeing?
Yeah, I don't know off the top of my head. I could get back to you on some more examples of that. My understanding is that there's kind of two different ways that the chatbot and then the models are being used. So I don't think there's kind of an overlap between the chatbot usage and then the denial piece. Some of the adverse decisions are, of course, those prior authorization pieces when you're reaching out at the front end. And then, of course, the back end, like when somebody, particularly in the Medicare space, is being transferred into a skilled nursing facility. And I think there's a lot of instances of that being the adverse determination. But I can get you more information about that.
Thank you.
Mr. Matterson.
Emily, thank you for the presentation. Thanks for clarifying that statistic, too, that Dr. Bogie brought up. One thing your comments about education, I think, are really important. Being in a provider of healthcare and using some of these tools and techniques, it doesn't matter if it's AI or if it's the medical record as a whole. I think that's very important because we think about HIPAA, we think about our protection and privacy. And so that's high of mind on all technology that we're using in healthcare. So I think getting that education out there so people don't think it's going into ChatGPT or Claude or something that's in a private realm. And I'd like to know, what do you think? How do we do that? What's the best way to do that? Because I think that the public is keeping, faith in us to keep that safe and keeping their information safe by having conversations with their provider. Just wondering your thoughts on that.
Yeah. It's a great question. And I think it's not just on healthcare providers to be doing that education. I think some of that, again, comes down to that informed consent. I think that is very helpful. Again, if your provider is going to be using it with you, kind of building that trust, if they're going to be recording it, kind of sharing that that's happening. And then I think it is kind of a broader conversation in this entire space of healthcare providers, policymakers, advocacy organizations that work with these patient populations to kind of share, like, this is the space we're in, this is how things are changing, and this is what you might be seeing as you go into a doctor's visit, as you work with your Medicare provider, whatever that is, this bigger coalition that can work together to educate patients that this is kind of what is going on in the healthcare space. I think this committee talking about this issue is a great place to start to get these conversations going with the community. But we've seen healthcare organizations do great work educating patients on a variety of topics. I'm thinking about like the advanced directives. There's a lot of healthcare organizations that provide amazing community outreach and education on advanced directives, like at community fairs, talking about that issue with patients. So I think there's definitely an opportunity for healthcare providers to actually be doing kind of that grassroots education for patients on a variety of healthcare topics.
Thank you. Any other questions or comments from anybody? Thank you very much, Dr. Herr.
Thank you, Madam Chair. Emily, thank you. I have a question going back, well, a comment first. What we've heard from patients in our clinic to the earlier question of why would someone not want this technology? Sometimes in our experience, it comes down to the question of, do you mind if I document what we talked about from my memory at a later point, or do you mind if every single word you say is going to be recorded? And then the questions about, well, and then what happens to that recording after the visit? So I think that's hesitancy that creates hesitancy for some patients. Mm-hmm. You said a very interesting thing, though, that, and my question actually has to do with getting actual true consent. One of the comments you made just in passing was patients can deny it, although patients are often hesitant to say no to their doctor. And when I think about that, and also my 93-year-old mother, our conversations on the phone are often helping her get back to Gmail because she can't figure out how to do it. In these populations, what kind of barriers to true consent and understanding what AI actually is and how it's being used, what barriers exist and what can we do to overcome those?
Yeah, that's a great question. And yeah, it was kind of an offhand remark because you do think of like your doctor coming in, kind of swirling in like, okay, by the way, do you mind if I record this? And so what did you come in for today? And can be that really quick process. And I think something that can provide true consent or barriers that may exist for older adults is one, just I think time, that ability to find time for older adults to actually sit down and understand really what you're talking about. First of all, we already kind of, I think, addressed or settled that there's a bit of a lower understanding for older adults about AI beyond just like the colloquial understanding of AI in the world right now. So having, again, that education piece for understanding how will this be used, I think you address that perfectly, like that back end piece of like, yes, I think recording, we all agree, like that ability to take notes and make sure everything is documented accurately, but then also being able to explain that barrier on the back end of where is this recording going. So kind of that education piece is the biggest barrier. And then the technology component, like if you're going to have a signed consent form for something like this, maybe it can be provided in a printable copy. Probably providing as many opportunities to opt in is the most helpful for accessibility purposes. Things that you would normally probably do for older adults that you're seeing in a care setting are the ways that you can kind of eliminate as many barriers as possible to understanding for this issue.
Mr. Harris.
Just a final comment and maybe remark just to kind of piggyback on the education piece. I think, and Representative Nealon mentioned this earlier with the internet, I don't think many people know how the internet works, but they don't ask questions about it anymore. And I think that's really attributed to trust. So I love the education component, but I also think there's a realistic variable that sets in. If it's going to take time, I think people will eventually get there, because I don't know if you can. I know technologists that don't know AI and all the inner workings of a neural network and all of this. So I love the education angle, but I almost challenge us to consider it's going to take time at the same time. And as long as we can build on the trust, reinforce the trust, eventually, I always say we get to the point where we stop talking about AI because it's just everywhere. It's just embedded in. But we are at the beginning of a blip here in a technology landscape that we've never seen before. So we're all kind of maneuvering at the same time. But I think it's a great point of how do you establish the trust and how do you build on the trust, especially with the aging population at the same time. So thank you.
Yeah, thank you.
Thank you. Any more, or shall we move on? Thank you very much for your testimony today.
Thank you.
Next, we are going to work with, hear from Aaron Fabrizia, Associate State Director of Advocacy, as well as Leslie Spencer, who is the Volunteer State President of AARP Wisconsin. Gals, we've heard some great stuff so far today. What can you contribute to other areas that we might not be thinking of?
Yeah, so thanks so much for the opportunity to testify before you today. I'm Erin Fabrizius. I'm an Associate State Director of Advocacy for AARP Wisconsin, and I'm joined by
Leslie Spencer Herrera, the Volunteer State President for Wisconsin.
So just a little bit about AARP Wisconsin before we jump in. We have about 750,000 members across the state, and our mission is to ensure that older adults, people 50 plus, get to choose how they live as they age. And so a big part of what we do, of course, is advocacy in the state capitol to kind of enact that mission. A big part of that is access to health care. But I did want to point out we do some on-the-ground programming in Wisconsin that actually helps promote health for older adults. So we offer driver safety courses. We have a great program called Walk with a Doc. Just now in Madison is new, and a long time in Milwaukee, where older adults can come and walk with a licensed physician, get some exercise, ask some health questions. We have a counterpart program in La Crosse called Walk with an Eagle. That is not bird watching. It is UW La Crosse student, so to promote some intergenerational connections. And then we do work across the state to ensure that communities are livable. All right, so AARP has engaged on policy debates related to AI in DC and across the country. Our advocacy on this issue is not limited just to healthcare. It includes broader consumer protections related to employment, fair housing laws, and of course, scam and fraud prevention. You've probably all heard a lot from us this session about fraud prevention. And so our guiding principle on AI policy is really twofold. So the first is we want to make sure older adults do receive the meaningful benefits of the innovations that AI can bring. But we also want to ensure that older adults are protected against potential pitfalls of AI. So AI as it relates to healthcare, we know there is significant potential to help older adults living independently as they age. We also think there are opportunities to reduce caregiver burdens and lower healthcare costs. So, right, rather than just issuing a reminder, AI agents can actively manage interconnected tasks that help older adults be safe and supported through things like health data monitoring, coordinating care, detecting early signs of disease or risk, and even potentially assisting with routine activities like bill paying, right? These things help older adults maintain independence. However, right, there's always a flip side. There are errors in medication management, there could be missed alerts or incorrect financial transactions that could have serious health or financial consequences for older adults. So these risks underscore why strong safeguards and oversight, as well as clear avenues for redress, are essential as AI becomes more entwined in the lives of older adults and all of us. All right, so we're going to be a little bit different from Emily's presentation to spice it up. So we really focused on what are older adult patients, what do they think about AI nationally and in Wisconsin. So really the most striking theme, AARP did a national scientific survey that came out in June 2026. And while we've heard from the American Medical Association that 81% of physicians are using AI, AARP nationally found that only 19% of adults 50 plus believe that their provider is using AI, and only 9% of adults 50 plus have had a provider explain to them that AI is being used in their care. So in that same national AARP survey that I mentioned, older adults were clear that they are comfortable with AI in healthcare. And the things that they told us they are specifically the most comfortable with is AI handling administrative tasks, so things like billing, documentation. 54% of older adults nationally said they were comfortable with that. And AI scribes, as Emily mentioned, showed up in the pit this season. 43% of older adults said that they're comfortable with their provider using an AI scribe. And we heard from almost 1 in 4 older adults that they themselves have personally used a generative AI tool in connection with their own healthcare. Kind of examples that came up where older adults have used AI to look up information about a diagnosis. They've done it to better understand or interpret what a healthcare provider told them during a medical visit. I think we all know sometimes those 15 minutes with your doctor might leave you with some questions and things you want to research afterwards. And then as well as some people use it to decide if a symptom warrants reaching out to a healthcare provider or seeking medical care. So while older adults are comfortable with AI being involved in their healthcare, they have concerns and they want to see some clear safeguards in place. So 65% of older adults nationally told AARP they're concerned that their provider may rely on AI more than their medical training. 68% were concerned about their personal health information. That was a big theme that's already come up a couple times today. And 90% were clear they want to be informed when AI is used in their healthcare. I know I'll get a question from you about this, Representative Nalen. And 82% want to make sure that the provider is making that final decision when it comes to their diagnosis and treatment. And now I'm going to turn it over to Leslie to talk about what we heard from Wisconsin AARP members specifically.
So good afternoon again. My name is Leslie Spencer-Herrera, and thank you so much for having us here. And I feel really privileged to talk on behalf of many of us Wisconsinites who are over 50. And, you know, we're here. ARP is the voice of those of us who are aging, whether we're 50 or 100, you know, and that's a broad expanse of generations of aging with different, as already some of you have alluded, cognition and health issues. So we're trying to speak for all of us. Again, the perception and reality of dealing with AI in this already very complicated aging healthcare Wisconsin environment. So I became involved with ARP because of their ability and voice in speaking for those of us over 50 years of age. I also know all of you have much more expertise. We looked up, who you were, your backgrounds, your abilities, skills. So you know about our expectations, our needs, and the services that you've provided in your various roles. The other thing you know is as we age, and I certainly have seen that in my friends, my family, myself, as you age, more things happen to you, and you end up visiting healthcare providers and more complex healthcare, more, you get up that pyramid of healthcare much more. And so overall, this is a huge concern for those of us over 50. So I'm very grateful to share with you this information we gathered here in Wisconsin. It was not a scientific survey. We didn't have much time to get the official, random sample, this and that. We just asked members if they had thoughts to please complete the survey. So it's totally unscientific. But what you see here, and we have the word, slide in front of you, what really matters to people. And you heard it already in the previous discussion: human oversight, privacy, care of trust. And so that is really important. And then moving on to...
Yes, sorry, just interrupt. Yeah, we heard back from 521 Wisconsinites, and yes, this beautiful word cloud, which was made by Copilot, is kind of a lot of the things that came up.
See, I didn't know it was made by Copilot. I was not informed of that. But anyway.
I'm informed now.
Right. And so at any rate, what the perceived benefits, people understand, healthcare is expensive and getting more expensive. So maybe, this can help cut costs, increase efficiencies, get more accurate diagnoses. We read what's out there with the studies and what can happen, faster diagnoses. I know myself, I've read the studies about radiology, x-rays being read quicker. And it then also provides more time for the provider to really speak to you. In fact, I spoke to a friend about coming here today, and she said, yeah, last time I was in, the doctor came in and said, I'm recording this for my AI. And the whole time she looked at me in my eyes because she wasn't busy in putting stuff into a computer. So that was great. So we understand the advantages. However, we also do have concerns. And again, I think you heard already the same themes earlier, that we perceive is very difficult to challenge AI coverage, 81% of folks. So how can you argue against this black box, which is really what AI is perceived to be? I mean, and like you said, even technologists don't understand the generative model. So how can we, humble citizens, healthcare utilizers, feel we can contest that? Maybe AI will be seen as the dominant force over doctors, and the doctor will take that shortcut. I mean, doctors are being asked to see more patients in less amount of time. So that's, again, a very high number, 84%. AI mistakes could affect care. I mean, those of us who read some about AI, of which I count myself, understand that studies have shown different AI agents have biases, confirmation biases, different, so how are we going to account for those, balance those out? And then key, I know for me, is personal health information is not secure. We've come so far with HIPAA, and now, is that going to go away? Is our data going to be sold? I mean, I see a scenario where, it's found out, Mary has diabetes, so now to the highest bidder goes, Mary has diabetes, and all the drug providing companies for diabetes care are saying, hey, come by, or ask your doctor to give us our pill. So what we want you to know, policymakers, policy suggesters, is that it should not be used as a tool. It should not be the final determination. This is someone from Chippewa County telling us this. We have the, quote, huge concern that AI will be used to determine the most profitable care or lack thereof based on age and profit margins rather than the patient's desires. Someone in Waukesha County told us that. Mark, I do not want computers denying my care or my family's care. Sue in Milwaukee County. High penalties must be levied for unintentional release of personal data. Mark in Pierce County. AI should only be used as a reference entity, not in any final decision making. Robert in Marathon County. And make sure patients understand when and why it's being used. Jeanne back in Milwaukee County. So we've covered the state here, and I'm sure it's just the teeniest top of the iceberg.
Yeah, and so now that we've talked about kind of what older adults think are the potential benefits and potential pitfalls of AI, let's talk about ensuring that we can meet those twofold goals I talked about at the beginning, that older adults are benefiting from the innovations of AI while being protected from those potential pitfalls. So AARP's recommendations are informed by our guiding principles, which were closely mirrored by the feedback that we heard from older adults nationally and here in Wisconsin. So AARP, we believe that public policy related to the use of AI in healthcare should really focus on three key pillars. The first is fairness. We want to make sure that AI tools are fair, reliable, and accurate without disparate impacts on different groups of people. We want transparency. There should be transparency when an AI tool is used, including an explanation about the results. And finally, we want to make sure there's accountability. We need to see fair and meaningful processes to allow individuals to challenge adverse incomes, right? Like maybe a prior authorization denial, to ensure that there is accountability in the healthcare system. And we do believe, I think Emily mentioned this in her presentation as well, that a qualified third party should be required to evaluate AI tools used to inform consequential decisions within healthcare for reliability, accuracy, and fairness before they are deployed. And I do, not to go back to the WISER model, but AARP nationally does have concerns about the rollout of the WISER pilot program. We do actually think that this is a good example of potential patient impact to be aware of. So the WISER pilot, as Emily mentioned, was rolled out in 6 states. And it specifically looks at prior authorization for 13 services in original Medicare. And this pilot, for the first time, introduced prior authorization to original Medicare. The things that AARP nationally has communicated to policymakers about as concerns is that, yes, while there is a doctor that can override an adverse decision, there is some incentivizing for AI vendors to generate savings, which we feel could create a clear incentive to deny care. And we have heard anecdotally from older adults across the country in those 6 pilot states telling us that this rollout has been challenging. So we've heard from older adults that their treatments are being denied, that urgent care has been delayed, and they're spending hours in a car or weeks on a waiting list to receive procedures that their doctor already ordered. There was a great, Kaiser Health News did a great story on the rollout that I'd be happy to pass on that also has some specific stories of things that have happened. And so ultimately, right, we want to make sure that seniors don't need a permission slip from AI, or also we have feelings about prior auth generally, but definitely don't want people to need to get a permission slip from AI to access services their doctor ordered. So I would leave you with specific recommendations that do look a lot like Emily's probably, but we want to make sure that as you talk about this issue in the coming months, and there are, like, right, this is a thorny issue. I think there's a lot to grapple with here for all of you, but we think that Wisconsin patients deserve legislation that will protect them against improper AI-based coverage denials. We want to make sure that there is a required notice and explanation to patients to ensure transparency around the use of AI, and that's consistent with what older adults told us nationally. 9 in 10 older adults in that national survey said they want transparency. We want to make sure there is third-party evaluation for AI healthcare tools to ensure they're accurate, reliable, and fair before deployment. We need to make sure that there are safeguards against incorrect AI-informed diagnoses. So we specifically believe that providers should continue to be medically liable, even in a situation where AI informed a diagnosis. And we need to preserve and require human decision making, so keeping a human in the loop at all stages. We believe that doctors and licensed clinicians should remain final decision makers. And finally, really making sure that consumers have and retain the ability to contest and appeal AI-informed coverage decisions. Key takeaways, which I won't repeat, but thank you so much for your time. I do want to make you aware that AARP's Consumer Pulse series, which is like our national research arm, is doing a lot of study and reports on AI in healthcare. So 2 are out already, one on AI-powered healthcare tools, and the second about AI in your doctor's room. And that was what a lot of our national data that I provided came from. There are 2 more coming out in the next few months, one on AI and caregivers, which I'm very excited to see the results of, and AI and patient safety. So I will be happy to pass those along as they come out. Thanks again for the time. We're excited to be part of this important conversation. And thank you, Chair Cabral Guevara, for making sure that patient voices were included in the conversation today. And we're here to assist in any way throughout the process.
Thank you much for your presentation today and your insight for your organization. I think I've seen a parallel of some themes here from you but that's important. The repetition of that is important because it seems to be a key factor that many people are thinking about. And to Representative Neelan's point here, is this something that we should be concerned about, or is this something we shouldn't be concerned about, or is it initial concern because this is fairly new to individuals? Will it be concern over time? I'm not sure. Questions or comments we have for these gals today for AARP? Anything that anybody has? Representative Neelan.
Well, Aaron, I had to, I guess, huh?
Yes.
I always enjoy working with you.
Same here.
So I guess you alluded to it, so I might as well, right? So if the data shows that, like, there's, you know, your organization does necessarily see it as like a way to save money and costs and streamlining, and then, but then you say only 53% would say they want to use it, or as a scribe, right? As a scribe.
Are comfortable with using scribes. Yep.
But then when they're then 90% though say they don't want it at all, right?
90% is they want informed consent.
Right.
They want to be told.
So the 90% they want to be informed, then you're going to lose 40%, right? That'll be like, nah, we don't want to. And I just worry, like, again, to the point, like, we just have to be careful where we put in law versus best practice that's already happening, right? We have to identify the difference between what we need to put in law now, and if there's best practice happening that we want to, like, put into law, maybe, but I think in the future it's going to be, like, outdated and archaic, and we're going to have to go back and clean it up. And you see that, right? I mean, we used to have a law that gas stations had to have payphones. At every gas station, there had to be a payphone. That was a law in Wisconsin. And we had to go back and, like, fix that. So you can, right?
Yeah.
But, like, I worry about, like, putting all these laws on the books that are going to look silly, that are like, hey, this is making our job harder because we're, like, trying to cater. And in reality, like, your group probably would like it. It's just we got to get the education out there. And then, so that's where we just need to be careful in terms of, I think, the earlier points, just like what we put in law versus, like, what we're considering, what's best practice. And, like, I look forward to working with you on what that looks like.
Ditto. And can I take a crack at I'll take a crack at that. Okay. Well, I think right for me, right. So the 90% nationally in the scientific survey, 90% of folks said they want that informed consent. I think for us, right, informed consent's a really important principle in our healthcare system. And so we do think that people, if they do want to opt out, and then it's just those 54% using the AI scribe, I think that is probably their healthcare right at this point. But I totally hear what you're saying. And just to bring it back to HBO's The Pit, where we started with Emily, I think in that storyline, Dr. Al-Hashimi was really promoting that the intern should be using the AI scribe, and then Dr. Santos was over-relying on it, and there were mistakes in her charting. And so I think about for myself as a patient, I think if I do initially, right, in these nascent days of AI, I am kind of skeptical about errors. I think for me as a patient, if I get that informed consent, I'm going to make sure I look at my doctor's notes afterwards and make sure they accurately kind of summarize what I brought up as concerns or symptoms. So I think for me, it kind of comes back to informed consent and making sure people are flagged right now. So maybe in the future, no one cares and we can clean up the books. But I think for now, people are telling us our position is informed by what patients are saying, and they want that informed consent. So,
and I guess I would like to add my experience too is that this is a new technology, and Aaron and I were talking about it on the way here. Autos were new technologies. There were no rules of the road. You could go whatever speed the highest your car could go, or no stop signs, and you could drink ever much as you wanted, and rules have evolved. Some have gone away, some have come in. I think where we're at right now, because this is such a new thing, and it is, and we admit it, and the whole drive of AI is that it is in theory, self-learning, self-improving, self-educating. I know from my usage, I've seen about 80% things I consider correct in any document I've prepared or written or read, and then 15 that's kind of weird wording or something, and 5% that's just wrong. And when it counts for your health care, that 5% could be your life or quality of life. And we do have generations, we do have thinking of my mom, your mom, friends in my 80s. And that's where we rely on other things like having power of medical care surrogates who can help and go there with visits. I mean, I've done that so often with friends, sat in doctors' offices, and maybe then we talk together about the use of AI or not and review the document. But we need to have some form for the healthcare provider to understand they need to take the time and listen. So if I find that 5% error in that transcribed document, that means, oh my gosh, now I can't get that medication that might cost $1,500 a month, but means my life, that I can submit a correction and the powers that be will listen to me. I think that's the fear, is that once AI rules, it's a ruling.
Yes, please.
That's very, very good answer. I appreciate that. I think that when it comes to like disclosure and like best practice, again, just to not to get too into the weeds here, but like we could currently, there's nothing to stop DHS or somebody in the state from issuing guidance to physicians that they would say, when you are using AI or when you're transcribing, just please disclose it to the patient. And most practitioners will follow guidance, right? We don't need to come up with like a criminal penalty or like come up with like punishment for not following disclosure. I mean, in most cases, and I think I tried to make the point earlier, like a lot of times people don't follow it, and the bad actors, there's nothing anybody does about it, quite frankly, because like what's gonna happen if a doctor just doesn't do it? Like, who's gonna prosecute them, right? So now we're giving all the good actors just an additional thing, like, and then the people they're gonna be like, well, why did you say that? And they'll be like, oh, well, it's state law that I had to tell you I'm gonna use it. They'll be like, well, don't do it then. Like, that's scary right there. Like, so I think it's like shooting ourselves in the foot, like looking for a problem to solve here. In some ways, on this specific, not the whole topic, but just in the specific space of how doctors or how providers are spending their time. So I worry about some of the unintended consequences of actually doing law in places where we could just have guidance from experts that are informed by like best practice.
Thank you. Representative Baer.
Thank you, Madam Chair. I appreciate the presentation, and I'm a firm believer in the wisdom of our elders, and so I appreciate the quotes. And I was asking myself about those quotes, are these all reasonable? And I think the answer for me was yes. And to get to what my Assembly colleague Rep. Nealon's, I think, getting to is a skepticism, correct me if I'm wrong, a skepticism of the regulation. But I think what you're sharing is the patient skepticism of the tool and the technology and the treatment and the experience of walking into a care setting or dealing with an insurer where this thing is applied. And so, I think what I saw was all reasonable requests and reasonable thoughts about that experience. And you also shared, I think, a really interesting and useful set of principles, the fairness, transparency, and accountability that Mr. David Staus had sort of talked through earlier or touched on. He sort of recommended that we think about principle-based regulation instead of looking at the specifics and the technology, which I think is also an interesting way to think about this in terms of how this technology might evolve going down the road, that if we set up parameters that are based on principles like these, we may not have to come back so often to correct the phone booth at the gas station problem. So, I think you've sort of connected a dot there that I was curious about and skeptical myself about principles rather than going after the specifics, but I think that really sort of helped get me there. So the question then is actually about a specific. Sorry, contradict there. One of your specifics was about AI-informed diagnoses, and I'm sort of curious about AI-informed treatments or recommendations for treatments, if that same principle applies there as well, diagnoses and treatment recommendations, prescriptions.
Right, definitely, yes. Siri.
She's been here with us all the time.
Diagnose that.
Yeah, so right, that was on the safeguards against incorrect AI-informed diagnoses. So yes, diagnoses, treatment, right. I think the main point there is this question now, right? Like if an AI agent informs the decision of the provider, like the AI bot didn't take the Hippocratic oath and they probably don't have med mal insurance, right? So I think the point is that the medical provider should continue to answer the question of who retains liability if an AI-informed diagnosis, treatment, whatever, causes harm.
Right, okay. I think you also just got into another sort of interesting, or triggered for me an interesting point about, you keep doing this, about sort of disclosure versus consent.
Right.
And if what you're experiencing or what's about to happen is a treatment, a shot in the arm, I would suggest that most people would want there to be consent for that shot to go in your arm. That's certainly the public discourse these days. And not just disclosure of, hey, I'm about to shoot you in the arm with something. So I think this is where the definition, I think, gets very important about what is the thing that we are doing to you or with you when you walk through the door. So that definition, I think, is something we really have to answer to really get to the question of, is the regulation something that is useful in this place or not?
Yes.
All right, well, got myself thinking. I hope that helps Rep. Nealon as well about...
He's a great skeptic. I appreciate Representative Nealon because he's a great skeptic, and I'm a skeptic as well. So.
But back to the earlier discussion, education, I mean, I was an educator, an adult educator, education's key. And, ARP does a great job of that, too, through our various publications and all the things. We work hard at educating people, like what are the signs of heart attack in a way people can understand, or this is what this medication does or doesn't. So we would be in that battle of clarifying, educating. We are, as Erin already says, trying to educate folks and understanding, too, that different people are going to be at different places on that road. So maybe for some folks, saying, well, gosh, you get overwhelmed by your doctor and these things, be sure and bring a friend or your daughter or your niece, or something along with you and have them read up for you, And for the younger folks who are very computer literate, okay, here's what you're dealing with and here's how you can... here's alternate methods. You could research it, because we know not all AIs give you the same answer. I mean, that's in a way the scary thing. I mean, yes and no, but so that's, back to education.
Right, yeah. Thank you.
Thank you. I think we have one more, Mr. Fung.
Just a couple of comments. So
Yeah.
one thing is, thank you for sharing first. And one thing is like, on all these processes, when we're afraid that AI is going to make mistakes, it's good to know the baseline, the human baseline for mistakes, right? Because the assumption here is probably humans don't make mistakes when they do these things, and I bet you that they do. So there are studies out there where, depending on the workflow, AI can make less mistakes than humans, or the combination of human plus AI reduce the number of mistakes. So just a comment there, right? So I think some of these decisions and all these, the way we think about those things, it should be driven by data too. Do we know what is the human baseline? What are we willing to live with? How we should regulate that, right? The other thing is, again, I think a lot of people comment about this is about information and being able to educate, right? But one other thing is most of these frontier models are PHI compliant. So you can use a model of these things, and if you have the right contract with the right company, they give you PHI certification. So they're HIPAA compliant, right? The other thing is there are different ways to host them. Again, that's one. You can also have contract with them, zero retention policy, that whatever it goes is inside your firewalls, where you have the model deployed, and they keep zero data. So things that probably people knew that, they were less worried about it, and it also depends on people, implement these things as well, right? Because not everybody's doing that. That's the other point, right? Yeah.
Definitely, and I was just at NCSL a couple weeks ago, and that we heard from the godfather of AI, who is a Nobel laureate, and he, just in this vein, you made me think of a great quote that he said that stuck with me, where AI is like this fast-moving car, and regulations are not like brakes. Regulations, in this case, are the steering wheel to make sure it's going where we need to go, which I think you kind of highlighted that. Like, there are best practices and things that we can do to protect people's data.
If we have no other comments or questions. Oh, we got one more here. Thank you. Mr. Blair.
Just one quick comment, because I think one of the things that stood out to me in the presentation is that 1 out of 4, it was close to 1 out of 4 individuals is utilizing generative AI. I thought that was pretty interesting too, because one of the things that I think, along with education and guardrails, is very, very important. But I think as a piece of that education, recognizing the impact that could have. Me utilizing generative AI to self-diagnose myself is a flawed system, because I'm going to end up with some rare disease.
Probably,
that, I most certainly do not have, but I am not a physician, nor can I diagnose that information. But if I have the ability to give that tool to somebody who is a physician and can utilize that information to take their already baseline understanding of things and extrapolate that, that's a big piece of the education too, where, nowadays you talked about physicians and how they're rushed from one patient to the next. How much time do they really have to actually sit down, diagnose, and treat a patient? It's less and less. And so if there's a system or tool out there, when used properly, that can make that relationship better. Even you spoke to, like, I actually got to talk to my doctor because they weren't just transcribing the whole time. And when a system can catch things like, hey, I just came into the urgent care, and because the system is sweeping and it can see that I'm about to prescribe a medication that's going to have an unintended consequence with something that I was unaware the patient had because I'm not their primary care physician. Those things, I think, are important pieces of education to say, like, we understand the downfalls, but we really need to recognize the windfalls that can happen as well with proper guardrails. Because again, you give me AI, I self-diagnose, not a great tool. You give a physician AI and you allow them to use that, it can extrapolate that much better than I can.
Yeah, absolutely. I would say over the weekend I was with my family, and my cousin Carl is a pediatrician. He's a physician in Minnesota, and I was talking about doing this presentation, and we were kind of talking through, and he's like, yeah, right now I will sometimes use ChatGPT if I know I have maybe a complex case coming in where I'll be just like, what should I do? And it will give me ideas. I'm like, oh yeah, I wasn't thinking that maybe I should order that test. So just to and your point, where yes, my physician in my life has used it to kind of make sure to test their decision making. But right, me as a patient with severe anxiety using ChatGPT probably is not going to be great for me. But yeah, so completely agree. And that's why we have that twofold principle, right? Like, we want people to reap the benefits of the innovation, but making sure we're keeping people safe and secure.
And maybe speaking for those of us over 50, we're not technology abhorrent, I guess is what I want you to walk away with this too, because I think there is a stereotype that many of us, once, particularly we retire, is like our mind's retired and, technology. And I'm not a digital native, but, as neither many people my age. We're going to start getting digital natives almost, and now the new 50-year-olds, So, yes, things are going to change some, but they still will have that skepticism, I think. Some, maybe not an automatic no, but, and so we are not here to say, oh, no wheels in this bus, where we understand the need for technology. We use computers. Many of us use AI. So,
Thank you.
Thank you.
If we have no other comments, then we will move on with our last speaker today. We are going to hear lastly from the Executive Director of NAMI in Wisconsin, Mary Kay Battaglia.
I want to do a seventh inning stretch. Stand up. Thank you.
Thank you very much for speaking on behalf of NAMI today. We've heard a little bit about chatbots, so I'm sure you're probably going to bring that up.
I am. I thank you so much to Emily and Aaron and Leslie. It was great. We should all gather as nonprofits and have a conversation about this, because I don't think we cross-talk about AI enough, so that was great hearing from them. I appreciate it. So I'm Mary Kay Battaglia. I'm the Executive Director at NAMI Wisconsin. Can't do a presentation without an ad of who we are, right? We're the National Alliance on Mental Illness. I'm from the state office. This is a map of all of the affiliates we have throughout the state. Those affiliates provide support groups and classes and advocacy in their community for people living with a mental illness and their families and caregivers who love the person that lives with a mental illness. We have a national office in D.C. I'm in the state office, and you can see the affiliates across the state. The trivia that I always share with everyone every time I do this is that National Alliance of Mental Illness was started and based right here in Madison, Wisconsin, almost 50 years ago. We're at 47 years, so we can be proud of that. So I'm just going to start off with, this conversation is going to be a little bit different because the way AI and mental health interact is a little bit different than the clinical setting that we've been talking about. NAMI National is talking a lot about AI and mental health, and we are concerned about some of the issues and also excited about some of them. And we've teamed up with Dr. John Torres from a digital psychiatry at Beth Israel Deaconess Medical Center, is at Harvard Medical School Teaching Hospital. We're collaborating with them to help people understand how different AI tools respond when asked about mental health. Dr. Torres is the premier expert on mental health and AI. He's a psychiatrist who's been working in this area. If you look at up, his name's almost on every paper that intersects AI and mental health. And I've had several meetings and participated in many discussions, and I will just tell you, I am not the expert, but I'm here to share with you what I've learned from him, as well as what we're doing and some of the concerns and things that would be positive about AI and mental health. So what Dr. Torres is working on is a project called MindBench AI. And the goal of this is to track and evaluate large language models to develop benchmarks. You're going to hear a lot about benchmarks. Guardrails and benchmarks seem to be the terms that are used a lot in mental health and AI, right? To help people better understand how we're using these tools in mental health responses. And the early phase of this project, they're looking at, and this, when you were talking about maybe not specific regulations, but more kind of guardrails and overall arching, is what is the safety and crisis response in these tools, whether the tools recognize when someone is in distress and offer appropriate safe next steps, the accuracy and quality of the information, whether the responses are factually correct, consistent evidence, and then the cultural relevance. And this is just the first phase of it. They're utilizing NAMI in a way that collaborating with us, but also asking a lot of our peers and families about their use of AI and their mental health. One of the biggest challenges I heard earlier, the man that was discussing AI and legislation, was one of the challenges in identifying the benchmarks is actually defining what AI means in the mental health world. What is AI in mental health? It seems to be defined differently by the people utilizing it, scientists that are studying it, and companies that are creating it. So what is mental health in AI? There's also difficulty in defining the use of AI in mental health. I mean, we heard about, which was great, that AARP, about a fourth of the folks are using AI, but we're trying to identify who's using AI for their mental health, which is different, because I tried to reach out to our peer leadership council, find out somebody that would join me here today, and all of them said, oh yeah, I use AI in my work and my life, but I don't use it for my mental health. So that's a different question, is are you using AI as a part of your mental health? Dr. Torres and his team have looked over about 66 studies that discuss this, how many people are using it, and it is a broad range. And also, it's a fast-moving topic. You can ask somebody 2 years ago, and it would be 3%. You ask them now, and they're predicting it somewhere around 25 to 27% of people are using AI as a part of their mental health. And most of the tools we're talking about are chatbots and apps. And the areas that it is looking at is mental health, simulated therapy, so that would be counseling, treatment, access, and diagnosis, emotional support, and this is the area that we see the most of people utilizing it, is companionship and reassurance and empathy. And I just want to emphasize, I think one of the reasons we see such a high rate in that area of it being utilized for mental health is the U.S. Surgeon General in 2023 put out a whole paper on a whole report discussing the current crisis of isolation and loneliness. And a lot of people are utilizing AI products for feeling, not feeling so isolated and lonely. And ironically, it does then increase the amount of loneliness and isolation you have, because then you're not socializing. So it solves a problem, creates more of a problem, right? And then a lot of wellness support is used for mental health, physical wellness, meditation, exercises, social coaching. Think of the app Calm. People have a hard time getting to sleep. There's an app you can go to. It helps you. It has all sorts of avenues to help you feel calmer, and that's one of the ways that it is utilized. So for the next few slides, I'm just going to talk about our concerns. Y'all have heard a lot about it, but I'm going to hit some different concerns for us. I think earlier today it was brought up about a young man in Florida who had died by suicide using a chat box, but this was from a couple of years ago. New York Times did a whole article about a young man whose family is suing the chat box company. He had a companion chatbot friend, and when he told this chatbot at that time about his suicidal thoughts, instead of saying, well, you really should, perhaps get therapy or call 988, what it did is started looking up ways to kill yourself and ways to execute that, and reinforcing what he was thinking and saying. And I'm going to get to why that's something that's concerning. Another is you can see the example here of somebody on a chat box, and the chat box claims that, yes, I am a licensed therapist. Here's my license number. So it is putting those sort of things out. These are products from Dr. Torres, so this is not me. This is him putting this. This is a slide that he shares. So the concerns included in these, I'm going to highlight why these are concerns, the common errors. They use the term hallucinations. Somebody that works for a mental health organization is not thrilled that that's the way they use this. But so they use this term hallucinations in AI, and it's that it makes things up. It doesn't know the answer. It confabulates and makes things up. So that's kind of concerning, that you're talking to a chatbot and it's your friend and you're using it for therapy and it makes something up. So that's not a great thing. The overconfidence of stating uncertain information as a fact. Oh yeah, that's true. The one that I have the greatest concern about in the mental health world when people are using chatbots for therapy or companionship is it agrees too easily, and it's actually set up to agree with you because it wants you to come back to it. It likes you. It wants you to like him, her, it, whatever. And so I'm just going to give a few examples. People living with a mental illness are, say, paranoid that their neighbors are harming them or watching them or whatever, and you tell the chat box that, and then it agrees with you. Oh, yeah, that's probably going on. I can see where you're doing that, right? And then it reinforces that paranoia, which is not a healthy place for you to be in because it's a paranoia. A psychosis. Somebody's thinking that there's, the FBI's haunting them or there's somebody in their TV, right? So if you're telling the chatbot this, it will reinforce that because its goal and its intent is to keep you happy and keep you going. So those are negative things that is somebody living with a mental illness. And I'm also just going to share a personal story, and it's I have a relative who was going through a divorce, going through a real depression, and didn't go seek a therapist, became very close to a chatbot, which that person's parents didn't understand what that was, what is a chatbot, because they kept identifying as a name. And he was depressed, and here's where it got kind of weird because it affected his financial and his ability to maintain his daughter, relationship with his daughter, is he would tell the chatbot all the things he was upset about in the divorce with his, ex. And of course, the chatbot reinforced everything he had the view of, right? I'm mad at this person because of this, blah, blah, blah. And it reinforced that. So he made a lot of unwise decisions because he believed that the chat box knew more because it's a computer and it knows more than anybody else knows more. And so it just reinforced his feelings, and that it didn't affect his financial outcome of that divorce and his ability to see his child. So, that was kind of a negative thing that I saw, that he was using a chat box, that it's that ability for it to agree with you constantly and not step back and have a viewpoint. If he was talking to a friend or a relative, they might have said something a little more, well, I see your point there, but, and if it doesn't ever say the but, or let's think of another angle, then you're always going to have that negative viewpoint. And also the inconsistencies. You ask it something and it can give you different answers. And to your point, yes, I call the IRS and I get 2 different answers from a human on the same question. So yes, humans do that too, but chatbots do as well. So those are some of the common errors that are concerning. Obviously, we've all talked about the privacy issue. It's kind of a clear thing. One of the things that I want to emphasize for mental health, though, on that is getting your diagnosis put out there in the cloud or wherever it goes. Like it or not, mental illnesses are discriminated against, and having that information out there as a diagnosis can be concerning. So I'm not going to spend much time on this because I feel like y'all spent a lot of time talking about privacy and revealing information. And so now I'm going to talk about a couple of the positive things. Dr. Torres gave a testimony at the U.S. House of Representatives, and he stated, "You can imagine there's a world where we can actually build new therapy treatments. We have this whole new world of personal insight that can drive personalized treatments." And it is an opportunity to use AI to help personalize treatment, because it doesn't matter if Bob is depressed and Sally's depressed. Their depressions are very different, and maybe the response and therapy you give them would be different. And you could tailorize it to their specific needs. But it is, however, hinges on good, safe, regulated, and a trustworthy AI chatbot or AI system. The other thing is psychologists are using, and I'm going to skip a slide because I put them in the wrong order. Psychologists are using AI to assist their work. This was done by the APA, I believe it's last year or this year, 2025. And you can see that it lists 2024 and 2025, and look in 1 year's time, especially that bottom data. How many more are using it just in that year's time, using AI as a part of their therapy sessions, a part of their, assisting them with caring for, their patients. So it is coming. It is something that's being used. Y'all have talked a lot about recording those sessions, not recording those sessions and whatnot, but it is here and it is being used, and it can be an efficient way to help psychologists and psychiatrists work through seeing patients, because they do see patients for a much longer time than a lot of other clinical settings, right? They're usually 45 to 50-minute sessions. And so that is something that's positive. So I'm just going to hit kind of overall the thoughts, and someone earlier had asked, and I know the APA just likes to remind everyone, there's currently not an AI tool that does have FDA approval or clearance. But the pros and cons, obviously, and I just want to point out the interesting thing, the amazing thing about these pros is it kind of identifies all the current gaps and problems we have in the mental health system. Right? It's addressing a lot of those gaps. So accessibility. We in our state have a big swath of the northern part of the state that have very few mental health providers. So it's accessible at rural communities, it's accessible at home, it's accessible to work. It's convenient, it's there when you need it, it's affordable. There's no insurance parity on this. They're not going to turn you down because you only need 5 sessions to then suddenly be, cured of your depression. It's not in a network limitation. I hear all the time people go, they ask their insurance company for therapists in their network. They get the list. None of them have openings, or the next opening 6 months or 9 months away. So you don't have that limitation. There's no specializing. There's also a lot of psychiatrists and therapists who will not take this certain kind of patient or this certain kind of patient, or I'm at capacity and you're too difficult to work with. They're going to take everyone that comes to them. There's no judgment. Again, mental illness has a lot of stigma, and if you go in and share things, you're not going to get those facial response. You're not going to have to tell a human what you're feeling or thinking. It's not going to be a real person. It's going to be a computer or an AI bot. There's no time limit. You don't have that 50-minute clock behind you or limitation. And the pro that I see strongly at this is it could be a complementary intervention. NAMI Wisconsin has support groups. We consider our support groups complementary to the care that the person already receives. And so I can see that being very complementary. The cons are it can validate unhealthy thinking, as I talked about before, how it does validate your thinking, whether it's accurate or not. There's no current guardrails, guidelines, or standards. It may be inconsistent and inaccurate. It's not equipped to understand life-threatening situations. It's not equipped to refer to prescribers for medication. It raises privacy concerns. It may perpetuate loneliness. It does not navigate social interactions in a therapeutic alliance. One of the whole reasons you have a therapeutic alliance is to teach people how to manage and continue their job, continue their relationships, and continue to improve regulating their emotions. And the bots are not going to do that. They're not going to teach you how to regulate your emotions. They're going to reinforce and validate your emotions currently. It can't analyze basic mental status, for example, eye contact. Are you bathing? Do you smell? That is something that a therapist would, or a psychiatrist. Are you having tremors? Are you having verbal cues that you're, stuttering or speaking too fast or speaking in a different way? A bot's not going to pick up on that. And it's not required to follow any training standards, ethical codes, and have any supervision. So those are the pros and cons as I see them, or we see them. There is a difference between support and therapy. So support, which I think some of these can be great at, would be listening, emotional encouragement, sharing experiences, helping them. But therapy is typically a structured treatment. It's a clinical assessment. It's evidence-based intervention. It's ongoing monitoring and adjustments. And it has ethical and professional boundaries. This is the current map of mental health laws by states, legislators. And this is from 2025 in October, so of course this is dated already. But we know that there's a lot of regulations on mental health, and I've expressed a lot of my concerns about AI in the mental health world. It's here. We're not going to keep it from being here or utilizing it, and I think it's very hard to figure out how to regulate it, because what we're asking is regulations of how the companies provide guardrails, right? And so I don't know how a state organization, I'm being honest, I don't know how a state organization, a state legislator would regulate how a company provides that. And if someone says suicide, can we as a state require an AI bot to ask them to call 988 or find some other way than to lead them on the way to a way to take their life by suicide? Because that doesn't seem a healthy response. But can we as a state, a legislator, can y'all actually regulate that, right? So that's a challenging question. But I'm just going to leave you with, this is National NAMI's AI statement, which is, we believe that AI general purpose chatbots and other AI systems should not be used as a substitute for licensed mental health care providers, clinical diagnosis treatment plans, or crisis support, and that AI should include guardrails that ensure people seeking mental health support are directed to appropriate crisis and clinical resources. And that's all. Thank you.
Thank you. A couple thoughts here just on what you said. Can we regulate it? And then can we reinforce it? That's another question, right? So can we make people do something? Sure, but then who's going to be reinforcing it and making sure that it follows through? As somebody, skipping to another topic here, as somebody that has a sibling with schizophrenia, as AI has become more and more available, I struggle with that with my sibling, right? This individual has schizophrenia. And so I'm already trying to battle with him, telling him what celebrities are talking to him and not. And now I'm battling with telemed, right? This is a tough one, because you think telemed is so useful. Great, unless somebody is psychotic and now the computer is talking to them and trying to separate that. I know this is unique, right? But in those situations where somebody is having some sort of psychosis or not managed with their medications, I could see how this is an absolute nightmare in those specific situations. But then again, I can see how it could be so much more useful for the large majority of people that aren't battling those really severe mental health crises. But holy man, yeah, it's hard to battle it out and trying to clarify what's real or not in some situations with my sibling, right? And then to try to explain what a chatbot is to somebody who's actively psychotic.
Right.
It's
so
a losing battle.
It's not real. Yeah, no, it is. And I appreciate that. I too have family members with schizophrenia, and thinking about how to, the whole thing of when you respond by telling them, no, that's not really there. Of course, that's not helpful, because in their mind, it's really there, right? And so it's very difficult, but it also doesn't help and lead them to poor decisions that affect them. And I don't know. I would hope that those that create this, I know since several of those cases have come out about folks talking about suicide and then it leading there. I know several of them have had meetings about that and discussed it, and they've added some guardrails, but I'm not sure how much. I'm not sure how much it's beta tested or regulate. There's no regulation, right? It's kind of like telehealth, quite frankly. When telehealth first came out, I mean, obviously we want it, but is the person licensed? Are they licensed in our state? Who's going to monitor that? It was kind of the wild, wild west at the beginning, because it was like, it seemed like a great idea. And I will say, just as legislators, there was a bill put forth for school-based mental health that was an online product. And when I looked at that online product, I was quite concerned, because, yeah, telehealth for students in the northern part of Wisconsin that don't have access, that's great. But there was a lot of AI links on that software that I was very concerned about. And who's going to, are we going to fund something like that? And y'all didn't pass it, so I'm glad, and I'm probably talking up. But these are things that I think are very important that we think about. We have a problem. We don't have enough caregivers in the northern part of the state, well, most of the state, and we definitely don't have enough child psychiatrists in our state. How are we going to solve that? And by just throwing money to an AI company or a software company is not, to me, always the best solution to the problem.
Thank you for that comment. I had similar thoughts. Yeah. Thank you. Other questions or concerns that we can address to NAMI? Dr. Bogey.
Bogey, yeah.
Oh, yeah, I got
if
it.
If it helps, people can just call me Justin.
Okay.
I'm not treating anybody in here. And I think we have some mental health providers on the committee. Yeah, okay. So if I go offline, you guys correct me. But my read of the current healthcare evidence-based medicine information is, and I think cognitive behavioral therapy's got has a lot of evidence it works, but that's the one that's the most studied. There's different types of therapies that therapists use. And they found that, in general, what they find is couple common denominators in people getting better from mental health is having a human therapist that they create rapport with, right? That's really important. And then you work out the problems. If you have those things, that's really what, that's your bang for your buck. And then you can quantify that. And I think all this healthcare, AI bots and everything is great, but I think we should focus in anytime we're talking about AI, like where the rubber meets the road. Where does it benefit? If this AI stuff helps rapport and supports therapists that have different ideas, because it doesn't seem to be cognitive behavioral therapy or processing therapy or some of these other therapies. They all kind of work as long as you have a good therapist who creates rapport with their patient. And I want AI to help with that and not, create more loneliness. Does that make sense? Did I articulate that? Okay.
And what you're referencing is the therapeutic alliance. That's what is the standard of therapy. If you're just talking about therapy, then there's psychiatrists who are also medically treating people with mental illnesses, which is a total different bucket. But the therapeutic alliance is building that relationship, and that's what I was saying is if a bot can't do anything but say, oh yeah, you're totally right, I totally agree with you, then how does it actually provide that therapeutic alliance? And also, how does it teach someone to navigate anxiety and stress in the workplace or at school or other places if it only agrees with their feelings and does not provide that therapy of insightfulness? So it's I don't know how a bot can be created to do that. I'm sure they will one day, but right now I'm a little concerned about it because it's affecting people that are using it right now.
Okay. I'm looking over at Senator Kiewski. I'm seeing if she has any questions. I know you're thinking.
I don't necessarily have any questions per se, but one of the things that it makes me think about is as a mental health provider, I mean, the relationship is in so many ways the healing component, right? And but I'm also always working myself out of a job, trying to help build the skills in the person so that, and boundaries are so important in that, right? So trying to be available but not so available, kind of, so that people have to self-regulate and use all of that. So it's just an interesting concept of how this can be probably a supplement indeed, and can be helpful, probably for those that are maybe, sort of having maybe an adjustment disorder, maybe kind of thing, where they maybe need just a couple breathing tips, some self-soothing skills or something. But like when you're doing any kind of like traumatic, deep, psychological work of treating somebody that needs to really heal, I just think about how, I don't know, it'll be interesting to see how, if this just sort of serves as something of a dependency creation more than a healing creation. I don't know.
Thank you. Mr. Blair?
I just wanted to make a comment.
Light, yep.
Philip, just wanted to make a quick comment. I think it was one of your bullet points. I forget the exact wording, but and kind of seeing a theme throughout all the discussions. It's supplement but not replace. If it can provide a supplement to great mental health providers, I think it's a tool worth pursuing. But if it's used as a replacement, I think we all are probably under some agreement that it can't directly replace that. So, as somebody that manages a self-funded health plan for a group of employees, I can tell you that access to mental health providers is very limited. We've engaged in a couple of direct contracts to make sure our employees have access to that on a quicker basis. And if there's a tool in which, like, hey, it may be a 9-month wait time before you can get in, but if that practitioner has some sort of tool that is directly connected to their care in some way to say, okay, we can see you in a week through this resource, and then if that tool is used as a supplement to make sure that that care is derived in a week as opposed to 9 months, I think there's value there. But I forget the exact bullet point, but it's been a reoccurring theme, and I just wanted to point out, if it's supplementing, it's great, but if it's used to replace, I think that's where the concern comes in.
Thank you very much. Mr. Harris.
Thank you. One thing that we use at Rogers Behavioral Health, and which is a national behavioral health player, full spectrum, is we often refer to AI as a member of the care team, but not the leader of the care team, which I think is a lot of what we're saying as far as supplementing. We want them to be there. They're valuable insight, but they're not leading the charge, right? They get a vote at the table, not weighted more than anyone else. We have a lot of pilots going on right now, which is just a lot of test cases that we're working on, and really kind of just working on a care companion model. Because our goal at the end of the day is to give you the skills to go off and work with the conditions you have, but not readmit. We don't want you to be back in the emergency room down the road, a week later because you didn't learn the skills or have an extension, a care companion, if you will. So I think your presentation was spot on, and I think it's our job to kind of figure out how to best take the technology, because I am a firm believer we will never be able to regulate the technology. That's not what we're here to do. It's just how to take that, drive the outcomes that we're after, and make sure the right guardrails are in place. I'm fully confident in this space we'll figure it out, but it's very different than prepping for a knee surgery or having an image read through a scan. It's just very, very different when you're dealing with human emotions and people that they want to feel better, and they want you to want them to feel better. And if you don't meet them where they are, they'll just leave, right? It's not like I have my knee surgery and I can't walk until I have the surgery. It's I will suffer until I feel like I am ready, and we feel that this technology can help embrace and enable a lot of that, but it's got to be done in a very thoughtful, mindful, ethical way at the end of the day, and I think that's what we're trying to solve.
Yes, and I think your point is, and I don't know what your pilots are at Rogers, but I know there's 1,000 apps right now out there to help people help regulate their stress, anxiety. It's they can be incredibly helpful if done well and right, and they could be tailored to that person, so that when you're going through that situation, you can go to that. So I totally get that, and I struggle with, I know the other organizations that talked to you had really strong presentation on what their suggestion is. I genuinely feel like I don't know what the suggestion is for a state legislator, and I do think television shows have statements, movies have ratings. We've done this before, right? We've been there before, and I know one state passed a law that social media, like students over 14 couldn't use social, under 14. I don't remember who it was, and I was like, how are you going to regulate that? Yes, we see the negatives to students, you overusing social media, but how do you actually regulate that? So I think y'all are in a difficult situation of how, I love it that you're talking about this and looking into it. And I think for the mental health, it is a different beast because people are utilizing it as a therapy as opposed to, the other ways that we were presented before. But I do think it makes it just a really scary for especially those with serious mental illness, with schizophrenia, bipolar disorder, or in paranoid state, that it can be a really scary option because it's out there. Yes, so I don't have any regulatory suggestions. I do know there's a lot of them, and I will spend a little more time looking at that as we go through, but I think it's a very difficult discussion of how do you regulate this.
Ms. Skoll. And then we'll get to you next, sir.
Thank you so much for your presentation. I thought Thank you so much. I thought your presentation was very helpful, and it really strikes me that your presentation was a little bit different information than we've heard earlier today. In a lot of today, we've been talking about how healthcare uses AI, and that's a piece of what you were talking about, but it's also about how the public is using AI for healthcare.
Right.
Even some chatbots or apps that were never intended to be, they're not marketed anyway as a wellness tool or a healthcare tool. I wonder if there's the safety considerations are different when a healthcare provider is recommending a evidence-based tool where there's been research studies versus the risks that come with, and how do you regulate how someone just uses a publicly available chatbot?
Right, and right now, that's what I was saying, is right now there is no tool that has been approved, social media, AI tool that's been, approved for such a thing. And, maybe that's the direction we, NAMI, as we work through this research study that we're doing right now, of really looking at the guardrails and what, is there, and I'm not supporting one or the other, but, maybe there is tools that would be more acceptable because it would have gone through all that screening and regulation. Yeah.
Thank you, Madam Chair. So, Mary, I really liked your presentation, and one of the slides I liked was the one that had the difference between support and therapy, and that was really helpful for me. So support being more around the listening and the validation, not feeling alone, but therapy is when you get into evidence-based interventions. It's part of that therapeutic alliance. And it kind of reminded me of the earlier discussion we had today around the definition of AI and how that sets a lot of the groundwork. And so when I think about this distinction between support and therapy, it seems like that's an important distinction to apply when thinking about recommendations. And I was wondering, where do you think this committee would get the most bang for the buck for where you apply that distinction? Should it be applied to like what an AI tool claims to do versus what an AI tool is actually doing, supportive therapy, or what a user believes that tool is doing, providing supportive therapy? So, you could take that distinction and apply it to like what the tool is claiming it's doing, what the tool says it actually does, or what the user thinks that it's doing. Where do you think is the most important
Well,
place?
I think if a tool is claiming that it is providing evidence-based therapy, that is not true. I think you could look at the ways that they are promoting themselves, advertising themselves. Is that really factual? Is that really true what they're providing? Are they just, they're providing support? They can say that, but can they really say that, they are providing true evidence-based therapy with a licensed therapist? Because if we're not going to regulate licensed therapists, then we have a whole nother bucket. It's kind of like the telehealth that was concerning, is like if we're going to have licensures in our state for people to be therapists in our state, are we going to allow a chatbot to say that they're a therapist and not have some sort of requirement that there's actually a therapist on the other line or the other chat or whatever it is?
Thank you. Dr. Justin.
One more quick comment. There is an evidence-based medicine medical app that's out there that physicians use, and I would recommend anyone who has a healthcare question to use this app. It's called Open Evidence. I don't know if they have one for mental health, but that would be a good one to model after, because it only goes to the data set of evidence-based medicine. And I think Aaron brought up a good point. When you use generic or AI, and you ask it a question, it goes, and it goes to all sorts of different data sources. When you use an AI that uses a system that uses just a group of data that it goes to every single time before it answers a question, you get a similar answer if you ask the question the same way, and you get an evidence-based answer. And, that would be something that would be nice for mental health. But there is an app that already exists.
Mm-hmm.
I'd recommend if anybody has any healthcare questions, don't use generic AI. The app is free. I have no stock in that app. But, I wish I did, but, the Journal American Medical Association and a couple of my colleagues at the Wisconsin Medical Society, we promote it, because at least it goes to a block of data that has already been screened and verified. Anyway.
It goes to the encyclopedia, right? Doesn't go to.
Yeah, I will vouch for that. But with that open evidence bit, don't you need an NPI for that? I think you need an NPI for it. I don't think it's open to the general public. Am I right? Or
You get 5 queries a day without an MPI.
oh, you can do 5 consults a day without an NPI. Is that what you said?
I think last we looked at it, if you don't have an MPI, you get 5 queries a day.
Okay, so you have, as long as you have less than 5 illnesses a day, you're fine on open evidence. It is a very good program, though, I will have to say. Yes. Thank you very much. Do we have anybody else? No. Okay. Well, thank you for your information, and we will definitely take these thoughts into consideration as we continue to pick along here. Appreciate it.
Thank you for the invitation.
Thank you. We have one section left here that I am just going to do as kind of a around the room bit. So today we kind of had patient advocacy groups here with us. Each meeting that we have, each day that we spend together, we will focus in on different areas. We have large healthcare systems, we have insurers covered, we have a pot of different individuals with each theme day. And what I'm going to ask of everybody is if you could provide 1 or 2 things based off of our conversation today. May that be an area you want to talk about more. May that be someone you think might be worth having come in and speak on a particular area. 1 or 2 bits of info that you feel we could dig a little bit deeper on or assist with for the group. So I will start as an example. So as I sat and listened today, one thing that stuck out to me, I mentioned earlier, is can I get the definitions from other states of what AI is to them? That's a good base for me. I might be on a different level of AI understanding than many of you in here, but I would like to know what are the other states looking at as a definition for AI and AI use, as well as other definitions that they have outlined in their legislation that they felt were important. The other thing that I think I would find very beneficial would be if there was a radiologist but preferably that actually uses AI, and I would like to know more in depth of what capacity they're using it in regards to diagnosing, in regards to reading of records, accuracy of that, and maybe even a well-versed physician or nurse, medical person of some sort. I'd like to go a little bit more in depth on how is that saving them money? Is it truly helping them with time management? And where does liability fall if there are concerns there? So that's 2 areas, along with everything else that we will hear, that are something of interest to me to put out there. Thank you. Thank you. Representative Nealon.
Thank you. So, 2 things. All right. So I would say if I had to narrow it down, and I don't know if this is exactly what you're asking for, I apologize if not, but the 2 major themes that I heard that maybe I would be interested in pursuing or people bringing ideas to the table would be like human interaction within the system. Like if you look at like the introduction and the bullet points and what people talked about, maybe everybody said it differently, but there was a constant theme of like a human being present, whether that's making decisions, whether that's like oversight, whether that's like tools to enhance their performance. Yeah. There was always some level of human interaction within the system. So how do we protect that? How do we like ensure that? And maybe if like there are some like guidelines or standards that says, oh, here, like in Wisconsin, we encourage AI, but there's always a human interaction involved within our health system. And there'd be more trust and more like faith in the system, or more be buying into these tools, or be more open to learning about it, or allowing doctors or providers to optimize or enhance their work. And the other one was the data privacy component. Like, how do we protect data? Right? How do we make sure that people feel good about? I mean, I do know that there's a lot of things being done already. Like we've heard in terms of like health providers and insurers that use their own AI systems. It's not like they're plugging it into ChatGPT, right? But maybe there's some level of standard we need to have at the state to say, oh, make sure you're using your own system, or it's not, or some sort of protection for the public good. So I would say, at least for today, those two things really stood out to me, was the data privacy component and the protecting the human interaction within the health system.
I'd just like to second that human interaction. I think that's where I was going with the radiologist and the physician, to kind of get that component of it, but he said it in a more wise way. So thank you. Representative Baer.
Yeah, thank you, Madam Chair. I'm sort of struck by, I think we should compliment ourselves because we're into sort of a new frontier. That was a word that was used early on, which is cool, but I think also presents some real challenges that we have to grapple with. I was sort of rewinding my political science brain back into more the philosophy and political theory realm of, we have regulations and statutes that are based on founding documents and then before that is Enlightenment and social contract, and we're dealing in this frontier realm that doesn't fit very neatly into what we have regulated and legislated in the past.
Yeah.
And that's really presenting, I think, some challenges. And so I was picking up some, not the specifics, I think, as much as the more broad, needing a definition, and needing a principles-based approach to this, that are looking for the specifics that are reasonable, but also focused on patient protection and protecting the interest of all the providers and players and insurers, whoever's in the systems, but making sure that it's durable too, and that might be the most challenging piece, and something that we might have to get kind of creative about. But sort of strikes me that a one-size-fits-all is not going to work, and a moment in time that we are in is also not enough, and we need to think bigger, broader, long-term, multi-dimensionally, perhaps, in how we approach this. So, got me in some rabbit holes, perhaps, but thinking real big.
Thank you very much. Senator Kiewiecki.
Thank you. I guess the mental health piece, of course, is just really fascinating to me, and wanting to be thoughtful about that. And I think one of the things that you sort of brought up, Representative Baer, was the idea between disclosure that we're using AI versus consent. Can we use AI? And that seems like a difference that needs to be kind of considered. And then the final thing to me is the piece of discrimination that we need to be careful about, and maybe actually can serve us well, that it can take out as you were talking about earlier, the reality is humans have a bias, and we make mistakes. And so is this something that we can also utilize in a way that takes that human bias a little bit away, and perhaps offers some protections of people that perhaps are not being well served because of biases or discriminations that we have as people? So I just think those are just some interesting questions to think about along the way.
Thank you. Ledge Counsel, do you need any further clarification on any of these, or are you going to speak up if there's anything you want clarified further? Yeah. Okay. I think we'll go around this way this time, if that's fine. Please, Dr. Huth.
Thank you, Madam Chair. This has been a wonderful set of conversations today, and I've really appreciated everyone's perspective. I want to come back to one thing Representative Barr said about perhaps focusing on developing principles rather than rules. This technology is changing so quickly, and it's gaining more capability, and I like the concept of trying to develop principles that will be a little longer lived than just a set of rules that might fix a problem of last year but not this year, because we don't know about the new problems yet. So I think trying to focus on principles that will help us set up those guardrails and reinforce the best practices and the best use of this so that it truly drives better safety, better outcomes, better value. And I was fascinated by our conversation about informed consent and what actually is informed consent, of course, relative to the use of AI. I think that's a really fascinating piece of this, and I'm still rolling that around. Truthfully, most patients don't realize how much their providers are already using AI when we're not in the exam room, and we really want to very quickly look and see what the best evidence says, but then we vet it and say, did this come from Facebook or did this come from the American Medical Association publications? And so I think it's being used right now, and clinicians are responsible for still making the medical decision and the recommendations. But I think in order for patients to really trust this more and more, I think they have to feel that they understand what it is, how it's being used, and they have the opportunity to say yes or no.
Thank you very much. Thank you.
Thank you, Madam Chair. The point that I wrote down that I think would be interesting would be the AI sandbox. And just to learn more about what some of the other states have done, so Connecticut and Texas, Utah, I think. And earlier when I asked David the question about durability, and I wrote down his answers, there were the two parts. One was the principles-based approach, which I think was really good, sage advice. And then I noticed the other part he answered was that the ability to amend, and he pointed out Connecticut amending one of their laws 3 times.
Yeah.
And then I later recalled that Connecticut is one of the states that has an AI sandbox. I don't know if that's a coincidence or if that sandbox allows them to iterate. But I know sort of boots on the ground for our internal governance and policy, our ability to iterate through our internal policy and guidelines has been really, really helpful because things evolve. So you try to start with the foundation and the basics, but the ability to iterate our guidelines before we formalize them in the policy has been really helpful. So I would be interested in, I think that could be a potential topic to follow up on, is the AI sandbox.
Thank you. I will tell you, as he talked about the amendments and amendments and amendments and coming back to the bill, I was over here sweating, thinking, oh yeah, that's really easy.
That's hard for us, yeah.
That's an easy one. We'll amend it 10 times. No, we get one shot to start with, sir, with the hope to amend, do we not?
That's right. That's right.
Thank you, Mr. Mattson.
Well, thank you. This has been a good day. It's a quick day when you're engaged, so I'll just say that. Lots of thoughts here. Thinking about it from running an AI governance and ethics, even in our own organization, I keep coming back to the concept of do we have a lot of already overlap on legislative work that has been done? Because I keep hearing about privacy and some of the things, and I wonder if we're overcomplicating it. In some cases, because we already have strong legal protections for healthcare information in some of these cases. And one of the things that we've done in our organization is if we ask the question, would we be having this conversation if we didn't have an AI in front of it within the concepts? And I just think that's maybe a concept that we might want to consider as we look forward in part of the technologies, because when we start. And what kind of biases my thought process in that is I've heard a lot of the presentations, and they're based upon LLMs and generative algorithms and your ChatGPTs and those interactions, and not thinking about the whole aspect of the different AI portions, machine learning, and different aspects today. And I think it goes back to that definitional piece that we talked about at the beginning, and understanding. And Frank, you made a good point, not today, but earlier in conversations about AI and how it's used as being that definition versus just thinking about AI. So lots of things coming through my mind, but going back to thinking about what would be beneficial, I think we're hearing a lot about clinical care in healthcare. There's still, I'd like to dive a little deeper on the support mechanisms in healthcare as well. I think there's a lot of opportunity for efficiencies that that organizations are using, and I just want that perception a bit, maybe from a revenue cycle and a payer perspective. And I know we'll probably get into some of those, but those are things I'm looking forward to having conversations about.
Thank you very much. And I know we do have payers in a few meetings ahead. Thank you.
Want to just thank the group for a great day, and I appreciate the thoughtfulness on what is really going to have the most impact for patients. David today used the word durability earlier. The word that came to my mind was agility. So how do we make sure that recommendations that come from this committee, yes, can hold space for the way that this technology evolves in the future, and so that it can remain agile for Wisconsin, but also that it is meaningful and makes that difference, so that we're not adding additional costs to the system without really seeing that impact on consumer protections. That's one for me. The second, kind of echoing back to what Representative Nealon was saying about the human interaction, I would love to be able to provide just some more transparency about that, especially in the payer space, how humans are still in the loop with the use of AI, and also hope to clarify some misconceptions as well.
Thank you. Ms. Gold.
I echo everyone's sentiments that it was a great day, learned a lot, and probably have more questions rather than less. But one of the things that I think would be really useful, it really struck me to hear a repeating theme of people having concerns about their providers utilizing AI in their healthcare. That was interesting to me because I've never thought about thinking about which tools my provider's using. So hearing from a provider to say, how does something become standard of care? And whether it's a new technology, whether it's a new lab test, whether it's I did just learn yesterday, providers rarely consult textbooks anymore. But whether it's a new resource, I think that would be something that would be interesting to hear.
Thank you very much. I was just saying, I still do consult textbooks sometimes. That's probably not good. New textbooks. Mr. Hoffert.
Thank you. The two things that really stand out to me, number one, we didn't have a lot of discussion today about the safety element. When we did, we kind of focused on the sandboxes. But I'm interested in taking that safety element kind of one step further, I think. Several of the patient advocates brought up testing of AI and retesting of AI, kind of continuous testing. And I'm really interested in, once the developer's out of the picture, once the vendor's out of the picture, once you have healthcare organizations using this, how do they have the resources to continue to make sure the AI is working as expected? We talked about how AI will work differently different times. How can they keep track of that performance and make sure it's continuing to behave as expected and not changing over time? So I think there's kind of an unexplored area there. The other area that came up 4 or 5 different times is the privacy area. And one thing I'll hone in on that I heard David Strauss say about privacy, kind of to your point, Mr. Mattson, about, we already have a framework for privacy in healthcare. It's called HIPAA. But he pointed out that HIPAA will cover the use of AI by a healthcare provider. It's not going to cover, your wearable, which is not a healthcare provider. It's not going to cover if a patient requests their records from you and then uploads it to a large language model. So where are the gaps in that privacy regulation that already exists that maybe AI is kind of showing us the gaps, revealing them to us, and then what can we do about filling those gaps?
Thank you very much.
I won't say anything that everyone else hasn't already said. I love the idea of disclosure versus consent. I think that's a really piques my interest as far as how you lay it out there. I just challenge us to identify the outcomes. I keep going back to that. We're not going to regulate the tech. That's a losing battle, in my opinion. It's identifying the outcomes that we're after and putting legislation forward that brings a very practical approach. I, too, think about the same thing. When the technology vendor is implemented and they're gone, we as provider systems have to maintain it going forward. And if we put a lot of regulation in place to fall on those limited resources, I think we're going to miss the boat on what we're going to try and do. We're going to ultimately overcomplicate which is a very complicated matter, but it doesn't have to be in the form of legislation, in my opinion. At the end of the day, I don't think patients and consumers want more AI. They want higher quality healthcare. They want more access. It's our job to figure out how to weave that in seamlessly behind cloaks of darkness, if you will, so that they don't have to worry about it, and we don't have to worry about educating the masses. We build the trust, we deliver high quality healthcare and the access that they deserve and want. Thank you.
Thank you very much. Mr. Fung?
Well, thank you again for the opportunity to be here. A lot of the topics today kind of resonate with me, and I've been working on a white paper, and I just kind of read a few things here about that white paper that I've been working on because it kind of resonates with me on the topics that we're talking about. The first one, I will try to be brief, right? But what we did here is because I'm responsible for agentic AI in my company, which is a healthcare company, and now we're part of this bigger, very conservative, in a good way, company for healthcare and data protection and patient protection. What are kind of the manifesto or the things that means to be a governed infrastructure for doing AI? So I'm taking this from a lot of the thoughts that me and a couple of members of my team have been thinking about this. The first one is interesting, the word that I've been using here, durability and recovery. And durability is not the same way we're using it right now because we're saying that whatever decisions we want to make here, they're going to be durable. But thinking is what AI does has to be, those execution has to be an object that could be persistent so we can go back to it. So that's what we call about durability and recovery. Also, when we are in the middle, especially a patient is there, and this AI process, because it's a software process, gets interrupted, we should be able to recover it, to go and see what happened. But again, the overall topic here is track. We need to be responsible and be able to track the actions that AI is doing. Go back and always audit and see what AI did, because that's is what are going to give us that peace of mind to be able to, again, to be able to monitor what's happening with AI, right? The other thing that we're talking about, these models being sometimes non-deterministic and not doing the same thing, the way that we express it is but let me say something else before I say that, is that they are very powerful too. So how do you harvest the power of AI at the same time that you kind of reduce that, or put those guardrails so it doesn't go crazy and do things that you don't want it to do? So we call that bounded non-deterministic. And it's probably a little bit of a technical term, but how do you make them do workflows very well defined? This is what you need to do, right? And when you're going to get out of that, ask me as a human, which also ties us with the human supervision and human oversight, right? A few things here. There is more there. We put safety by default, which is all that we've been talking about, PHI and all that. But I think, again, coming back to your comment, I think these are more principles that things that are probably enforceable. But I think, again, those are things that are more general thinking that have been kind of socializing in my company, that when we think about AI, we should be thinking this way.
Thank you very much. Dr. Justin?
I got to follow that one? All right. Good statement. Some of the themes that I've seen today with this fire hose of information has been trust in AI, and maybe we need a big PR campaign. I don't know who's going to fund that one. And then the other one is the fear of over-regulation and stifling innovation, which I've had some experience with. And so when I take difficult concepts and try to translate them to my medical students, I use mnemonics or something to remember. So, I think trust AI is a good mnemonic. So as we look at, voting on legislation, we should regulate things that really need to be regulated, things that can cause lots of harm. If they can't cause lots of harm, maybe we don't need to regulate them as much. So there should be a harm factor, and this plays on my anesthesiology background. Sometimes we use meds that are kind of safe, or a new monitor or something. You don't have to do as much background information and resiliency on it. But my acronym for the stuff that we kind of talked about in themes today is Trust AI. So T is transparency, R is reliability or resilience, U is understanding the evidence. Is it evidence-based? Is there something that we can hang our hat on that this is a reliable standard of care? Safety, we talked about the sandbox. Do we have to have a sandbox evaluation of a new AI system, stress it so we know what happens when it breaks and how much harm it can take? Accountability, who's accountable? For some of the lawyers and other big business people in here, who's going to be on the hook if something goes wrong? And then improvement or resiliency of the life cycle. So once it's out there, can it keep learning and not drift and not become biased? So Trust AI is how I'm trying to assimilate all of this information and hang my hat. But I think we might want to think about having some sort of filter or analyzer for an AI technology so we don't overregulate it, and we can come up with a little checklist that certain things make sense, and then we can be confident, because this all has to do with trust. If we don't get it right and we lose trust, that can we could have another AI winter, if anyone knows what that means. But
can you just list off each of those again here? We have Ledge Counsel, who doesn't write as fast. She's also looking for suggestions on
I'm happy to give it to Emily in a nice
dictation.
PDF document.
We'll email you, don't worry.
Please. Yeah.
I only missed the second, or the R and the second T, so I think I
R and the second T.
Transparency, reliability, understand the evidence, safety, team, human agent oversight, accountability,
Hey.
improvement.
Slow down a minute here. She's writing, not...
Really good to acronyms, and I can see that. Launch, he was telling me, I'm really good at that.
You're going to contact him, right?
Yeah.
Okay, between the two of you, did you get it all?
I think
These gals are going to need suggestions on transcription programs versus their pen and paper, so if anybody has a good one. She's gone through half a notebook already today, I see. Thank you.
Awesome. Thank you for a great day. And I'm just going to lean into one of the words that was just mentioned I think it was a theme of the overall concerns with AI, and I think it's who is accountable to AI. And I think we need to make sure we're keeping a lens of this is a tool. And at the end of the day, who's using the tool needs to be accountable to the tool. And I think that maybe helps build that trust that we're talking about. Because if the thought is that AI is going to be making healthcare decisions and no one is accountable to the decision that AI just made, that's going to be a big gap. So we need to make sure that accountability is weaved throughout this. And then in my role as administrator of Gamber Johnson's medical plan, I'm really interested in the next stages of some of these conversations when it comes to medical plan administration and how AI can affect that. As the administration of a medical plan and the costs associated with that is a continual battle, I think, for a lot of individuals, and where AI can supplement that or potentially harm that is something that I'm very interested in diving into the next stage of the process. I recently looked at a graph, and I think it's pretty telling if we take a look at our medical ecosystem, that if you take a look at the growth of providers over the last 20 years, it's a gradual growth in providers as you would expect, but if you take a look at the growth in administrators within medical plans, it is an exponential chart. And a lot of the costs that we have weaved in within the healthcare ecosystem is born out of the necessity to administrate a very complex system, and where AI can help that I think is going to be very interesting. I spend a lot of time helping our team members navigate billing issues, probably once a week, if not, maybe not once a week, but once a month. And the continual errors that we see within that process is something I think would be interesting to review within this committee, and how AI can supplement that to make that process better, and ultimately control one of the biggest problems I think we all face with healthcare, which is the cost.
Thank you. Sanderson.
Well, first of all, thank you all. This has been fascinating. This is my first committee to be on, so I appreciate being here so much. And I guess looking at everything, I echo everything everybody has said, and it's your thoughts are what my thoughts are. And if I feel like there's an AI bot in everyone's mind here, because I'm like, oh yeah, that's what I think based on everything that's said. But needs moving forward, I think an ethical discussion about using AI in healthcare and all the components that come along with that decision making, and if there's, and this may just be a gap for me, legal precedents, if there is any that have been set forward that would guide any legislation surrounding it, if that exists in our state, if there has been anything around that. So I think coming back to evidence-based things and making sure that vendors have are valid and reliable as far as like the whole sandbox thing, and then where does that go from there after it's been delivered to the healthcare system from the vendor? What does that mean for the healthcare system moving forward? And is there support from the vendor of that LLM, or does the system own the LLM? And then back to the patient advocacy group, I think one thing, being human, being a nurse, is that I think there is a big concern about what's free, what's fun, fast, and easy for the vulnerable population to get their hands on is open AI. But what that gives them, as opposed to a LLM that's developed under evidence-based practices, is the potential is very different, but the ability of the consumer, the vulnerable population, will say the mental health, the people that are in mental health crisis, as opposed to a physician or somebody like that, to be able to discern between the two. They may not have that ability, and I'm not trying to discredit them, but I think that's where the health system is there to help the people or their patients or the clients they serve. And maybe that's where education comes in, to be able to guide the patients into what is safe, what's not fun, fast, and easy. So those are my thoughts. And I guess I just caution people, like, AI is kind of sexy. You know, everybody uses it and it's great. And I remember when my kids got, the school sent home Chromebooks with all of them. And it was great. And it was going to be great. And it was going to help their learning and all of that. And being an educator now, I see that students have lost the ability to critically think because of that. Yeah. So I'm a little fearful in the medical profession that is that going to take away our ability? Not today, not tomorrow, but 10 years down the line, are they going to be able to be like, no, that's not right, and discern between somebody said, oh, that's the encyclopedia. Are we going to lose the encyclopedia?
Thank you. We still have one more after you, ma'am. We have Julie I'm really bad with names. Paola?
Good afternoon. This has been really interesting and very thought-provoking. I thought the patient advocates brought a really good point about how we need to look out for them when we make decisions. What was kind of interesting is that the executive director of NAMI really didn't have any recommendations on what we should do in terms of like mental health use of AI. So I think it would be very informative to learn about what other states have done, because the other patient advocates had very specific recommendations. And I think looking at mental health to protect patients is very important. And then ultimately, right, any kind of legislation, there's going to be like, who is ultimately responsible when we use all of these tools to help our patients. So thank you for letting me listen in and participate.
Thank you very much for being here with us today. So Ledge Council here does an amazing job, and they got our speakers today. They have a few lined up for the following weeks. But as we talked about each of the things that kind of stuck out to each of us, if there is anybody that you think might be a great suggestion to come speak, for instance, on sandboxes, I mean, if you got a good sandbox guy, hey, let these gals know, or any other particular area. Otherwise, they will do their research and find people to speak on most of these topics or all of these topics that we talked about here today. But there's nothing wrong with being friends and sharing any info and on people that might be make their jobs a little bit easier in searching them out. So if anybody has any info, please reply to them directly, not as a reply all, if I'm assuming correct. Reply to them directly. Our upcoming meetings are going to be September 9th and 10th, and both of those days are going to start at 9 o'clock. And so we look forward to seeing you then. If you need any of us, please reach out. You know how to find us via email, via phone, however that might be. Any other things we need to touch on, Representative Nealon?
That sounds great.
Okay. And Senator Kiewski, anything else for you? And your counterpart's gone there? Okay, I call it as a. Thank you very much, everybody, for your time and your dedication here.
You have been watching a production of Wisconsin Eye, your unfiltered window into legislative deliberations and public policy programming, where our mission is to provide Wisconsinites an opportunity to access the legislative process and connect with conversations that inform our citizenry. Please consider supporting our mission, and thank you for watching. Wisconsin Eye, policy made public.